Good morning and welcome to today's hearings in the Health and Human Services and Elderly Affairs Committee. This is going to start looking like more of a typical day in the State House back when we were running from committee to committee. So we'll have committee members coming and going as necessary, introducing bills, testifying elsewhere, and coming back. Fortunately, we now have the YouTube recording, so nobody will have to miss the testimony. So this is a huge benefit to what we're doing now today. And with that, I will open the hearing on House Bill 1706 FN, and I will recognize Representative Julius Sodi to speak first. Oh, yes, sorry. We're going to do the pledge first. I forgot. Sorry. Thank you, Lisa. Representative. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, Representative Mazur and Representative Sodi. Thank you.
Good morning, honorable committee members. My name is Julius Sodi, representing the Rockingham 35, the towns of Londonderry, and both pronunciations of Windham and Wyndham. That's an inside joke over there. My testimony here is going to be for the informed consent bill, which I co-sponsored, but my testimony is also relevant to the following bill, so it'll be covering both topics. Also want to make a point that this is a nonpartisan bill, and I want to give a overview of the topic here, of what circumcision is and where it came from. So in an historic overview, so I'm going to be brief with it because I'm sure there's going to be a lot of other people to flesh it out. So what is circumcision? Circumcision is the cutting off or amputation of the foreskin of the penis. Where did this come from? It's a religious ceremony performed by Jews and also observed by Muslims. It's a rite of passage in a few African tribes, and it's performed in the early teen years. And make no mistake, it is meant to be painful. A test of manhood. That's a test. Maybe I'd stay a kid. I don't think knife and penis should be uttered in the same sentence. Very cringy. So circumcision is not a thing in the rest of the world, and it wasn't a thing back then either, in the past. But in the later half of the 1800s, in the English-speaking world, it was sold as a medical practice, a panacea for anything that ails you. We got your cure right here. Hypersexuality? Check. Got you covered. Can't find time to bathe? Check. Got you covered there too. Alcohol problem? Yep, it'll do that too. Epilepsy? Yep. Snake oil and quackery all rolled into one. That's the beginning of the demonization of the foreskin. Well, which, by the way, does serve a purpose, but I'm sure I have a lot of heavy hitters behind me. They'll explain that part later. Fast forward to today, and the jig is up. It's on the way out. Infant circumcision is no longer routinely practiced in English-speaking nations like England gave it up, Canada, Australia, and it's also on the way out in a few states in the U.S. But today we still have these bitter clingers who are clinging to the practice. Circumcision is still a cure in search of a disease, an answer to a problem that does not exist. In other words, it is backward science. That's what you're going to be hearing from the other side. What other body part do we do this with? None. But let's play the game. Let's do teeth. Let's pull out your teeth. Prevent tooth decay. Tonsils, take that out too. Or breast buds for both girls and boys because it prevents breast cancer. And the cost benefits analysis, each of these would be far more meaningful health impact than circumcision. I want to move to some quotes from various public figures on this issue. First, I'm going to go with Ayaan Hirsi Ali. She's from Somalia. She was She had female genital mutilation performed on her, and he left Somalia, became a politician in Europe, and is a human rights activist. Here's the quote from her. "The foreskin is cut off the penis. That's a form of mutilation. You should leave the child as he is, as he came in out of the womb. He's finished, he's complete. You shouldn't take things off, especially if there's no medical reason." And we have George Carlin, the comedian, in his memoirs, Last Words. It is PG rated. Quote from Carlin. "I also survived circumcision, the barbaric practice designed to remind you that, as early as possible, that your genitalia is not your own. That's certainly a case for my body, my choice right there." Then I also have Richard Dawkins, the biologist, he has some Twitter posts, which I'll pass this around. And then the author, journalist, polemicist, Christopher Hitchens, that's also one I'd rather not read. Penn Jillette from his TV program Penn and Teller's BS. They did an episode on circumcision. And the quote there is, "Vast majority of the world knows there's no reason to circumcise. Someone should tell the doctors," the U.S. doctors, that is, "put down the knife, step away from the baby." Joe Rogan, okay, I'm not going to read his.
For the quotes, if you can circulate that, because you said that you want copies, and then if you just want to either speak to the content of the bill.
Oh, just one more quote. Well, actually, two more quotes and I'm done.
Okay, thank you.
Howard Stern, radio personality, never thought I'd be quoting him. He's of Jewish origin, and this is his view on it. "I am circumcised, and I tell you something. I despise it, I despise it, I despise it. I'm completely pissed off that I'm circumcised." And finally, from the psychiatrist and noted debunker of many science myths, Thomas Sass, also of Jewish origin. "I believe that the time has come to acknowledge that the practice of routine circumcision rests on the absurd premise that the only male in creation born in the condition that requires surgical correction is the human male." So in other words, it's not a birth defect. In fact, the condition where you are born without a foreskin, and there is such a condition, that is generally listed as a birth defect. So with that, I end my testimony. I don't think I'll answer any questions quite yet. I'll wait till the end if necessary, because I got a lot of heavy hitters who are on the cutting edge of this issue.
Thank you very much, Representative Sodi. Next, I'd like to call Representative Emily Phillips. And after that will be Representative Burrough.
I was just hoping, Madam Chair, that people who testify can be directed to turn very quickly to the substance of the bill that's in front of us, because the point about the actual surgery itself has been well made, and we have all taken the point very clearly to heart. So
Representative Weber, I believe that he was setting the table for that so that everybody else can speak to the content of the bill. And we will be going back to having 3 minutes. Then the committee may ask questions as well. So I will start with that. Representative Phillips, and your microphone's off, just so you know.
Thank you, members of the committee. Thank you, Madam Chair. My name is Emily Phillips. I represent Rockingham District 7, Fremont, New Hampshire. I am the prime sponsor of the Informed Consent Bill. How do you right a wrong? Sometimes you can't. So in my role as an elected official, I decided to put in meaningful legislation to ensure parents are educated to prevent future wrongs. I am a regret mom. You prepare for your firstborn child and you go through lots of imaginary scenarios and how you're going to be as a parent, how you're going to care for your newborn baby, what labor and delivery will look like. Nobody prepares you for the wound care involved when you choose circumcision for your son. That was a startling process for me. In my postpartum haze, I think most of you can agree that nobody's in their right mind after giving birth. We're sleep deprived. We're healing from our own surgical wounds or the birth process. And there was no way for me to absorb any kind of, informed consent had it been given to me about the choice of circumcision. My son was born healthy. At about 24 hours old, a nurse came into my room and said, from my recollection, it's time for his newborn screen. Do you want him circumcised? My husband at the time and I chose yes, we do. We didn't know. We didn't even think it was an option to not. That was just normal in our culture. They took him. He was returned to us. I don't remember signing anything. I'm sure I did. I'm sure I signed some sort of invasive procedure general consent form. Obviously, I delivered at Exeter Hospital. I'm sure they gave me some sort of sign off for this. He was returned to me. He was all right. A couple hours later, he became very distressed. He was crying, and 24 hours before, he was just a normal, healthy, sleepy baby. The nurse came in and said, we're worried about his respiratory rate. He was having very fast, rapid breathing. And we said, we don't know what's going on, but something's wrong. So they took him from our room, which at the time they had a baby-friendly policy, so the baby stays in the room with you. And they took him from us and they put him in the special care nursery for 5 days. And they could not figure out what was wrong with him. He was just upset. So they put an IV in his head, because as babies, it's hard to get an IV. So they put an IV and gave him sugar water, he was not breastfeeding. So back then, you're a new mom trying to learn how to breastfeed. So they do tummy to tummy when you try to breastfeed. And I'm assuming, looking back on it now, that his wound hurt him after the local anesthetic would have worn off, and he was distressed, and it was hard for him to breastfeed. So they taught me how to do what's called the football hold, which some of the moms will understand, but basically they lay behind you and their belly is up to the ceiling. So I wasn't making contact with his wound. And he was able to kind of breastfeed, and we eventually got out of there. He had jaundice, which may or may not be related to the procedure. But again, the wound care I was not prepared for. Constant attention and cleaning him and repairing what I chose to do to him lasted at least 2 years. I never had a healthy child when it comes to his genitals after that. And we were referred to a top pediatric urologist in Manchester sometime before he turned 1, because he had issues. I don't want to say specifically, but he had complications. And she said we could offer a repair procedure, like a new circumcision or something, or we could wait. And maybe by the time he was walking, or maybe when he reaches puberty, it would resolve. So obviously, after that trauma, we chose not to do anything and just wait, because why put him through more? 2 nights ago, in my research, I found out one of my son's conditions is listed as a diagnosis code for revisions and repairs in this state under the Medicaid billings. So I know now, he turns 11 next week, and I know now that we're not done. So I have to go back and find somebody to help us. I will spend the rest of my life in regret, and I hope he forgives me, and I have to have this conversation with him because he doesn't know what's going on. But I went on to have 2 more children. My last son, he's 2.5, he's intact, and no health issues, no special care, no trauma. I'm wrapping up, I promise. I asked the committee to be open to this discussion because infant circumcision is the only routine surgery performed on healthy infants that is not medically necessary. So that's why a special form is required. According to Dr. David Jones, who couldn't be here, of University of Vermont Medical Center, Medicaid and other third-party payers require specific consent forms for other elective procedures like tubal ligations and vasectomies, and that's why we need a special form. In closing, I introduced this bill for 2 mottos that I live by, and that's know better, do better, and courage is contagious. I am open to all amendments. I just want this conversation to happen. And I'd prefer not to take any questions because I feel like there's plenty of people and a lot of people to get through. I'm sure that someone can answer if the committee's okay with that.
Thank you very much.
Thank you so much.
Thank you. And with that, I'll call Representative Burrows.
Thank you committee members for having me testify. State Rep Anita Burrows, I represent Carroll 2, and I'm testifying in opposition to this bill. My assertion is that HB 1706 does not provide the complete story about this procedure and potential medical benefits. There is a directive in the bill for DHHS to provide medical care experts with an intact care guide with information to inform parents on the proper care of an intact penis. My question is, since when does DHHS provide medical experts in healthcare institutions with directives on what information to give patients? Are we doing this with heart surgery, tonsillitis, appendectomies? The healthcare provider must also furnish parents with a comprehensive consent form with a two-person signature required. Without it, the circumcision cannot be proceeded. Again, is such a consent form created by a government? Since when is a consent form created by a government agency to healthcare providers a requirement for any other procedure? The parents must be shown the restraining board, clamp, and plastic all used in the procedure. Do we require parents to be shown the scalpel, graspers, and needle drivers for an appendectomy? The bill states that circumcision is an unnecessary cosmetic procedure. However, major healthcare institutions, including the CDC, National Institute of Health, and American Pediatric Association, which asserts that the benefits outweigh the risks, state that there's a decreased risk of urinary tract infections, decreased risk of sexually transmitted diseases, and prevention of penile problems, including the inflammation of the foreskin. Although we did hear opposing testimony today from Howard Stern and George Carlin, which I appreciate. There are disciplinary procedures delineated if these procedures are not carried out by the physician or medical professional, including referral to a licensing board and potential monetary penalties. Is this not the purview of the medical institutions? Since when is this something that the legislature regulates? Now, it's been mentioned, Jews and Muslims have been performing this rite of circumcision for thousands of years, and many parents opt to have this procedure done in the hospital. But this bill would not allow this religious custom to be done in a medical office. And I ask, could this be interfering with our state constitution, Article 5? Where do parental rights stand in this bill? Should parents be the arbiters of whether or not to have their babies circumcised? Why do they need to jump through legislative hoops in order to have this procedure? In closing, to my knowledge, most of our 400 legislators do not have medical degrees. It's time for the State House to get out of the doctor's office and healthcare institutions and leave such issues such as informed consent and disciplinary procedures where they belong and stop interference with the doctor-patient relationship. Thank you.
Actually, I have a question for you, Representative Burrows. Could you point to me where it says that they are not allowed to be done in a medical provider's office?
I actually don't. There is a sentence. I don't have it in front of me. Can I look it up? And
if you can follow up, that'd be fantastic.
I will do that. Absolutely.
Thank you.
Thanks.
Are there any other questions? Okay. Thank you. Oh, you have one? No. Okay. Thank you very much.
I'll get that.
Next, I'll call Representative Paige Beauchamp. Sorry if I said your name wrong. If I said it wrong, please correct me.
Thank you for having me here today. And I'm Paige Beauchamp, very close, it's French. So I am Paige Beauchamp. I'm a registered nurse and a New Hampshire legislator in the House of Representatives. I'm here today as a nurse with nearly 15 years of experience in women's and maternal child health with significant experience in mental health specific to the reproductive years. I am the nurse that gets consent. I take the baby to the board where they will be strapped down, and I soothe the babies during the procedure. So I have firsthand knowledge of this process from the inside out, how it would impact clinicians and new parents with real-world application. Sorry, sometimes I need glasses, sometimes I don't. I'm getting to that age. From the beginning, 15 years ago, I noticed a significant gap in education. And I have some insight as to why. So while all of the, and the fact is that all of the professional organizations, such as the American Academy of Pediatrics and the American College of Obstetricians and Gynecologists, all agree that circumcision is medically unnecessary. It's a well-known and accepted standard from the OBs, the nurses. This is something we all know to be true, and this is how we educate our patients, and this is how we are instructed to educate educate them that this is not medically necessary, but it is their choice. And I strongly believe in parent choice. The problem is that there's a gap in the education. One of the reasons being that people do not have pediatricians until after they have the baby. So who's going to educate them? While the OBs or the midwives and the nurses are very, very good and are well intended, they're bogged down with so much, and they frankly don't have a good source of education. This is well accepted in society, and a lot of people don't do research before they come to the hospital. They don't even know really that circumcision is an option. So with that gap, I think this is a really important opportunity to supply the community with input on this health information. I feel strongly, I'm concerned when I do this. I don't think that people are getting the right information, that I feel comfortable they're making informed consent, because it simply isn't there. At the same time, I do agree with the representative who just came up. I feel very strongly that it's not our role as legislators to interfere with medical practice. I do think it's our job to make sure that information gets out there. And I don't have too much longer, so don't worry. I've been thinking about this deeply over the last few weeks, and I do have a recommendation. I would recommend that this bill be simplified to include a consent that is specific to circumcision. Right now, most of the consent forms are consent for general invasive procedure. They don't have anything specific to circumcision. My recommendation would be that we create a form that is that is specific to that. And on that form would be a box where people can check that they have received a brochure with education and that they understand it. Now, the other thing is that the state and the federal government already do regulate many of these. There are forms and education that are required, such as helping people know about shaken baby syndrome and sudden infant death syndrome. So there is required education and forms and processes. I would recommend that we talk with DHHS so that we can see if they would create a brochure that is congruent in language and sentiment for the brochures they already create. So it would be congruent with all the education people get in the postpartum period. That would be consistent across the state. Everybody gets that education, and then the consent form is processed the way all the forms already are. Thank you.
Thank you. Are there any questions? Representative Shapiro?
Thank you, Madam Chair, and thank you for taking the question. You're a nurse who does this, so you know much more about it than myself. But my question is, while you've described this essentially as an elective procedure, which I would totally agree with you about, is it not true that if one goes looking through the research, that one would find conflicting research about the medical benefits of circumcision? I'm not making an argument one way or the other. I'm just saying, wouldn't one find in the research that circumcision as a procedure has medical benefits, as well as a lot of research that says it doesn't, or it's more harmful than beneficial?
Sure. So again, the presiding professional organizations that dictate most of my practice agree that it is medically unnecessary. Now, in previous years, when it was very culturally accepted, organizations would say something to the effect, and this is what you might find, it's medically unnecessary. Benefits may outweigh the risks. Most organizations are moving away from that type of statement. A lot of the research, I've been researching it for 15 years. I'm a newborn care educator. A lot of the research that was done that indicates that it decreases things like STIs, HIV, and UTIs were often done in populations that don't have the same hygienic environments as us. So they had increased risk, or they were in environments where they were exposed to more of those things that we talked about. So again, it's generally accepted by the professionals that the best research out there very much indicates that this is not medically necessary.
Thank you. Follow up? Then Representative McLean after that, and then King.
Thank you, Madam Chair. I have a different question. So
I'll have Representative McLean, then Representative Seth King, and then Representative Shapiro again.
Thank you, Madam Chair, and thank you for taking my question. So, yeah, I mean, I do have concerns about how consent is often gained. In my personal experience, it's often been a rubber stamp, and so I have enormous sympathy for the testimony of Representative Phillips, who she's under a state of duress almost, and she's being asked to put things forward. So on the consent side, which is what this is focusing on, you talked about education. So this bill as written, it does create a special unique consent form for circumcision, but would it do anything to address the situation that Representative Phillips found herself in, where yes, I have a dedicated form, but it's being put in front of me again in the state of duress? So do you see anything in this bill that would address that concern, or no?
I recommend reworking the bill a bit to focus a little bit less on the consent, although I think it's very important that it's a specific circumcision consent. But I think that to even it out, we've got to have a specific brochure that is written that improves the education. Unfortunately, this whole concept of educating people before the postpartum time is a cultural problem. That is one of the major problems. It's one of the things that makes this the most dangerous country to have a baby in the industrialized world. So I could say the exact same thing. People come in and want to breastfeed, and they haven't looked up how to breastfeed. They come in wanting a natural birth, and they haven't educated themselves on how to manage pain. So I think the best that we can do when they're in that state is, at the very least, give them a brochure. And what we know is we repeat things over and over. So we mention something about a circ at the beginning and give a little education. We give the brochure. We give them time to look at it. Rather than somebody coming in, you just woke up, the doctor's coming in at 6 a.m., they're kind of throwing something in front of you. They need to know now because they're doing the circs now. So if we give it to them, I think, they can take it and say, okay, wait, let us look at this for a few more hours before we decide. And they can take that time of the day. They can take the time they need to really look at it and ask the nurse questions. I actually think this would be very well accepted and very helpful for doctors and nurses and midwives.
Thank you.
Representative King?
Thank you, Madam Chair, and thank you for coming here today and giving your testimony. I hope you get lots of questions, because I really like the fact that you've got both real-world experience as a nurse and also legislative experience.
And a parent
And a parent.
of two boys.
This is probably something I could look up on Google. I haven't done it yet, but I'm just really curious, because in the Bible, it's clear that the circumcision is supposed to be performed at 8 days after birth. And it sounds like a lot of circumcisions nowadays are being done the day of birth. Is that correct? And how did that happen? How did it go from clearly 8 days of that baby being able to heal itself from just being born, and the parents being, of right mind, to all of a sudden, like, birth circumcision?
Sure.
Thank you.
Thank you for that question. I'm still getting used to the decorum. I don't know the whole history from the Bible days to now in how circumcision has developed, but I do have a few answers to your question. One is, we can't have a whole debate on healthcare, right? But people are in the hospital. That's where they are. They're there. I will tell you, I know that some of the standards of practice are that boys are allowed to get the circumcision as long as they're 6 hours old. So that is pretty much the earliest they could get the circumcision. My guess, and again, this is a guess, is that we're removed from the
Sorry,
Bible.
if I could interrupt for just a moment.
Yeah.
We have a lot of people testifying.
sure.
I appreciate that you're
Yep.
providing more than you know, but if you can stick to what you know,
Yep.
I'd appreciate that. We have three more questions for you after
Yeah,
this.
I will say this. The people are in the hospital at that time, and if they leave, they're unlikely to come back. It's hard. It's more complicated.
Representative Shapiro and then Representative Weber.
Thank you, Madam Chair. So on page 2, line 8, it says one of the requirements of the process of informed consent would be that the parents have seen the circumcision devices to be used and the parents still wish to proceed with the circumcision of the child. So I have 2 questions for you about that.
Yeah.
Is that outside of the norm of informed consent for most procedures to actually view the tools of the procedure? That's the first question. And the second question is someone who obviously does this and is very attuned to the emotional state of the people you're dealing with. How would you feel about actually doing that?
Yeah, so when I read the bill, I had a similar reaction. My recommendation is, from the logistical point as well, that would be impossible for us to do in the hospital. We don't have time to be bringing that to every patient, sterilizing it again, doing the procedure. My recommendation would be that if people feel strongly to include that it would just be a picture on the brochure. I can't speak to how many other procedures do something like that, but I do think that there's a lack of understanding of what it is, and that could potentially inform people. What I will say is another reason I like the brochure is because to speak to the sensitivity and an emotional state, especially first-time parents, they are very, very they want to be a good parent and they're very sensitive. And when we go in with something controversial, such as to teach them about breastfeeding and formula, no matter how neutral you go in, they usually have a defense mechanism. And I think if we go too strong with this, I don't want to be the nurse that has to talk to them about this. So I want to be really careful because I do think it can be a very emotional state for them. And just like our representative, in that fog and with those emotional hormones, I think we should be very careful. But
sorry.
sorry, the
Representative Weber.
information needs to be said, but very carefully.
Thank you.
Representative Weber and then Representative Murphy.
Thank you very much, Madam Chair, and thank you for taking my question. Am I really getting the sense from your testimony that what might be more useful than some of the prescriptive stuff currently contained in the bill as written, that what we should be aiming at for all parents is earlier education and education significantly in advance of the birth process, so that it's one of those things that they have had a chance to consider, to prepare for, and to be able to make a decision that's not that, here I am, you've got to make a decision right now. Would that be, in your opinion, a more effective mechanism?
Short answer, yes. Real answer, I don't think that it's realistic.
Okay.
This is one extremely small piece of everything else that people don't get, right? They don't get if you don't take a class, you don't even know what the stages and phases of labor are. You don't know what Pitocin is. You don't know what increases your risk of cesarean. You don't know what breastfeeding is. You don't know, this is everything. So that would be about fixing the entire system. I have lots of ideas on that. But in the existing system, with the existing time that our clinicians have, I think this is the best option.
Okay, thank you.
Representative Murphy.
Thank you, Madam Chairman. Thank you for taking my question. Just a simple question. You mentioned medically unnecessary a couple times. I just want to make it clear. You're not equating that to medically contraindicated, are you?
No, it would be more neutral, meaning it's not necessary.
Follow up. So if you can look at a procedure, any elective procedure, as quote, medically unnecessary, which I would argue the majority of procedures are elective procedures, would you then, based on what you were trying to, how to amend this bill, would you then suggest that every procedure that is done in an operating room, the surgeon or the people taking care of them show the patient all the equipment and all of the other aspects of a surgery that they may encounter during a procedure?
We're
I-
getting a little far
Yeah,
off from this
I'm not
bill.
an
We have
expert
this many
in the
more
other
people.
areas. I'm not an expert in what should happen. I know parents, and I've been educating for 10 years. I teach childbirth ed classes. I teach perinatal mental health. I teach newborn care. I know what is good for parents in that time period.
Thank you.
Thank. Yes, you can make a suggestion.
I would suggest that perhaps we consider right now that this might be a bill that might go to subcommittee, because it sounds to me like there are any number of real specifics with the bill that might well be better off discussed in a forum with more time so that people can be heard now. Is that helpful?
I recognize that. However, we have a lot of members from the public who are here to speak on this topic. And it's great to have the input from one legislator, but we need to look at how this committee as a whole will be dealing with this bill as we move forward. But obviously, all considerations remain on the table. But thank you very much, Representative. Thank you. And we've already recognized you for 2 questions, Representative Shapiro. Sorry, Representative Nagel, you have a question?
Thank you, Madam Chairman, and thanks for taking my question. This question may be for a lot of different people. I really, really, really appreciate everything you said about informed consent. I think it's a huge problem, but it's not unique to this procedure. According to the National Health Statistics Report from the CDC, in 2010, 48.3 million procedures were performed in the United States. And this is where my concern comes in. Should we be writing a separate statute for the tens and thousands of procedures that are done every year that we don't provide informed consent for? Or is there a better you've already outlined a non-legislative way of doing this. Is there a better way in process now to accomplish that goal without creating statute?
I can't speak to all of the other procedures. I can speak to this. I can say we have specifics on things that are extremely important for the newborn, such as the risks and benefits of breastfeeding and formula, sudden infant death syndrome, shaken baby syndrome. And this is something, the one thing that's different between this and most other elective procedures is this is a newborn infant who doesn't have the opportunity to give consent for their body autonomy. And I do think that is a good reason to consider extra education on this area.
Thank you very much. Let's see.
Are we done?
Yes, we're done.
Thank
Thank
you
you.
very much for hearing me. And of course, I'm available for any other questions at any time.
Thank you. Next, I'll call Lauren Sardi. And I'll make sure that my 3-minute timer is a little bit louder. I want to be respectful to every single person in this room who has signed up to speak.
Hi, can you hear me? Hi. Okay. I'm gonna try to shorten this and really kind of speak to, I think, some of the gaps and inconsistencies that have already been brought up. So hopefully that's what you're looking for.
Could you say your name?
Yes. My
and
name is
then
Lauren
I'll start the
Sardi.
timer. Yes. And also speak a little closer to the microphone so we can make sure that we have you. Thank you.
My name is Lauren Sardi. I'm a professor of sociology and women's and gender studies at Quinnipiac University in Hamden, Connecticut. I'm speaking to you first as a scholar and a researcher. I've spent the last 17 years of my academic career, beginning in graduate school at the University of Connecticut, studying the ethics and human rights implications of neonatal penile circumcision and the ways in which this procedure has been maintained and upheld in our society. This is done even though all national and international health and medical organizations note that the procedure, above all else, is cosmetic, which we have already established. And secondly, I'm speaking to you all as a parent. I support both bills that are in front of the legislator this morning, and I'd like to sort of briefly explain why. Obviously, as we've covered before, penile circumcision has commonly been described as a routine procedure performed shortly after birth, at least in the United States. In my previous research on medical providers and parents, I asked what the most common reasons were for parents to approve a circumcision on their child. I'm going to list some of these reasons below briefly and also kind of talk about sort of like why these are a little bit off, and then explain sort of why this is all kind of a moot point anyways, because we're talking about the concept of informed consent. This is actually a misnomer as it applies to neonatal circumcision, but I'll get into that in a little bit. We talk about things like basic hygiene. It is much less invasive on a person to just simply be able to bathe themselves, use mild soap when appropriate. We talk about, this common phrase that gets tossed around, that circumcision prevents UTIs. What we actually find is that you would have to perform 100 circumcisions to prevent one case of a UTI. And certainly if a child with a vulva has a UTI, what do? We prescribe antibiotics. We do not circumcise them. Again, we talk about these lowered risks of HPV and STI, other types of STI preventions. Even if you're circumcised, you still need to use barrier protection. That is actually the only true way to actually fully, attempt to prevent these kinds of infections and diseases as they later may occur. From a public health perspective, these are easy to obtain, easy to use, cost effective, and does not result in the permanent removal of a part of a person's body. We also get into other things like aesthetic preferences, matching the father, things like that, which are all culturally cultural considerations. Parents actually should not allow their own preferences of genital appearance to be literally circumscribed on their infant children. As a society, I think we would feel disgust if we heard parents discussing aesthetic preferences of infants born with vulvas. And so I will admit it's a bit perplexing that we do not have the same response for those parents who have children born with penises. So there's a lot of other reasons here that I could list, but what I really want to talk about is that, people also give this argument of, well, what if they just have to get it done later on in life? And what I would say is that based on the best estimates that we have, only 1 out of roughly 16,000 adults with a penis need to be circumcised as an adult. And I say need, like there's medical necessity. Simply put, neonatal circumcision is not ever an appropriate prophylactic procedure to be done on neonates or frankly anyone who is too young to give direct consent. In fact, circumcision is literally the only procedure in the world in which parents are able to provide proxy consent to an elective procedure, no less one that permanently alters one's body forever. So truly informed consent, as described in medical ethics, the kind of informed consent we all get as adults for both medically necessary and cosmetic procedures, at least in theory, is not able to be carried out in the case of neonatal circumcision, right? So the issue here is that what we actually have is that parents can provide proxy consent, right? So in my research in hospital settings on circumcision, in all cases, verbal and written proxy consent, which again is incorrectly referred to as informed consent, was wholly inadequate and did not fully include a comprehensive list of all the short and long-term side effects and risks of the procedure. In fact, I was truly taken aback by the number of parents I talked to who told me that they not only wish they had more information about circumcision before they agreed to it, but that it was brought up earlier on in a person's pregnancy so that they would have had adequate time to consider the complexity and permanence of the decision on behalf of their neonate, which frankly, we shouldn't have that choice to begin with. It is not our choice. We are not giving informed consent. We are giving proxy consent, which we cannot give technically in a cosmetic procedure. So when we talk about sort of like, well, what about this situation? What about that situation? Those are wholly different. They're totally different procedures. One is where you're an adult making a choice for yourself, and the other is where you're an adult making a choice on behalf of a child that's not medically necessary.
And if you could wrap up, I'm sure we'll have some more questions for you.
Okay. I will just say in my own experience with childbirth in 2012, although my healthcare providers knew that I would be having a boy, I was not given any information or even asked about it until 5 minutes after my son was already born. I was literally being put back together after what felt like the most physically grueling experience of my life. While I already knew based on my previous academic research what my decision would be, I couldn't believe there was no discussion at all about it beforehand the entire time that I was pregnant, and that I received no prior consent forms to view. Upon viewing information about circumcision a few hours later, I was still shocked by the blatant misinformation and lack of any detail on what the procedure actually entailed or would have been in store for my son.
Thank you very much for that testimony. Representative Merchant?
Thank you, Madam Chair. And also wanted to voice my lateness and tardiness to this committee. This morning, unfortunately, had a situation at home that I had to take care of, so I was late to the committee. So I want to let you know why I was late. If I may, I understand the issue of what you're saying about informed consent and parents' rights, but where do we draw the line? Because we always talk about parents having the rights on behalf of their children. Is this not a situation here where the parents, by de facto, still have the legal right to make decisions for the children? Because that's one of the things we've been talking about is the rights of parents. And the state should not be infringing upon those rights. So can you speak to that, please?
Yeah, sure. I guess I would just counter argue that question, which is what other procedure do parents have a right to take a part of their own child's body off of them? I don't know.
An appendectomy?
That would be done for a medical reason.
Thanks.
Follow? Okay. Representative, sorry. I have a question for you. I know that some other practices post-childbirth offering formula and other choices have sort of had a paradigm shift where instead of saying, would you like formula, there is a wait for the parent to request it. Do you think that a shift in policy to meeting a parent's request for circumcision as opposed to a default assumption that all children will want to be circumcised would have a more appropriate conversation on those desires, given that there's no medical reason that it needs to be done immediately?
Yeah, I certainly think that the paradigm shift has to occur and that the assumption should not be, that the default should not be at all that this is what parents want. And I think it honestly puts medical providers in a very tough situation where they're forced to kind of, I think many medical providers aren't really interested in this, but parents are asking for it. And they're also asking for information. And it's such a touchy subject that there's just not a lot of communication going on. But I would also argue that, again, something like formula is, and I'm not suggesting, it's just not an equal comparison at all in any way, shape, or form. We talk about vaccines, not an equal comparison. Ear piercing, not an equal comparison. And so I truly mean when we talk about this is the only procedure in which someone's body part that is important is permanently removed. It stands alone. It really does. It's tough to compare.
Thank you. Representative Cushman?
Thank you, Madam Chair, and thank you for taking my question. You had said that there were about 1 in 16,000 medically necessary circumcisions in adults. Do you know what the rates are for dealing with complications of circumcision?
The best estimates that we probably have, and I've seen these actually on some consent forms, are anywhere between 2 and 5%, potentially more, and which I didn't actually say out loud, but what I believe is actually much more commonly the case is that we get revisions done because a circumcision is done, and because we're removing very small parts on a very small body. As a person is growing into their bodies, things change. So revisions might be necessary. But what also equally is going on is that when we talk about circumcisions that are performed after the neonatal period, we're talking about oftentimes issues that occur from lack of knowledge and lack of information on how an intact penis actually works, which is that the foreskin at birth is fused to the head of the penis. So when I hear things like, oh, somebody told me that I need to retract to clean under it, no, you don't. That's actually causing harm. It's causing damage. It would be the physiological equivalent, if you will, of trying to clean under your nail into the nail bed. You cannot do that because your nails are fused to your fingers, right? So that is what causes significant damage, and that is what leads to circumcisions in the post-neonatal period.
Follow up?
Thank you. I was actually asking, and you did touch on it at the beginning, about revision rates for circumcision and complications from that. Do you know what some of those potential complications are for following circumcision?
There is significant research done on what those complications are in the short term. Usually what we see are things like adhesions, where the foreskin attempts to heal itself and sort of connect back onto the head of the penis. There are also other kinds of issues dealing with too much skin that's removed, so skin that's actually sliced off or removed from the head of the penis too. Things that have to do with uneven or jagged kinds of foreskin cuts, things like that. You can also see things like foreskin bridges that could occur. They're incredibly graphic. I think you'd probably want to search them.
Thank you. And seeing no other questions, thank you very much for bringing. Oh, sorry, Representative Murphy. My apologies.
No, thank you very much, Madam Chair, and thank you for taking my question. Are you aware of how circumcision is listed in the CPT codes for most medical insurers?
I think it depends on the insurance.
Are you aware that this listed as a CPT code under cosmetic surgery or as an elective procedure?
What I have seen in the past is that it's sort of listed under its own category of just circumcision, not as even underneath either one of those. But again, those codes change, so I'm not quite sure.
Just to be clear, so you're not aware of it being listed as a cosmetic procedure for insurance purposes?
No, but it should be.
Thank you.
Thank you very much. And perhaps there's somebody who knows coding who can get into those answers. Thank you very much for your testimony. And Representative Santonastaso, I apologize that I did not see you listed as a representative when I was handling the card. So it was not an intentional oversight since we recognize representatives first.
Thank you. Good morning, Health, Human Services, and Elderly Affairs Committee. I'm Representative Santonastaso, representing the towns of Rindge, Jaffrey, and Dublin. I'm in support of House Bill 1706. This bill provides notice to parents prior to circumcision of an infant, as you all know by now. In the bill, Roman numeral 10D says, your son may want an intact penis, and a decision to have a circumcision denies him his bodily integrity and autonomy, which he may resent when he matures. My relationship with my mother suffers today, and this is in part because I resent the circumcision that I received as an infant. I do believe she was just going through the motions. I'm not from a religious family. There's no reason that she would have had the circumcision except that that's just what you do. If she was informed, she might have made a better decision, and it could be possible that our relationship wouldn't have this contention point that it has today. An adult can always undergo a circumcision later if he so desires. For 10C, circumcision is associated with between 20 and 47 known complications, including heavy bleeding, infection, disfigurement, scarring, mental cirrhosis, skin bridges, loss of sexual function, poor cosmetic appearance, follow-up correction surgery, and in rare cases, death. The long-term impact of newborn circumcision on the physical, sexual, emotional, and physiological, psychological health, self-esteem, and well-being of boys and adult men has never been followed and is only being explored and publicized in response to increasing complaints from circumcision sufferers and those pursuing foreskin restoration. My own circumcision was botched, and mine, like most other people, I believe, wasn't counted in the stats because it wasn't until I was 17 years old, actually at a physical, where someone had the courage to mention to me that there's surgery available to correct this sort of thing. Before that, nobody would even dare talk about such a thing, even though my parents must have been aware of it because it's obvious. All circumcisions where the person doesn't desire it is a botched circumcision. One of the outcomes of a botched circumcision is death. So it's important for parents to be aware that this procedure may actually kill their baby. It may be directly from hemorrhaging or indirectly, like in the very known case of Bruce Ramir, who at 8 months old had a botched circumcision so bad that it led to the result of him losing his penis. The parents, under guidance of a psychologist, attempted to raise Bruce as a girl, and this ultimately failed as Bruce took his own life at the age of 38. Circumcision for convenience and hygienic reasons is not necessary. Even if it was true that circumcision is more hygienic, it would be similar to believing that if we remove a baby's arms, it would be easier to put his shirt on and off, because it's really hard to put their shirt on. They like moving their arms a lot. Removing body parts to make it easier to keep a baby clean is inappropriate. All three of my boys are uncircumcised, and we have a 3-year-old and 2 7-month-old twin babies. And there's 0 additional tasks that we perform to take care of them. So in the United States, on the very first day of a baby boy's life, in these moments when a newborn should be experiencing the gentle care and bonding with his mother, he is instead subjected to an act that can only be described as a brutal assault. This procedure introduces the innocent newborn to experiences of pain and trauma. It makes it so that at one time in that person's life, the only thing he understood was brutality. It's a perfectly crafted evil, a practice that embodies the very essence of injustice and violence against the most innocent. Thank you. And I will take questions if necessary.
Thank you very much. Are there any questions from the committee? Representative Cushman?
Thank you, Madam Chair. Do you know what the risk of death is following circumcision, the statistical risk?
Well, we can't even understand the psychological damage. So for people taking their own life and things like this, we don't know. But I know that death from hemorrhaging and stuff like this is one of the more rare than the other conditions.
Representative Merchant?
Thank you, Madam Chair, and thank you for taking the question. Do you support parents' rights?
Sorry, do I support what?
Do you support parental rights?
Of course. But this is making a decision on behalf of someone else that is irreversible and medically unnecessary.
Thank you, Representative.
Thank you.
Next, I'll call Dr. David Conway. And 3 minutes, I'll make sure my timer is close to the microphone so you can wrap up at that point.
Madam Chairman, members of the committee, thank you for letting me testify today. My name is Dr. David Conway. I can. Is that better? Okay. I'm a retired board-certified OBGYN. I practiced for about 33 years, about 16 years here in Concord at the residency over at Concord Hospital, where I, in fact, trained residents how to do circumcisions. I've done probably 500 to 1,000 circumcisions. I never really kept track of those numbers. I kept track of the number of kids I delivered, which is about 2,500. So half of those were boys and half girls, pretty much. I'm here to testify in opposition to this bill. It's an incredible intrusion in the practice of medicine, dictating the specific information on the informed consent, requiring submission of that form for approval, requiring parents or patients to inspect the surgical instruments, and that parents be shown a restraining board. I can think of no other surgical procedure that requires that degree of legislative intrusion, which is no news since you've heard testimony to that fact already. I'm not going to read the whole statement I provided to you. I certainly agree that it is not a medically indicated procedure. It's an elective procedure. There are a variety of elective procedures that don't get this kind of scrutiny. One that I'm particularly familiar with is tubal ligation. During prenatal care, one of my jobs as the provider was to talk about circumcision and also about tubal ligation, but not so much tubal ligation as contraception after delivery. Whether those are recommendations from the American College of OBGYN, and that was certainly part of my practice and part of my job as training residents. It's a painful procedure. When I was a resident in the late 1980s, local anesthesia was not used, and kids scream a whole bunch, and I thought it was barbaric. And I don't know if you're familiar with the type of instruments that are used to do circumcisions. There's a Mogan clamp that is kind of like a pincer that kind of clamps across the foreskin. There's a Gomco clamp. There's a Plastabel. And there are advantages to both. I used in residency, I used the Mogan because it was quick and it got it over with as quickly as possible for the infant because it was very clear to me that it hurt. I don't have anything really more to add to my statement. I will certainly take questions.
Representative Cushman and then Representative Shapiro.
Thank you, Madam Chair, and thank you for being here to testify. So do you understand that the practice of medicine and licensure to practice medicine was created by the legislature, and therefore the legislature creates the rules that one agrees to operate under for that license?
I am well aware of that. I was a member of the Medical Review Subcommittee for 6 years of the Board of Medicine. I was a member of the Board of Medicine itself for 7 years and eventually president of the board. So I'm well aware of that.
Thank you. Follow up?
Yes, follow up.
Understanding that, and I just want to kind of contrast that or show that there's precedent for us having a form, and would you agree that we have protections in place for the human rights of subjects in medical research, and we have increased consent requirements for when that's going to be done on children? Are you aware that we have consent forms for vaginal births after cesarean section, and that's in our statute also, so that this isn't creating a new idea or a new method of ensuring protection for patients?
I'm not aware of those specific requirements. Informed consent is central to doing surgical procedures or any kind of procedure. And it's something that's very clearly taught during medical school and very clearly taught during residency.
Thank you.
Representative Shapiro and then Representative Weber.
Thank you, Madam Chair. Thank you for taking this question. We've heard terms like cosmetic, elective, unnecessary. We've also heard from at least one person about some of the health benefits of circumcision. But we've heard these terms as if they were one and not the other. And isn't it true that there's some overlap between elective surgery and medically necessary surgery? For example, when I had terrible sciatica problem, I was given the option of a medically necessary back surgery. It was still elective. I mean, I chose not to do it because, I made the decision based on my research. So isn't there some overlap between what's medically, I don't know, maybe there's another term besides medically necessary, but medically legitimate and elective?
Hard question to answer, because I've sat in your shoes with exactly that same decision. And the outcomes after, this is not going to be news to you, but the outcomes after back surgery don't typically last for a very long time. And there's certainly complications involved. So I don't have a great answer for you.
Representative Weber and then Representative Polozov.
Thank you, Madam Chair, and my apologies. I had to step out for another, trying to be in two places at the same time. So you may not be the appropriate person to ask this question, and if it's not your field, just feel free not to answer. I was just wondering, I know that certain other states have regulations in this space. Do you know if there are other states that have adopted this particular bill in its complete form as it has been presented to us? Because from what I heard from many people prior to this meeting, it sounds like this is a form that and a movement that is national in scope. So I wondered if it has been adopted in its entirety elsewhere.
I don't know.
Okay.
I've been retired for about 7 years. Is that something that could be going around? It could be, but I have no knowledge of it.
I'll hold it for later. Thank you.
I think it's a little bit over the top.
Representative Polozov and then Representative Merchant and then Nagel.
Thank you, Madam Chair, and thank you for taking my question. So, if we modify this bill, in your opinion, what's the best procedure or what's the best time to discuss this issue with a parent? We heard testimonies that sometimes it's discussed minutes after delivering, so that's probably not the best peace of mind for mother to make decisions. So when it should be discussed with mother, and like in what form, like should it be like some additional opportunities to opt out or opt in? Could you give your thoughts?
I don't think there's a specific time. It's recommended sometime during the prenatal period, during prenatal care. One topic that comes up is contraception, specifically around tubal ligation. And for Medicaid patients, there's a requirement that that be performed and the consent be signed 30 days prior to delivery. So somewhere between 7 months and 8 months, or I'm sorry, 5 months and 8 months. Kind of a flip of the coin.
Representative Merchant.
Thank you, Madam Chair, and thank you for taking the question, Dr. Conway. First of all, congratulations on your retirement. In regards to the consent form of consent, as a practicing physician who's delivered to 2,500 people into this world, was that something that was a verbal consent? Was it written consent? Is it really kind of elected procedure, surgical? Can you comment on whether it's more of a verbal consent or whether it's a written consent?
Any kind of invasive procedure has got to be a written consent.
Written consent. So in saying that, where do you stand on an informed consent? It sounds like we already have one because it's a surgical procedure. The question I think I'm wrestling with is how prescriptive that form has to be dictated by the state.
I don't have a good answer for you. If I listed every single possible complication for every single procedure that I was trained to do, I would spend hours, which I've talked to patients about what are the most common things that happen. Certainly with circumcision, there's a risk of bleeding. That's kind of is a no-brainer. There's a risk of, I'm not sure if you really understand what happens with a circumcision, that any of the instruments really crush the foreskin, and the extra foreskin that is being taken off is then excised above that crush line. Whether it's the Mogan clamp that kind of comes together like this, or whether it's the Gomco, which comes in 3 different sizes, which really gives people the best control over how much foreskin to take off. One of the possibilities is that crush line can separate so that the foreskin then kind of slides up the shaft of the penis. I'm not sure if that answers your question.
You, sorry, Representative Nagel and then Representative Shapiro.
Thank you, Madam Chair. Thanks for taking my question. I had 2 different questions. I decided to go with a different one because you answered mine. I've been a doctor for 40 years. It's actually my 40th anniversary of my first circumcision that I did. So it's ironic that we're here today to celebrate that event. But one of the things that's really hard about becoming a young doctor, and you as a teacher would know this, is learning how to inflict pain because it's part of the job.
Mm-hmm.
Am I wrong? Is it unusual for us to ever inflict pain on a patient when we do a procedure of any kind?
If somebody is under general anesthesia, then there's really, you would be inflicting pain if they were not having general anesthesia.
Right.
So you inflict pain when you inject local anesthetic. Having had several misadventures with kitchen knives and visits to the emergency room, local anesthetic hurts like hell. Mm-hmm. And the amount of local anesthetics that's injected for doing a dorsal penile block is 3 to 4 tenths of a cc on each side of the dorsal penis at the base of it. So I will tell you that the difference between doing a circumcision without anesthesia compared to doing it with a dorsal penile block and kind of a sucrose solution on a pacifier is like night and day as far as the experience of perceived pain of the infant.
Thank you. Representative Shapiro.
Thank you, Madam Chair. If we were to end up amending this bill to create an informed consent form that, listed pros and cons, or if we amended it to create an educational brochure to do the same, which I think people should be fully educated, who would be, in your opinion, who would be the experts and maybe non-experts who would come together to create that kind of form or that kind of brochure to have people with different ideas represented? Who would be the experts who would be in best position to create that kind of informed consent or educational brochure?
I don't have a perfect answer. I would include people who do circumcisions. As an OBGYN, it's something I was trained to do. It's something I did throughout my career. Pediatricians in different areas of the country where I've practiced were more likely to do circumcisions. I never fought for them. It's not something I go out of my way to try and talk people into, period. Family physicians, those are the people who are doing most of the circumcisions. So certainly one of those. Members of the public who have some say in the matter. Nursing, I didn't put it in my statement, but I used to be a labor and delivery nurse before I went to medical school. So I've seen it from a couple of different sides.
Thank you very much.
Okay.
Thank you. Do we still have Representative McLean?
Thank you, Madam Chair, and thank you for taking my question. Based on some of the prior testimony and your experience, do you feel that the informed consent that we have right now is adequate, based on your experience and what they've testified to? And do you think that there might be some merit, in non-emergency cases to maybe altering the paradigm a little bit to front load some of that consent so it's not coming at the last minute, or would that not be practical?
That's an excellent idea. That's certainly what we do prior to doing a tubal ligation, as far as getting that consent signed. The conversation about contraceptive options goes into that whole process. So I think that'd be reasonable. I think putting in every possible complication is really over the top.
Thank you.
Yep.
Seeing no further questions, thank you very much for your time, Doctor. Next, I'd like to call Adrienne Sodi. Can you push the button so the red light comes on and then give us your name? Thank you.
Thank you. Hello, esteemed representatives. I am State Rep Julius Soti's wife from Windham, New Hampshire. I come here today to support this bill as a resident of Windham and a mother of 3 children. This issue is very dear to my heart because it concerns child welfare. I'm grateful that Representative Phillips brought this forward and we have an opportunity to discuss it and at the very least raise awareness. You see, I moved here as a teen from Hungary, where just like in the entire European continent, or most of the world in fact, circumcision is not performed prophylactically for disease prevention. It didn't even cross my mind until after the birth of my first son in 2005. After an exhausting day of giving birth, upon leaving the hospital, my husband warned me to make sure his son does not get cut, or else something really bad is going to happen to the doctor's genitals. I didn't understand why he would be worried about this at all. You see, in my mind, circumcision was strictly a religious ritual of a faith we didn't belong to. But lo and behold, when I was by myself, recuperating from giving birth, and after a sleepless night trying to nurse my newborn, I was in fact presented with a form where I needed to check off if I wanted to have my son circumcised. There was nothing to explain what that meant, why it was an option. It was simply listed like one of the choices on a restaurant menu. I was surprised, but not wanting to hurt either my babies nor the doctor's genitals, I checked no. My son's Polish pediatrician did not try to pressure me at all. He's the one who came to the hospital to check out the baby. So we were smooth sailing until the time I inquired if there was anything special I needed to do to keep my little boy clean. That was the time he demonstrated how I needed to push back my baby's foreskin to wash under it at bath time. To my surprise, my son started screaming, and once we got home, I found a drop of blood in his diaper, and in the next few days, I noticed a tiny scar on his foreskin. This is what prompted me to start researching for myself. Sure enough, I found out that I was given the wrong advice by my pediatrician. I learned that at birth, the foreskin is attached to the head of the penis, and the tip is like a tight sphincter that keeps dirt out. There is nothing that needs to be done besides rinsing it with water. In fact, it was easier to keep clean than my girl's private parts, and definitely much easier than caring for a circumcision wound ripe for infection in a dirty diaper, which we know many parents don't even realize. Had the hospital included a brochure about intact care, like they do about breastfeeding, umbilical cord care, car seat use, which is regulated by the New Hampshire Department of Justice, this could have been avoided. Even at my pediatrician's office, this type of written instruction was lacking, despite an entire wall covered with brochures. The American Family Physicians website has a list of postpartum discharge instruction that includes genital care. Wouldn't it be nice to print that for parents? On a website from 2006, it says, parents should gently cleanse uncircumcised genitals with warm water. The foreskin should never be forcibly retracted because this may cause phimosis. Well, I can thank my intuition and inquisitive mind that I did not cause my child a true phimosis, but we can certainly use a little help in ensuring that proper information is provided to new parents by those who are entrusted with their children's care. This is what I'm hoping you will assist with in order to make sure that doctors honor their promise to first do no harm.
Thank you very much for your testimony. Seeing no questions from the committee, thank you very much. Next, I'll call Andrew Sheffer and Zoe Fowler up to speak together. I'll give you 3 minutes. Sorry, I can hand that over to you, actually. You want to take it? Whichever. I can keep doing it. It's fine. Okay. Okay. So these are...
Is this on?
Yes, that's on.
Okay.
Thank you.
So, firstly, I'd like to thank you all for allowing us the chance to speak about this today. And I'd also like to apologize in advance. I do have a mild to moderate stutter that I've had from a very young age. So I come to you today to support the bill, to include informed consent, to inform parents of, sort of the risks and dangers and, of circumcision. I've been circumcised myself, as has my father, and unfortunately, as has my son. I was not informed. I was not educated. Nowhere in my my sex ed classes in school, my pediatrician's or doctor's office, or even prenatal training or educational materials when I was taking fatherhood classes. They taught us, don't shake a baby, the no-brainer stuff, don't hurt your kid, but they also didn't teach us what really hurts our kid. They missed one big thing, and it's something that I didn't know about. I didn't remember being circumcised as a child, and many of the issues I had, I just thought it was part of puberty, just part of growing up, just... And, but the worst part was what happened to my son. I didn't think it was really all that bad when it was happening. He didn't scream. He just made kind of a little whimper noise. Like, you pinch a person a little too hard. But it was a week later when he started getting infections after we were cleaning him as we normally would. We followed the doctor's instructions to the T. We went to, and before that, we went to every class. We went to every course. We did everything that we thought we were doing was right, and he still ended up with an infection and a fever of 102 degrees, and we nearly lost my son. We had to take him to the ER. I nearly lost my boy that day. And I'm terrible with names here. So I don't remember who it was who said that they were a regret mom and that they hope that their son can forgive them one day. As someone who's going through that myself, something that absolutely breaks my heart is I don't know what I'm going to say to Michael when he's old enough to ask me, hey, Dad, what happened to my foreskin? Why'd you put me through a procedure that can kill people, that gave me an infection? What happened to my sensitivity down there? Maybe he has some other issues that come about in life later that I don't know, psychiatrically, physically. I'm not a doctor. I'm not a medical professional. I'm just a concerned parent and a person who is also, grieving over my own body. Now that as a foreskin restorer over the last 3 years, it really taught me a lot about what I had lost and what I had taken from my son. If someone had issued me a brochure or any of the things that we've been mentioning here, some sort of, sheaf of papers, maybe about this size, with this amount of information on it, I would have turned back and said, no, you're not cutting my son. I would have said, no, you're not going to risk my son, his life, his well-being. I wouldn't let you. And I wish, and my ex-wife wishes, and my father wishes, and I wish that we had the information available to us.
Thank you. That's been very powerful.
Thank you.
If there's anything else to wrap up, but that's been incredibly powerful. Thank you so much for sharing what's such an emotional and important thing to you. So thank you for being here.
Thank you. You have a wonderful, wonderful day.
Were there any questions?
Furthermore, I will say that in my opinion, a procedure such as this is not only unnecessary, it is frankly an abomination against the ideas of freedom and justice that it be done with so little information given to the parent, and that it is allowed to occur to someone who is completely unable to even speak on their behalf.
Thank you. Thank you both very much.
Thank
And
you.
I'm going to turn the chair back over to Chairman McDonald.
Thank you, Representative Leon. Good morning, everyone. I apologize for my voice this morning. I've been in crowds, straining my voice, talking loudly the last several days. So it's not a cold. It's just trying to get my voice back. So apologize for that. Next signed up to testify is Ben Bradley from the New Hampshire Hospital Association. Mr. Bradley, you've indicated 5 minutes. If you could keep it to 3, we'd really appreciate it.
Yes, of course. I'm happy to do that, Mr. Chairman. It's an honor to be in front of the committee for the first time in my new role as the Vice President of State Government Relations for the New Hampshire Hospital Association. We represent all 26 hospitals in the state, including our 15 birthing hospitals. The New Hampshire Hospital Association, I'll keep it brief, is opposed to HB 1706. And I'd just like to share a quick concern that has been mentioned before, but I'd like to reiterate. We believe informed consent is a critical process that ensures patients or their representative participate in the development of their plan of care. However, this bill puts into statute very specific language to be used for informed consent of a circumcision procedure. We're not aware of any other statute that prescribes this kind of specific language for informed consent or any other medical procedure. Treatment or care. By doing so, our concern is the legislature would enact language that becomes outdated or insufficient to keep up with modern medicine. I'll leave it with that, and I'll take your questions.
Thank you. Representative Leon.
Thank you, Mr. Chairman, and thank you, and welcome to Health and
Thank
Human
you,
Services.
Representative.
Looking
Thanks.
forward to getting to know you. My question is about the way that some of the policies in hospitals have changed, that some of the things that were just presumptive before became an on-request service. And my question, which you may need to go back and get answers for, would be if the hospital associations would be opposed to moving to having circumcisions on request, as opposed to saying, here's the form, yes or no. Because I remember, even though I was very aware of this, the forms that I had were did not have all the information that I needed.
Understood. Yeah, I think that's something the legislature should contemplate, is whether it would be appropriate to legislate that kind of consideration for for what you just described. As far as I know, I think it would also be important to bring together medical experts to understand what would be most appropriate. Happy to work with you. I'm sorry I don't have a concrete answer for your exact question, but that's my response.
Other questions? Representative Palmer.
Thank you, Mr. Chair. Thank you for taking my question.
Hi, Representative.
So you brought up the.
Get the microphone closer. Thank
Can
you.
I
I want
get-
to hear what you have to say.
Can I get taller? No, sorry. Thank you for taking my question. You brought up the concern I have, which is that the language in here is sort of the consent form. And my question is, would the Hospital Association support a bill that just said a consent form will be created with, you know, a group of experts and concerned citizens doing that, so that it's that now a document that could be changed over time?
Yeah, I think I appreciate the consideration of allowing those mechanisms that may already exist to support how to inform the informed consent process, right? I will say that, you know, the Centers for Medicare and Medicaid Services does have guidelines and standards, rules, requirements for informed consent, as does the Joint Commission, DMV, with their accreditation. So, you know, I can't commit to, you know, something before seeing it. I'm happy to take a look, but our big concern is really just legislating the specific language that you see before you.
Representative Weber.
Thank you, Mr. Chairman. Thank you for taking my question. As a follow-up to the earlier discussion, and with understanding of concern about intruding ourselves into the practice of medicine, I wonder if it would be a willingness on the part of the Hospital Association in connection with medical providers to undertake a rigorous examination of both the informed consent process and the question of whether this is something that you have a yes or no, or whether you have to ask for it and say, gee, I'd like to talk about this procedure, as opposed to having it in legislation.
Well, and that's what I tried to allude to with Representative Palmer, is to use the bodies that exist today to help with informed discussion with experts who can make determinations and help with the process.
Follow-up, sure.
I guess my concern is trying to make sure that somewhere along the line in this discussion, there would be a real representation that would happen, rather than that it ought to happen.
I think these are, I can't speak for as a medical professional, but what I would say is I think that the expectations of an informed consent are routinely reviewed on an ongoing basis. In a moment in time, I think that would be continually important. This is an important discussion for the committee's consideration on the importance of informed consent. And I'm not opposed to working with anybody on this issue.
Representative Merchant.
Thank you, Mr. Chair. Could you speak to how long a form has to be retained by a facility if you're a minor? Because in here it says specifically 25 years. If you're an infant, that probably makes a lot of sense. But if you're not, if you turn it into someone who does it at 10 or 11 ages of year, that's a long time. So is 25 years consistent with what hospitals today have to do with consent forms for minors?
I do not know the answer to that question precisely. I will say, and what I've heard previously is statute has recognized a 7-year hold of medical information.
7 years, right? 7 years
Follow up.
from, thank you, Mr. Chair, sorry. 7 years from what time? Is it 7 years from age of maturity, or is it 7 years from the time it's done?
I don't have an answer for you.
You want to speak? And Representative Nagel.
Thank you, Mr. Chairman. Thank you for taking my question. I'm assuming that your voice is gone because you were at the Bills game with me?
I was not.
No? Okay.
I would have had more fun probably than where I was.
Right.
But,
I really appreciate the discussion here today, especially about informed consent, because I agree that it's a more global problem that we really seriously need to think about more globally. With that said, I do have concerns about this bill that I wish you could answer for me, and I will reiterate what I said earlier. In 2010, when I assume the number may be increased, I don't know, but 48.3 million surgical and non-surgical procedures that would have required an informed consent of some sort. This is just one small element to that. And do you, as your organization, see this bill as a potential slippery slope that we're going to start facing not just this, but another legislation next year, another next year, another next year for back pain? Obviously, we should do it for back pain too, right? Do you see that as a potential problem with bills like this?
I think that's a reasonable consideration that the committee should think about, yes.
other questions? I'm seeing none.
Thank you.
Also signed up to speak is Rob Berry from the Department of Health and Human Services.
Good morning, Mr. Chairman and members of the committee. I will be brief. We are just here to provide information. We don't have a position on the bill, but I did want to direct the committee's attention to a couple things. On page 2 of the bill, line 25, it gives the department the ability to institute disciplinary procedures for violations of this section. In talking with our licensing and certification unit here at the department, we're a little concerned about how we could enforce that. There is some overlap with patient files that we might be able to look into with this kind of issue, but it's not something we anticipate that would be an easy enforcement mechanism for the department. With that being said, to the extent that there's any suspected misconduct on the part of a medical provider, we do refer those to OPLC. So that would be something we could do. But we just wanted to raise that with the committee. The last thing is on page 4, line 20. This is the consent form that we've been speaking about. Currently, the bill reads as the department is the final arbiter of what these consent forms should look like and how they should be presented. It's a bit outside the scope of what the department does. I've heard some recommendations from many individuals around the table here that this should be an effort by medical professionals, members of the community, things like that. The department would wholeheartedly support that, as it doesn't feel like it's equipped to deal with such a task. And with that, I'll take any questions.
Okay, thank you. Representative Merchant.
Thank you, Mr. Chair. And thank you, Mrs. Berry, for taking the question. Would you look at line 27 on page 2? My concern is that in here is a monetary penalty for medical facilities. Can you comment on the fact that they're not the ones doing the procedure, but the healthcare provider? Why would the medical facility be penalized?
Well, when we have licensing rules that we put in place, we do have the ability to issue civil monetary penalties. This may be something that falls under that, but to your point, Representative Merchant, this was something when I was speaking with the Bureau Chief of Licensing and Certification, we were not really sure how we could institute proceedings based on this section against a facility. We'd have to look into that, but it's not immediately clear how this would fit into our ongoing licensing scheme.
Thank you.
Other questions? Representative Cushman.
Thank you, Mr. Chairman, and thank you for taking my question. Hopefully I can remember what it was now. Would you find that you were saying that you don't want the department, or it's kind of tricky for the department to be the final arbiter of what the form says. Would you agree that perhaps a better way would be to find a form that already exists from an organization that has created one, like the midwifery consent form for vaginal births after cesarean?
I mean, that's a potential option, but I think the more appropriate, or at least the department's perspective is the more appropriate course of action is to involve as many stakeholders who have knowledge of the situation as possible.
Thank you.
Other Representative Shapiro.
Thank you, Mr. Chairman. I see on the back of this bill that there's no financial note as of yet. But is it safe to say that if the department actually had to provide copies of such forms at no cost to a variety of groups, that there would be some significant cost?
Potentially, with printing, especially when you're not able to charge the receiving entity for it, it can cost a lot in ink, toner, and in particular staff time. I deal with right to know requests a lot, and they can take a significant period of time to get out there. So it's a substantial amount of time to put this stuff together sometimes.
Thank you.
Other questions? Seeing none, thank you. Also signed up to speak is Richard Arthur Angel from Bodily Autonomy and Equal Rights. Sir, you've indicated you want 10 minutes. I'm afraid we can't give you that much time. We've asked everybody to keep it right around 3 minutes, please.
Good.
Also, you've filled out this card for both this bill and the next bill. We need separate cards for each bill. So if you could do a separate card for HB 1683, I'd appreciate that.
Oh, sure. Sure, no
Thank
problem. The good news is most of what I was going to say has already been addressed. But there are certain things that I would like to address. For one thing, one common theme that I'm hearing, we've got medical professionals who oppose the bill. We had a doctor, anyway, the problem is that medical professionals think they know more than they do. And studies have been shown, I actually sent links to such studies, 2 of them, studying medical textbooks in the U.S., which do not adequately educate about the foreskin and its functions, and surveying doctors and finding out that they don't know anything about what they're cutting off. So appealing to doctors is it's not a good idea. It's called argumentum verecundium, or appeal to authority. But when the authority are mistrained or uninformed themselves, that does nobody any good. This is not a medical issue, it's a human rights issue. Any and all argument about the pros and cons or medical benefits versus not benefits, it's all bunk when it comes down to bodily autonomy, which, by the way, is a concept, not any particular organization. The first speaker, Representative Burrough, cited the AAP, but the AAP's statement, which was made in 2012 and which was heavily criticized and torn apart by all the medical organizations of the world, basically, expired several years ago and is null and void. And the CDC, they themselves refer to it. So it's all bunk. There is no valid medical reason for amputating baby boys' foreskins. And as men who are victims of this, we do not appreciate it. There are hundreds of thousands of men that we know of, based on sales and inquiries and so on, that are undergoing foreskin restoration. As for me, I have to say this because people have to know that it's not a good idea. People have to know the truth. But I keep an O-ring or other device in place on my penis to hold vestigial skin and scrotal tissue over the glands to keep it protected. The glands, whether male or female, is an internal organ that is supposed to be covered and protected. If that ever slips off and I lose it, then within a short time, I start feeling very uncomfortable as the glands painfully rubs on my clothing, just like before I started the foreskin restoration when I was 25 years old. And within a few hours, my meatus, that is the urinary opening, burns with pain from being exposed and rubbing on my clothing.
You could please
Now,
start wrapping up your testimony.
one of the questions was the rate of complications. The answer is we don't know because such complications are hidden. It's a criminal operation, and the truth would put circumcisers behind bars. And so, of course, the complications are being hidden. But meatal stenosis, that is hardening of the opening there, the meatus, is diagnosed in about 20% of cases. I sent a link to Representative Phillips to back that up. That's 20% diagnosed. I maintain that there's a 100% rate of meatal stenosis,
Please, sir.
but
Wrap
it's
up, please.
only diagnosed as such once it starts obstructing the urinary flow.
Thank you, sir. Thank you. Are
I
there any-
support the bills to defund circumcision from Medicaid. It is not a medical procedure, it is a medical fraud. And to inform parents so as to slow down their eagerness to have it done to their children.
Thank you. Are there any questions? Representative Cushman.
Thank you, Mr. Chairman, and thank you for being here and taking my question. You had mentioned that you had alleged that it's a criminal operation, and I just kind of wanted to explore that a little bit. Is there some way of making money off of foreskin?
Oh, absolutely. Oh, absolutely. Look it up. Look up foreskin regenerative cream. There's facial cream that's being made with foreskins that are basically taken from hospitals. You can look it up. Candace Owens, did quite an expose on that. It's a huge business. That's not to mention foreskin restoration. One study found that, there's a potential for billions of dollars. If men had the money to do it, they would get their foreskin back. Not that it can be done, really.
Other questions? Seeing none, thank you, sir. And again, please don't forget that card for the next bill. Also signed up to speak, and I hope I pronounce this correctly, Yakov Abuhav. Am I close?
Yes, my name is Yakov Abuhav. I was born and raised Jewish Orthodox, where the practice of circumcision is routinely done with no anesthesia. The baby gets a tip of a finger is dipped in the wine that's made a blessing, and they put it in the baby's mouth, and there you go. It is not a joyful sight at all. And anyway. The circumcision comes, as far as you go from the Bible, when it is done as part of a contract between God and the Jewish people, and it goes from there. Even Maimonides, 1,000 years ago, is a Jewish scholar, a philosopher, and a doctor, wrote that it was mainly done for the benefit as it would keep men from masturbating. And this is nothing but a religious ritual that got carried on into the modern times. where most people around the world would not do it. When it comes to circumcising females, everybody's, oh, that's a big deal. And it'd be funny to see people playing the parental rights card on that one in this country. It only works when it's for male. Well, that's pretty much the gist of it. But at the very least, if as long as it's legal, people should be afforded at least a good acknowledgement to what the procedure is and what it is not.
Thank you. Any questions? Seeing none, thank you. Also signed up to speak is David Llewellyn. And Mr. Llewellyn, again, you've indicated 5 minutes. If you could keep it to 3, I'd appreciate it.
I'll do my best. Good morning, and I appreciate the opportunity to speak about this very important issue. My name is David Llewellyn. It's good to be back in New Hampshire. My grandmother was from Pike. I am somewhat unusual in that I am the non-circumcised, intact male from with a circumcised father and circumcised brother. I was born over in Salem, Mass., and I was a premature infant and had a doctor who decided not to circumcise me because he thought it would kill me. I was premature. And I am an attorney at law and practice in Atlanta, Georgia. I have been I'm a 1979 graduate of the University of Virginia School of Law. I've been a litigator for 44 years and have been studying this entire issue since 1980, just before we had children. Since 1995, I've actually been litigating circumcision issues. I've been admitted pro hoc vice in 28 states. I've lectured at Pace University Law School on this issue and at Jefferson Medical College in Philadelphia and several international symposia. I have handled about 72 genital injury cases arising out of circumcision, including such things as shaft stripping, buried penis, part of the glands being cut off or rotting off, forced foreskin retraction, and other injuries. I have handled over about 22 wrongful circumcision cases where a child was circumcised without permission. I've handled or advised on about 7 cases where parents were arguing over circumcision. I will go into this more with the other bill, but there are a lot of risks, and the risks are really unknown. The last statement of the American Academy of Pediatrics, the folks on that committee admitted that they didn't know the risks, even though they were willing to say the benefits they thought outweighed the risks, but they really didn't know the risks. Submitted to the committee has been a pamphlet that cites an 11 or a study that was put on at the Society for Pediatric Urology that showed an 11.5% complication rate. I believe it is greater than that. 20% of the average pediatric urologist's time is spent repairing circumcisions. I think probably 30% of men who've been circumcised have had too much shaft skin removed. What I do want to say is this is not a religious issue. None of the bills, neither of the bills that you'll consider today have anything to do with religion. My family is somewhat unique. One of my brothers-in-law is Jewish, and his sons are Jewish, although I don't know if they practice. One of my nieces is a PhD in Arabic studies, married an Egyptian, and converted to Islam. I do not see the bill of informed consent for the medical place having anything to do with religious circumcision, and certainly it does not prohibit it or even require that parents in religious ceremonies be informed of these things. Although I must say that even there, having represented about 5 Jewish children who suffered serious injuries, that it would not be a bad idea, but that certainly isn't what is required.
If you could
Now,
please start wrapping up.
let me say this. Circumcision is unique, okay? It is the only so-called medical procedure that removes a normal body part from a normal infant. That is why the consent form needs to be there. It is also the only surgical procedure that is solicited, unrequired surgical procedure that is solicited. Doctors unethically are not supposed to solicit medical procedures, and yet they do on a daily basis. In fact, when my first son was born, the first thing that happened after he was born is a nurse is waving a consent form going, do you want to have him circumcised? That is why the non-solicitation part of this statute is so important. I realize I should say this. I have brought a book here. I've passed out some things on the function of the foreskin as well as other things you can look at. I do want to say one thing. Doctors will say, and Dr. Nagel, I appreciate you very much, and the other doctors on the committee. Doctors honestly are not informed by the things I'm handing out, which are what I handed out at Jefferson Medical College to the students when I lectured there. They would be the worst persons, in my opinion, to be on a committee. This is unfortunately a very political, and as you can tell from the testimony here, a highly emotional topic. I think, though, if you look at it seriously.
Sir, why don't we see if there's any questions
Sure.
at this point? Are there any questions? Representative Cushman.
Thank you, Mr. Chairman. You had mentioned that you are an attorney, and I just wanted to clarify something, just for the record. It's according to the Lawyer's Code of Professional Responsibility, whenever a lawyer seeks legislative, administrative changes, he should identify the capacity in which he appears, whether on behalf of himself, a client, or the public. And so are you acting on behalf of yourself, your client, or the public today?
I'm here just as an individual acting on behalf of myself in an issue that I think is important. No one has, I'm not appearing here on behalf of any organization whatsoever.
Thank you.
Representative Palazov.
Thank you, Mr. Chair, and thank you for taking my question. You mentioned parents arguing about circumcision, so is father have any say in whether this procedure will be done? And like, in your opinion, is there any change needed in this situation when parents don't agree?
Well, I do believe this. Our law allows parents to make this decision. One can argue whether or not it ought to. Do I think two parents, if both are involved, as this statute requires, should have to agree on it? Absolutely. I have seen spite circumcisions. I have seen people fighting over this. I have seen instances where parents, the boy won't be circumcised, and then the parent later marries somebody who wants the boy circumcised, and they have custody. We fought over that in Chicago. Yes, I think it's absolutely essential that both parents have to consent. Not just one parent, not just the mom who is under anesthesia and may not even know what she's signing. I represented a boy who, when he turned 18, wanted to sue his circumciser. We found out that the mother really didn't even know she'd signed a consent form. She had just been given Demerol a few hours before, and she said she didn't even want her son circumcised. So, yes, I think both parents absolutely should have to consent.
Thank you. Representative Weber, and then Representative Merchant.
Thank you. I may finally have found the more appropriate person to ask my question. Do you know if this legislation, which appears to me to be sort of national in its submission, has been adopted unchanged in any other states?
I do not know. I do not believe it has been.
Okay, thank you.
Okay, this isn't like the American Legislative Exchange Council, who's sitting around lobbying legislatures. Okay, in fact, I didn't even know about the existence of this bill until somebody alerted me to it about 2 weeks ago and asked and Representative Phillips asked if I would come up and offer my testimony.
Thank you.
Thank you,
Representative
sir.
Merchant.
Thank you, Mr. Chair, and thank you for taking the question. Following up on the question from Representative Cushman, I understand that you're not here representing anyone except yourself. Again, for full disclosure and transparency, are you here on your own dime?
Years ago, okay, when I was asked to do a case in Chicago where parents had agreed not to circumcise the boy. They were both from Europe. The mother then divorced, married a circumcised man who had a circumcised son who wanted to push the circumcision on the boy. A number of people donated money essentially for my travel expenses. I don't think I charged any fee in that case. I thought it was important enough to do it pro bono, but I had to pay a co-counsel and I had to have travel expenses. As a result of that, an amount of money has remained in my trust account that we did not expend, and that is I'm using that to be here today. If that weren't available, either friends would donate it or I'd be here on my own dime.
Representative Shapiro.
Thank you, Mr. Chairman. You just spoke about both parents consenting.
Yes, sir.
And I'm wondering, I know you're not a physician, but you are a lawyer.
Right.
So I wonder if that is like significantly different than any other kind of medical consent. Where my understanding, at least as a parent and as a mental health professional, that it takes a parent, in good standing, a parent who actually has guardianship to consent to medical treatment. And that, people wouldn't typically be asked to have, if a mother takes their child for treatment, to have the father come in also to give their consent. So would this be a departure from the norm?
Yes, it would, but I think it's an important one, and I'll give you an example. I was involved in advising in a case in Missouri where the child had not been circumcised. The dad had always wanted it done and actually managed to get custody of the child, took the child and had it done while he had custody, and had the doctor call and laugh at the mother. So do I think both parents should have to consent? Absolutely. I'm very passionate about that. I think it's not fair to the child. Remember, this is unique. This is the removal of a normal body part on a child who cannot consent. Proxy consent for reasons everyone agrees is not medically necessary. Under the AMA's, the AAP, the American Academy of Pediatrics' own guidelines, that is unethical. All right, but we allow it. But if we're going to allow it, certainly both parents should have to consent. It should never be done over the objection of one parent.
Follow up?
Follow up. I don't think in whatever we do with this bill, I don't think we're going to solve the problem of contentious divorces or contentious parenting. So I wouldn't use this, personally, I wouldn't want to use this as an opportunity to try to solve that problem.
I'm certainly not thinking, having done an amount of divorce work, I've done a wide variety of cases in my time, not just these cases. I agree, we aren't going to end that contention, but it can, requiring both parents to agree would end the bickering about it in many respects, because it would just be the law. And parents would have to respect that, and you would not have the coercion that often happens. There was a terrible case down in Florida where a couple had agreed, the mother had agreed when the kid was 1 to have him circumcised. The parents never were married. She had custody. Eventually, he got custody. One of the doctors testified, well, I would do it, but it's really not necessary, on a 4-year-old. Okay, and the mother ran with the child, hid out, got arrested, and literally was forced to get out of jail to sign a consent form in chains. It's the Hieronymus case, and you can look it up on YouTube. It's one of the worst things I've ever seen filmed in a courtroom here in this country. If both parents had had to agree, this wouldn't have happened.
Thank you. Other questions? Representative Merchant.
Thank you, Mr. Chairman. It's not often we have a knowledgeable attorney before us, so I want to take advantage of it. So bear with me. In regards to this procedure, if I understand it correctly, have had the time for a child, basically at that point in time, a parent makes a decision and therefore causes a complication, and therefore you're basically saying the child has some legal ramifications to the parent. And this is one of the situations where the parent makes a choice on behalf of a child, and therefore, as an attorney, you're representing the child, if you will, against the parent. Can you tell me how this is different than a parent that elects not to have a child receive polio vaccine and subsequently becomes a victim of polio, and how the parent at that point in time is now going to be subject to the ramifications of making that choice on behalf of the parent? Charles,
I have never represented a child against a parent, and would hesitate to do so. I've only represented, I guess it was one young man against a doctor who circumcised him, okay, because the consent was invalid. I do think that the circumcision is quite different than vaccination. Vaccination can actually, and I don't want to participate in this because I don't participate. I believe in vaccines. I understand there are people who do not. They're out there in front here this morning. I respect that, but I think that vaccines have I remember, I'm old enough, I'm 73 years old. I remember polio. I have a couple of friends who still have metal braces, okay? I don't for 1 minute think that vaccines don't work effectively. Are there risks? Yes. I'm allergic to polyethylene glycol. When I had to get a COVID vaccine, I had to discuss with my physician, is it worth the risk, because PEG is in the thing? And we decided it was. Luckily, I didn't have a reaction to it. So I think vaccination is an entirely different issue. Here you are removing normal, healthy tissue from a normal infant. Now, this statute doesn't prohibit that, okay? And I'm not here to argue that it should be prohibited. Socially, I might argue that it should be, but that's not what this bill does. This bill merely says parents are going to be told these risks. I want you to know I have seen a dead baby who bled out. I'm representing a child right now who came very close to dying and had 2 units of blood from a normally performed circumcision, except they took off all the shaft skin on the ventral side of the penis. The wound opened because of pressure. The doctor earlier said something about wounds opening. They only open if you've taken off too much skin. The child starts to bleed. The parents, if they're lucky, get to the hospital in time. And it's not just poor parents, it's rich parents too. I had a pediatric urologist, guy, his head of pediatric urology at Georgetown, told me they had a situation where very wealthy parents right next to the hospital had a wound separation. The child almost died. I have seen a child that I believe died from circumcision for bleeding. But I didn't take the case because the autopsy was blown and the body was cremated. So I couldn't take the case because I couldn't prove negligence on the part of the doctor. I'll get to it this afternoon, but one of the problems with Medicaid is, here in Atlanta, is that what the doctors are doing is, because Medicaid takes a couple of days to be approved, they aren't doing the circumcisions in the hospital.
Excuse
They're running
me,
and doing
Mr.
them in
Chairman?
the office. And then
I believe we've gone way beyond the scope of the question or the bill, and I
If it's
know there
related
are
to
other
the-
people waiting.
If it's related to another bill, sir.
Yeah,
hold it
I'll
till
take
then.
that up this afternoon. I'll sign up for this afternoon.
Representative Nagel, did you have a question, or you kind of had your hand up, but I wasn't sure.
I do, yes. Thank you, Mr. Chairman. Thanks for taking my question. I just wanted to ask you a question. You in the last, can you hear me?
Yes, sir.
You in the last, witness, both implied that doctors really shouldn't be considered the experts on this. And I
Yes.
want to delve into that a little bit more.
Sure.
So I want to make it clear, I did my first circumcision 40 years ago. I did my last circumcision 40 years ago.
Okay.
It's not something I do, and it's not something I'm an expert on, nor would I even
Certainly.
profess that. But there are people who are. Dr. Conway, who was here early, pediatricians, things like that. Are you implying that shouldn't be considered experts, or doctors in general?
I think it depends upon the doctor and depends upon what he has studied. For example, I asked Dr. Conway if he could name for me the 5 layers of tissue in the foreskin. He could not. I asked him to take the items that I've just given to you. He refused them. Okay? Campbell's Urology 10th edition has a diagram in it that does not correctly show the layers of tissue in the foreskin. There has been such a prejudice against the foreskin, which actually in this country arose as a result of anti-masturbation hysteria.
I think he's just
that-
asking you your opinion.
Well,
of doctors
the
as
reason I think that doctors are, it depends upon the doctor. Dr. Van Houw, whose articles I have cited, has studied the issue in detail. I think he's an expert, but I don't think everybody is, and I think a lot of those who claim to be experts really don't know what they're talking about. When you get an AAP committee who says, well, the benefits outweigh the risks, but we don't know what the risks are, when I can tell you what the risks are, then I think there's a problem, and that's my
Thank you,
point.
sir. Any other questions? Seeing none, thank you.
Thank you.
Also signed up to speak is Shane Brewster. And again, Mr. Brewster, you've indicated 5 minutes. Please try to keep it to 3.
I will. Thank you. Thank you all for your time today. I appreciate it. Hello. My name is Shane Brewster. I am a neighbor from the north. I am a Mainer, born and shortly thereafter circumcised in Portland. I am a part of an ever-growing discontentment among those circumcised young, those who have had this procedure without medical necessity and without being able to give their own informed consent. I do not speak for everyone. We all have different relationships with our bodies, but I am not alone in wishing my body was left intact. I head up the main chapter of the National Organization of Restoring Men, NORM for short, a network of men who provide information and support to those concerned about being circumcised, are considering foreskin restoration, or are in the process of restoring their foreskins. Foreskin restoration is mentioned in Section 10C of the bill. To elaborate quickly, as it's kind of a niche subject, foreskin restoration is the non-surgical regrowth of penile skin via tension-induced mitosis. In other words, by tugging on the remaining tissue over time consistently, usually with a device, someone can trick their body into growing a functional facsimile of a foreskin. This is not a new concept, it's not a fad. Foreskin restoration has been traced back to Roman times when the pondus judaeus, a weight typically of bronze or copper, was affixed to the penis for men wishing to undo what was then a less extreme version of circumcision compared to what we practice today. In modern times, we are now following similar principles to those used in antiquity, but with devices made of nylon and silicone. The materials have changed, but the wish to undo a choice forced upon oneself lingers. The process of foreskin restoration can take months to decades, depending on an array of factors. It can be immensely beneficial both physically and mentally, but takes a level of time and commitment that a lot of men struggle with. Atop that, there are specialized tissues excised during circumcision, which cannot be regrown in this process. Foreskin restoration is in no way ideal, but nods to Roosevelt with a do what you can with what you've got where you are kind of attitude. I've helped a handful of men locally over the years, but as we are more trees than people up in Maine, I am also well connected on the internet. The online platform Reddit has a foreskin restoration forum, which alone has around 33,000 users currently, roughly growing about 1,000 users a month. I'm also a member of 15 Square, a United Kingdom-based organization formerly known as Norm UK. Their website traffic is upwards of 60,000 visitors a year. As I said, I don't speak for everyone, but there are a fair amount of folks around the world who, like myself, have been robbed of the chance to experience life in an unaltered natural body. Men who, like me, struggle with the physical and mental impacts of a procedure they did not consent to. Were a bill like this, the Circumcision Transparency Act as it's called, in place when I was born, my life would be much different. From family discussions.
Please start to wrap up your testimony.
Will do. For family discussions, I was circumcised at the prompting of the doctor who delivered me. He offered a slew of proposed health benefits that we know now are not grounds for the preemptive removal of healthy tissue. Parents should be fully educated about circumcision, should they ask, and not be erroneously coerced into a decision that has lifelong impacts for someone other than themselves.
Thank you.
Thank you.
Questions? Representative Palazov.
Thank you, Mr. Chair, and thank you for taking my question about restoration. Do you have any estimate in terms of like financial burden on a person who tries to restore his foreskin? And also, is this process associated with any known further complications? Thank you.
As far as financials, restoration can be as cheap as you want it to be or as expensive as you want it to be. So some people can do it by manual means, by only using their hands. Some people use medical tape and devices they make on their own. Other devices cost several $100s a piece. And it just kind of depends. Those devices need kind of maintenance over time. And when we're talking about someone who might be restoring for 5 to 15, maybe 20 years, those things have to be updated and changed with time. Pardon, could you remind me the other portion?
Complications from restoration, some medical side effects.
Nothing that I can speak to of specifically. This is an issue which often isn't understood by doctors. I've brought it to all of my physicians that I've spoken to, including my chiropractor for fun. All of them had no experience in this, and I was the first person to bring it to them. So my apologies, I do not have any firm answers there.
Thank you. Other questions? I'm seeing none. Thank you.
Thank you.
Also signed up to speak is Representative Ellen Reed.
Thank you so much, Mr. Chair and honorable members. For the record, my name is Ellen Reed. I represent Rockingham 10, Newmarket, and Newfields. I think it sounds, from what I've heard, that pretty much everyone is in agreement that parents, as you've heard multiple testimony, are not getting proper education before this. You may remember me sitting before you last year that I am an advocate for patients being informed. So it should be no surprise that I am here today. I did want to point out a couple of things that haven't been mentioned, and I wanted to address a few things that I heard. So the first thing is that some of the opposition has come from women, and I've, not to say that because they're women, but I personally am hurt by that because as a woman, there is a ban on female circumcision in this country and in our state that protected me as a child, as an infant, right? And yet we don't have those protections in place for men. Now, this does not ban that procedure, but I find it hard to benefit from protection while we're not protecting male infants. On the hospital guidance, I wanted to point out an example of a hospital guidance that I was given on circumcision because I think it kind of tells the story. It gives the care for both a circumcised penis and an intact penis. At the bottom of the care for the intact penis, which is far more simple, it's simply just making sure it's rinsed. It says in all bold, never forcibly pull the foreskin back because it could cause pain, bleeding, or tears in the skin. That's literally what you're doing when you circumcise the infant. So the care guide is saying, don't do the thing that that so many people kind of do just culturally. On the issue of medical necessity and the idea that for some reason it's culturally believed to be medically necessary when in fact 80% of the world, it is not considered medically necessary. If you ask the Physicians Association in England or France or Germany or Japan or any of these countries, they will all tell you across the board, it is not medically necessary, which is why 80% of men across the world, are not automatically circumcised. But the idea that, well, there may be some 1 in 16,000 people need to be circumcised as an adult. By comparison, things that we don't remove from infants, like appendices, I should say, and gallbladders and wisdom teeth, while 1 in 16,000 adults may need adult circumcision, 1 in 20 need an appendectomy, 1 in 10 need gallbladder surgery, and 85% of people need their wisdom teeth removed as adults. We do not take those from infants. So why would we do something when only 1 in 16,000 people need it as an adult? On the question of...
If you could please start wrapping up.
I will do my best, Mr. Chair. I understand that this is has been a long hearing. On the question of the duress state of the mother, I do think that the recommendation for showing the tools that are going to be used can help because that is a state where they're not able to process maybe things like facts and figures, but are able to see the tools and kind of emotionally process what they would be doing to their child. On the question of why did it become like an 8-day thing in religion and a same-day thing culturally, I think that speaks to the fact that this is a cultural thing, predominantly cultural thing. For some people, a religious thing in our culture, but it's just something we've become accustomed and used to. And I think our job as legislators is to be willing to question what we're comfortable and used to and weigh things logically, objectively on the basis of merits. On the issue of parents' rights, the thing is that parents, we have laws. We have laws. It's not parents have all rights. We have laws protecting children from their parents, maiming them. And then finally, the paradigm shift. I do personally agree that an opt-in probably would be more in line with the facts of the matter being that it's not medically necessary. I am glad to hear the suggestion that this will go to subcommittee. I do agree that the bill could use amending to streamline and soften the language to make it more consistent with hospital documentation that currently exists. But we do have hospital documentation that's required to be given to parents and other people, other patients as well. So having said that, I don't think I have technical ability to answer a lot of questions that you've had before you already, but I will happily answer whatever questions
Are there
you
any
have.
questions? Seeing none, thank you. Also signed up to speak is Dr. Param. Good morning. And
Good
again-
morning.
And again, you've indicated 5 minutes, as close to 3 as you can possibly be, would appreciate.
I'm going to set my timer and try to stick to what I have not heard already here. I am representing for myself. I'm a family practice physician. I came all the way from Vermont here to speak to you because I've been worried and concerned about these issues for the 40 years that I've watched medicine. I've heard doctors speak. I did circumcisions on my own patients. I also delivered my own patients because I was a family doctor in the Midwest, in Ohio, and in Cambridge, Massachusetts. The problem with all of this is that it is a bipartisan issue, and right now you're not understanding, as I'm hearing it, that this is very unique, as the attorney said. There's only one other thing that looks like that, and that's female genital mutilation. Yes, I'm using very harsh language. I did not say cutting. I did not say circumcision. I said female genital mutilation. You've already heard that there's a double standard. I want to say that I'm a mom who got caught in this, and I would love to have had the kind of informed consent that you're talking about here. Despite being a doctor, despite having kept my son intact till the age of 11, my divorced husband managed to take him in for a circumcision when I was out of town. All right. So that's one reason you want to have both parents. I'll also say that since I was in Massachusetts, I helped write the laws that said that only one parent should consent to surgery. And that was about abortion issues. All right. Because often it was the father or the uncle or the brother that was the perpetrator. So I was hoisted on my own petard. I know that you do not have the same attitude towards abortion that I have in Vermont, but I want you to know that there are two issues here. One is who's paying for this. One is whether anybody is a regret parent, physician, or patient. You've heard from the regret patients. I'm a regret parent. I'm also a regret physician. I was different from what that other doctor did. I did not lean into it and try to do this fast. I tried to know what to do that dorsal penile block from the very beginning. What happens? Nurses were telling the doctors, telling the parent, ask for Dr. Param. Your baby will sleep through the procedure if you have Dr. Param, okay? So I started saying, okay, this is religious. If you're Jewish, go and get it done as a bris. And in time, I understand that there's a political issue here. This is not anti-Semitic, okay, to be saying that this is not something that we want the state of New Hampshire to be covering. All right. And it's also bipartisan because I know some Republicans are like, ha ha ha, the neoliberals are hoisted on their own petard because that other bill that you're going to discuss later is going to take away the coverage from Medicaid patients. Right. I don't think it should be covered for any medical insurance, not in a newborn. Genital autonomy is a very real issue, and it haunts people. I took care of Somali women. All right. They resented what had happened to them. All right. It's not that different. You heard. It's not that different. And I will wrap up. It's not that different for the men. I say it 3 times. A peaceful earth begins at birth. Thank you. Oh, so sorry. My name is Opeyemi. That's a Nigerian name, but I'm an African American who's been here since before 1860. What am I doing now? That was a question, and I sat back down to answer the question. No. Thank you. Thank you. Also signed up to speak with David Atlas.
Good morning. One day, several years ago, I found myself in a hospital spending time with a family member who had recently given birth. This was my first time in a maternity ward, and I didn't quite know what to expect. Suddenly, someone entered the room, overpowered me, restrained me, and cut off part of my penis while I screamed in protest. Remarkably, this happens in hospitals around the country. Every day, perfectly healthy people are strapped down and have their genitals probed, clamped, sliced, and partially amputated while they are too vulnerable to resist or fight back. The hospitals obtain consent not from the affected person, but from that person's parents. Putting aside the fact that proxy consent, in which a family member speaks on behalf of a person who is temporarily unable to speak for himself, is not valid for the amputation of normal, healthy body parts, we are here today to discuss the issue of informed consent. Are the parents, on whose legally dubious consent the hospitals rely to avoid accountability, being properly informed about the trauma and harm of this unnecessary body modification? In almost every case, they are not. The head of the penis is an internal organ. It should be warm and moist and protected like your eyeball or your tongue. In addition to serving this protective purpose, the foreskin contains muscle tissue, blood vessels, and erogenous nerve endings similar to those found in the lips, fingertips, and clitoral hood. The foreskin also facilitates sexual activity by gliding back and forth across the head of the penis during intercourse, sealing the lubrication inside and reducing the likelihood of painful dry chafing. These and many other functions are documented throughout the medical literature, but until recently they were absent from most anatomy textbooks in American medical schools. The more one learns about foreskin, the more disturbing it is that this fascinating body part is being destroyed by a medical industry that does not fully understand the damage it is causing. We live in a nation of men with wounded genitals, many of whom allow that injury to be passed to their sons without even realizing that anything is wrong. Parents love their children and want what's best for them. When they learn the reality of this unnecessary genital trauma, they protect their children from it. If my parents had known about the structure and function of the human foreskin, they would certainly never have allowed such a barbaric thing to happen to me. HB 1706 will result in a better educated population, fewer human rights violations, and less suffering for baby boys and for the men they will become. Thank you.
Also signed up to speak is Georgeanne Chapin from Intact America. Good morning.
Good morning.
That still is morning.
Is it?
Yeah.
Yeah, thank you. Thank you. I want to thank the.
You have 3 minutes, ma'am.
Thank you. I want to thank the honorable members of the New Hampshire House Health, Human Services, and Elderly Affairs Committee for allowing me to speak today. And I want to thank the bill sponsors for bringing this extremely important issue to the attention of the people of New Hampshire. This is a really unique opportunity for people to learn about such an important subject. My name is Georgeanne Chapin. I'm an attorney, a bioethics authority, and former chief executive officer of Hudson Health Plan, a Medicaid managed care organization that operated in New York for 25 years. I was the CEO the entire time. It was acquired in 2014 by a larger insurer. I currently head the Hudson Center, a not-for-profit technology organization, and I'm the founding executive director of Intact America, which I'm here to represent today. Intact America is the largest professional anti-circumcision advocacy group in the country, and I'm speaking here on behalf of the organization and our approximately 375 supporters we represent in New Hampshire. Today, as we've heard, a mother who gives birth to a son will be set upon by doctors, nurses, and hospital staff who will encourage her to circumcise her baby. Some of the things that mothers will be told is that it's cleaner, that it's healthier, and that everybody does it. You've already heard about the condition of the mothers when they're approached and asked to sign a consent form, so I won't go over that again. But I know this because in the 15 years I've been leading Intact America, I've heard from hundreds, thousands of mothers with similar stories. On the delivery table or the morning after giving birth, a doctor or nurse approached them and said, "You're going to circumcise him, right?" Or "It's time for his circumcision," or "It's just a snip, it won't hurt," or "When I said I wasn't sure, they told me he'll thank you for it later." Other organizations committed to protecting babies from painful penis reduction surgery, non-medically necessary surgery, because that's what it is, received the same kinds of complaints. In 2020, to verify the extent of such overt solicitation, Intact America conducted a national survey. We found that new mothers were asked an average of 8 times if they wanted to have their boys circumcised. even if the mother said no the first time. The rate was higher for women of color, who disproportionately are enrolled in Medicaid. I believe these women were targeted because doctors know Medicaid will pay for the procedure, despite the fact that circumcision is medically unnecessary. Among the known complications of circumcision are hemorrhage, closure of the urinary opening, mangling, partial or total amputation of the penis, and even in rare instances, death. Why would any parent, if fully informed, put their child at risk from these events? If circumcision were a baby product, a swing, a cradle, a toy, the Consumer Product Safety Commission would prohibit its sale.
Please start wrapping up, ma'am.
Sorry?
Please start wrapping up your testimony.
The Circumcision Transparency Act will ensure that parents are fully informed before a doctor takes a knife to the baby's genitals. The act will stop healthcare professionals from aggressively soliciting parents to say yes to circumcision. Finally, the act will ensure that parents not be automatically compelled to consent to donate, in quotes, their son's foreskin to pharmaceutical and cosmetic manufacturers who pay hospitals handsomely for the same tissue that parents have been told is useless and unimportant, if not pathological. A child's body belongs to himself. A penis with its foreskin intact is as easy to clean as a finger or toe. The foreskin keeps pathogens from entering the urinary tract during babyhood, protects the head of his penis from chafing, drying out, and losing sensitivity over time, and ensures that when the child reaches adulthood, he and his partner will experience sex the way nature intended. I urge you to approve and submit this bill to the New Hampshire House of Representatives. Thank you for your time and attention.
Thank you. Any questions? Seeing none, thank you. Oh, Representative Cushman, I'm sorry. She does
Thank
have
you,
a
Mr.
question.
Chairman. It's just a point of clarity. You did say that you're here on behalf of the organization, so that's as a private person, as the executive director, not as an attorney representing the organization?
No, as the executive director. I am an attorney, but I am here representing Intact America, for which I am the CEO.
Thank you.
Thank you.
Thank you. Also signed up to speak is Matthew Goodwin. And again, you have 3 minutes, sir.
My name is Matthew Goodwin. I'm here today to speak as the primary author on a pending publication that broadly assessed the quality of circumcision consent forms issued by major hospital systems in New England, of which New Hampshire is included. Our current data set, which encompasses information collected from more than 40 hospitals, represents the largest assembly of consent forms related to circumcision ever compiled. These forms were reviewed for their content. The findings are deeply concerning. We observe a striking variation from hospital to hospital about what risks are being disclosed on these forms. While some forms list more than 10 risks associated with circumcision, others only list 3 to 4. Some forms do not list any risks at all, but simply state, "My doctor has explained all the risks to me," leaving us to wonder what was actually stated. Is it right that some parents know only of a few risks, while others know many more? Is it fair that some parents see this in writing while others only hear it? I would also argue a consent form that lists death as a distinct possibility is very different from one that does not. Most concerning is the observation that some hospitals include terms and conditions on their forms to enable harvesting of the amputated foreskin tissue for research and or commercial use. There is no means to opt out of this, as it is a term of the procedure itself. Does a hospital that receives financial compensation by selling neonatal foreskin tissue represent a conflict of interest? Shouldn't parents have the option to decline participation in tissue donation? Overall, the data from this study clearly shows that parents are not getting the information they need from their hospital to make a truly informed decision, and it calls for immediate corrective action. This bill would strengthen parental rights to informed consent by providing them with the necessary information and safeguards, so that it can make a reasonable, thoughtful decision. This bill would also serve to protect hospitals, doctors, and nurses by reducing legal liabilities related to improper informed consent lawsuits. With the suggested improvements proposed in the bill, there is less ambiguity about what information is being presented and who has agreed to the procedure. Based on the large discrepancy in risk documented and presented to parents, we anticipate the standard of care being questioned at some of these hospitals. New Hampshire hospitals can shield themselves from this scrutiny by elevating the current practices to a higher level of care. Most importantly, this bill gives many more children the opportunity to make a decision about their own body by slowing the decision process, one that does not need to be rushed and determined at birth. Thank you for your time.
Thank you. Any questions? I'm seeing none. Representative Leon.
Thank you. If that paper is published or if you have a pre-draft publication that you can share with the committee, that would be greatly appreciated.
I will see if I can do that, yes.
Thank you.
Other questions? Representative Cushman.
Thank you. Thank you, Mr. Chairman. So I'm looking at the American Medical Association's ethical guidelines, and part of it under patient rights says that the doctor shall advise their patients of any conflicts of interest that they may have in respect to care. Would you say that they are not upholding that part of their ethical code if they're not informing patients that the hospital is getting money from the harvesting of foreskins?
Yeah, they are not revealing their conflict of interest.
Other questions? Seeing none. Thank you. Also signed up to speak, and again, it's a tough one, Anthony Los Quadros? Los Quadro, okay. Health Equality Campaign. And again, welcome, sir. You've indicated 5 to 6 minutes. Again, I'll have to ask you to keep it close to 3.
Just want to give you some documents that'll you can refer to as I'm speaking. I'll try to keep my comments brief because a lot of it is, I don't want to tread over old territory already. But my name's Anthony LaSquadro. I'm the director of the Health Equality Campaign. I represent the growing chorus across America that advocate for higher standards for bodily autonomy of children, specifically when it comes to routine infant circumcision, which I call cosmetic. But specifically, I just cut down to the consent bill. HB 1706 is an important bill that's needed to reform the informed consent process because routine infant circumcision needs to be held to a higher standard since it's a proxy decision that's not medically necessary. It's a decision that's essentially forced on another person with potential lifelong consequences to his physical being, his future sexuality, his psychology, and one that violates his body autonomy or right to choose for himself. Hospitals often use inadequate consent forms, typically generic fill-in-the-blank forms that rely on an oral discussion between the parents and whomever health care worker is on duty at the time in maternity. The discussions are often brief and they can be biased based on the provider's viewpoint. New parents also have a lot of misconceptions about what circumcision is, if it's necessary, and how it's done. I've attached several consent forms used for circumcision from New Hampshire hospitals that we obtained. Some hospitals refuse to disclose their consent forms, like the birth center at Dartmouth, even to expecting parents, citing hospital policy. Why don't they want people to know what their consent forms say in advance? Since the decision to circumcise is a proxy decision, we need to hold the consent form to a higher standard than general surgery. Based on our research and conversations with parents, a circumcision decision is usually rushed and the mother is in a vulnerable condition after birth and may be under the influence of anesthesia. Now, for instance, when an adult undergoes general surgery, it typically involves multiple doctor visits, testing, diagnosing, discussions on the issue, maybe second opinions, and the patient has time to research and make the best decision for himself. So it's a very different scenario between routine infant circumcision and adult general surgery. So why don't we have different consent forms? Now, I know doctors really care about their patients and they want the best outcome for them. 1706 will help doctors provide better care for their patients by giving parents the information they need. It will reinforce the doctor-patient relationship because parents will appreciate getting more information to help them to make this decision that likely never came up before. It'll help avoid regret parents, and it'll help avoid disgruntled young men who feel their autonomy was violated and with very few options after the fact.
Please start wrapping up.
Sure. In my handout on page 3, it highlights a real-life case in Florida where a mom, Heather Hieronymus, who in a dispute with the father of a child was placed in jail over her refusal to sign a circumcision consent form. She ultimately signed the consent form in court, in handcuffs, in tears, and if she didn't, she would have been remanded back to jail by the judge. I'm just going to skip over some parts. Also on the issue of tissue foreskin donation, many hospital consent forms based on our research and exhibits require tissue donation. There are for-profit public companies that essentially purchase this tissue from hospitals for use in cosmetic and biotech products. In fact, there's one in Massachusetts called Organogenesis that has contracts with area hospitals just to do that. I know because I did the research and I wrote an article on it. And I based my article based on internal company documents. It's a big business. And they even sell it on Amazon. If you look up human neonatal foreskin fibroblast, it's $427.51 with Prime shipping.
Please wrap up.
Tissue donation opt-out should be the default.
You all set? Are there any questions? Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. I'm a little bit concerned by one of the comments that you made that Dartmouth would not release their consent forms in advance. Was that a communication that you had with them? Is that hearsay? And do you know what the reasoning behind that?
I called.
That is concerning.
Yes, sir. I called Dartmouth Hospital myself, the birth center, and I said, can I get a circumcision consent form? And the nurse checked with her supervisor. Her name was Judy, and she refused to release the form to me.
Follow up.
And was any reason cited?
Hospital policy.
Other questions? Representative Nagel.
This is just a pragmatic question. How many handouts did you have? Because I only got one.
One handout, 3 pages.
Okay, all right, thank you.
Other questions? I'm seeing none. Okay, thank you, sir.
Thank you.
Okay, in addition to those who had signed up and completed pink cards, 5 people signed the blue sheet indicating they were in favor of this bill, and 2 signed the blue sheet indicating they were opposed to this bill. I have no one else signed up to testify on HB 1706, so I am going to close the public hearing on this bill. And before I go on to the next hearing, a couple of announcements. One, 1669, we haven't detected a lot of interest in that. Not too many people have signed up to testify. Prime sponsors indicated there has requested that be moved to this afternoon, which it will be anyway at this point, but more like 3 o'clock. Representative Leon, did you want to comment?
3 o'clock would be perfect. That way we can continue with this and maybe have a chance for lunch before we get in at 1.
Any objections to moving it? Okay, and as far as lunch is concerned, committee members will do what we did last week in the interests of time. Obviously, we have some really important bills with a lot of public interest, and we want to make maximum time for that. So take lunch at your leisure. We'll continue to go throughout the day, so we don't have to keep staff into the evening. And it'll be more convenient for those who wish to testify as well as for the staff and everyone else. Any questions or comments before we proceed? Okay. All right. With that, I will open the public hearing on HB 1683. Okay. The prime sponsor is approaching with her pink card. She knows the rules and the ropes. Representative Phillips.
Thank you again. I'm going to be super quick because we're going to move along, get back on schedule. This bill removes infant circumcision from a covered Medicaid expense in New Hampshire. This law has passed in similarity in 17 states. I'm going to pass around a bunch of information specifically on the cost reductions and some other testimony provided to me. The cost reductions to the state is estimated at $90,000. If we no longer covered it, I would estimate it's a lot larger than that based on that is just for the billing codes. It does not include the facility charge, provider charges, supplies, that sort of thing. In addition, there's about a 10% revision rate reported. So I got the billing codes for that for children in New Hampshire over the past 5 years, and it's $177,000 in billing codes just to repair circumcisions for New Hampshire the past 5 years. That's it. Any questions?
Any questions? Representative Palmer.
So in that last part, so let's say somebody has their child is circumcised. They went through the whole thing. They really read up about it. They knew exactly what they're doing. That's what they wanted to do. And they have Medicaid. They paid for it out of pocket to have the circumcision. Now they have a complication. Are they not going to be able to get medical coverage for repair?
No, I suggest we do cover it because that is an injury. What I suggest is that it would be reduced. There wouldn't be follow-up care if we stop covering or encourage them to not happen through coverage. So that's what I was trying to paint. Yes, yes. Please help the children. Yes. Oh, yeah, go ahead.
Representative Cushman.
Thank you, Mr. Chairman. You mentioned some of the fiscal note analysis on how much this will reduce costs, but are you aware of how taking away a benefit being covered by Medicaid affects the market cost across the board of a procedure or intervention?
Yes, thank you. So if you reduce the demand on something, the market price is going to come down. I believe in other states, when people pay a cash price for this procedure, it's very simple. As my representative friend said, they kind of go corral all the male babies and they line them up and they do it all at the same time. So it's actually relatively inexpensive when Medicaid is not paying for it, driving the costs up because there's so much demand.
Thank you.
Thank you.
Other questions? Representative Shapiro.
Thank you, Mr. Chairman. Thank you for taking the question. So just to be clear, I think I am clear, but just to be clear, a low-income Jewish or Muslim family that has a child and chooses to have a circumcision that's kind of dictated by religious observance, but choose to have it in a medical facility maybe because of some of the risks that you've been talking about. So a medical facility would allow for more hygiene, more medical backup. So those services currently are covered by Medicaid, but they will not be if this bill passes.
Correct, in a medical facility. I don't see it as a benefit to poor children. I think that we're saving them by doing this because.
Thank you.
Okay.
Other questions? See none. Thank you. Also signed up to speak is Representative Santonastaso. Again, you have 3 minutes, sir.
Thank you. Thanks again to the committee. Representative Santonastaso, representing Ringe, Jaffrey, and Dublin. This bill stops the coverage of the cosmetic circumcision for infants under the state Medicaid plan. Infant circumcision is a serious human rights violation. A German court held any benefit to circumcision can be obtained by delaying the procedure until the male is old enough to give his own fully informed consent, with the option of delaying circumcision providing all of the purported benefits. Circumcising an infant is an unnecessary violation of his bodily integrity, as well as ethically invalid form of medical violence. Parental proxy consent for newborn circumcision is invalid. Male circumcision also violates 4 core human right documents: the Universal Declaration of Human Rights, the Convention on the Rights of the Child, the International Convent on Civil and Political Rights, and the Convention Against Torture. Once circumcision rates fall below a critical value, the social norms that currently distort our perception of the practice will dissolve and rates will fall. So the growing awareness in the United States about the brutal nature of the circumcision is becoming more prevalent. When circumcision will be legally recognized as inhumane, the state will be exposed to considerable financial liabilities. This will necessitate compensating individuals who underwent the procedure funded by Medicaid, or even something like a mass tort lawsuit. Basically, we're going to be looking at a tsunami of lawsuits in the future if the state continues to fund this. So, and given the profound, widespread impact of circumcision on individuals, the ramifications of such a reevaluation are substantial and far-reaching. So, any questions from the committee?
Are there any questions? Seeing none. Thank you.
Thank you.
Also signed up to speak is Rob Berry from the Department of Health and Human Services.
Good morning again, members of the committee, Mr. Chair. For the record, my name is Rob Berry. I'm the General Counsel to the Division of Medicaid. We are again here to provide information. We are not taking a position on the bill. This bill would alter current practice in terms of what covered services are offered under the Medicaid program. It would also require the department to engage in prior authorizations for any circumcision procedure, which we don't currently do. The only suggestion we have for the bill is in the medically necessary criteria on page 1, beginning on line 13 through lines 27. It's a very prescriptive number of conditions that would qualify for this. We would suggest having a little bit more flexibility, that if there are no conditions covered there, that we would have the ability to cover circumcisions under other medically necessary circumstances. And I'm happy to take any questions at this point.
Thank you. Any questions? Representative Cushman.
Thank you, Mr. Chairman. This is just my attorney clarification question. So you're here acting on behalf of the public?
I'm here acting on behalf of the Division of Medicaid for the Department of Health and Human Services.
As your client?
Yes.
Thank you.
Other questions? I'm seeing none. Thank you. Oh, Representative Leon.
Thank you. Since you had that potential clarification of the medically necessary conditions, if you could send an email with what specifically you would, what specifically you're stating around those requirements, that'd be helpful.
Sure.
Thank you.
Thank you.
Representative Weber.
Could I just ask you for a clarification? I believe the question about whether you were acting as an attorney, and am I correct in understanding that it is not the practice of law when you are an employee who is representing the general position of an employer?
Now you're getting into professional responsibility, Representative Weber. My view of it has always been that I'm here in my capacity as a representative of the department. I am an attorney. I try to abide by my professional responsibility obligations while I'm doing so. So I view myself as having a high standard of candor to this committee. And I do think I forgot to introduce myself in the previous hearing, so I do apologize for that. Yes, I am here as a representative of the department, and I am an attorney.
But if I may beat a dead horse, you are not here specifically or offering legal advice to us.
That's correct, Representative Weber.
Other questions? Okay, thank you. Also signed up to speak is Paige Boschman from National Ward 4. I'm sorry. Oh, I'm sorry. Good morning.
Thank you. Good morning. Good afternoon. Thank you again for those of you who are left. This may be a little bit surprising. I am in the previous hearing very, very strongly in favor of additional education and consent. I think it's very important for all the reasons we've already heard. On the flip side, I am here to speak against the Medicaid bill. And the reason is I don't think we're ready for it yet. Right now, nationally, circumcision has moved from a few decades ago being about 85% of Americans, of boys, were circumcised. That has shifted in the last decade or so to about 50%, but that is regional. Certain states tend more towards 10 to 20%. Here in New Hampshire, 76% of people currently circumcise their sons. I'm coming at this from a health equity and socioeconomic status perspective, as well as mental health. This bill, which would impact something that is a deeply held belief for people right now, for all the reasons we've said, because there's not enough education. Right now, it is a cultural norm. And what we will be doing is this will disproportionately affect people who are lower income and, of course, people of color. It then becomes a physical, permanent marker of poverty. Will that change? Yes. Am I in support of people staying intact? Yes. But is that the case now? No. And so I see this as as many of the things in health that have become markers of socioeconomic status. Previously, the biggest example I can think of is formula feeding versus breastfeeding, where how you fed your baby was a marker of your income. I see the potential for that happening, and as such, it has the potential to have a significant impact on the mental health of parents, of which I am an expert. The conversations that people have in their first few days postpartum stay with women forever. They remember these conversations. And if we passed this and I had to do this and I had to have this conversation next week with people, I have to go into somebody's room. Currently, we're not opt-out. I have to ask them. I'm required, or my job, I have to ask them. So when I go in and say, are you planning on a circumcision? I don't know who has Medicaid yet, so that adds work. But the point is, I go in and they say, I want a circumcision. I am the person that has to essentially say to them, you don't get one because you're poor. And for people that still believe, because of the lack of education, that this is something that is best for their baby, on day one, there's the potential for them to already feel like a failure as a parent and unable to provide what they see as something very important for their sons. Again, I am hoping that we can provide the education. Do I think that this might be the right move in 2 years, 3 years, 5 years? If we can shift our culture and we can bring that percentage down, I
Please
think,
start wrapping up.
yeah, if we can bring that percentage down, I think this bill makes a lot of sense fiscally. Right now, I have concerns about mental health and about our marginalized communities. Thank you very much for hearing me. And again, I'm Paige Boschman, representative from Nashua, Ward 4.
Thank you. Any questions?
Yes, I have.
Oh, sorry.
Thank you, Mr. Chairman, and thank you, Representative, for coming up again today.
Mhm.
I believe that our Medicaid births are about half of births in the state of New Hampshire. Do you have data on what percentage of Medicaid of children boys born with Medicaid are circumcised? Because I think that would be very interesting to know. Because with that 75% rate, if it's almost 100% in the Medicaid population, yet it's 50-50 in the non-Medicaid population, perhaps this actually might be reversed about an equity issue. What do you think about that? Or do
I
you have
actually
data?
need you to repeat the question. I'm a little confused. I'm sorry.
So I guess first question: do you have data on what the rate is in the Medicaid population?
I would guess it exists, but I don't have it. I just have the total population percentage.
Okay. And then secondly, my question would be that if it's either already evenly distributed or if there's a higher rate of circumcision in the Medicaid population, do you think that maybe this issue is different than you're first perceiving it?
If it's 100% of the Medicaid population, if I'm understanding correctly, it would feel more strongly in this way, because then that shows that the people who are in that population see this as something that is very important and essential.
One more follow-up.
Thank you. I'm just trying to square that with your testimony before about making sure that we're providing adequate education and that we're having informed consent. So I'm
Absolutely.
having a hard trouble on comparing
I
those two.
absolutely understand that. My main point here is that we're not ready for it right now. I think right now, step one is to provide education and to shift the cultural norms. And so I would advocate for this, but when we have made that shift, when it doesn't have such a social and emotional impact on people, which I think we can get to, but not right now.
Representative Cushman.
Thank you, Mr. Chairman, and thank you for taking my question. Just to kind of leap off of where my colleague just left us, is it possible that if it's disincentivized by being reimbursable under Medicaid, because in other states where Medicaid covers circumcision, the overall rates of the procedure are twice as high as states where Medicaid doesn't cover it. So is it possible that that if that is removed, that incentive is no longer there, that that the culture will follow, and maybe that's one of the reasons why the rates are higher here?
If I may clarify, you're asking, your assumption is that doctors or clinicians are incentivized to offer circumcision? Is that what you're saying?
They essentially are if it's a reimbursable event under Medicaid. So there is a reason that the hospital policy would be to counsel every parent on circumcision and recommend it versus letting it be just an elective thing that is only discussed if it's brought up by the patient.
I have experience in 3 different hospitals and a birth center facility, and this is anecdotal. I'm almost, trying to stay non-emotional. I'm almost offended at the presumption that people who have gone into a clinical field to take care of people are pushing procedures on people to make money. I have never experienced that with the people I work with. It's not the attitude I have ever heard other people being exposed to. I know there are cases where people have seen that happen. I have not experienced that. I don't personally believe in practice that is why we ask people. For the same reasons that I am not in favor of this bill, I would not be in favor of an opt-in versus an opt-out just right now, because people expect it. They wait for us to come in and ask them. They're not going to ask us, even if they want it, they are going to wait for us to offer it to them. So I've lost track of where we were with that. But no, I do not think it's incentivized. And when you give me that statistic and say, well, when it's not covered, there are half the circumcisions, doesn't that make sense? Because half of them are not being paid for. So of course there would be fewer, because fewer people have the option to choose that.
It's one way to look at it.
Yeah, I'm talking about being able to choose what's right for your children. And the way to do that is by educating people. We educate people to make the informed consent for themselves instead of forcing them into something because they're poor. If we are not going to ban this outright for everybody, we have no place to be putting this on poor people. And as a person that comes from poverty, I can tell you that this would be painful, and it is not okay to do this to people,
Other questions?
to penalize them for being poor.
Any other questions? Thank you, Representative.
Thank you.
Also signed up to speak is Peter Somsich. Good afternoon.
Good afternoon. Good afternoon. Good afternoon. Okay. Good afternoon. And thank you, Mr. Chairman and committee members, for this opportunity to speak to you in support of HB 1683, although I'd like to suggest a small amendment. I can certainly understand that you are attempting to ensure that the money that the state of New Hampshire is investing in the state Medicare plan is used for appropriate purposes. However, reading this bill, I noticed one area that was not included in coverage. This is when a documented family history indicates that a serious health condition will likely arise unless a circumcision is performed previously. For my family and me, this was not just a theoretical, but in fact resulted in severe health emergencies for my family members. Within my immediate family, I know for certain of 5 males who required emergency circumcisions in their lives as early as a teen and as late as in their 50s. All of them hoped that they would not encounter this medical condition known as phimosis, which is a condition where the foreskin cannot be pulled back from the head of the penis. But when the pain was too severe or when circumstances forced the issue, they all had to undergo adult circumcisions in situations that were not optimal for health care and certainly were much more costly than the cost of circumcision of a newborn. If you are wondering why this type of condition has not been mentioned much in public, I would suggest that this is because men are not willing to share this kind of story with others and will often suffer in silence, hoping that the condition will resolve itself. It usually does not. And that is why I'm asking you to consider an amendment in the list of allowable conditions for the circumcision in your, I think it's paragraph 3, adding a new section K for documented family history that suggests a high likelihood that a serious health condition will arise in the future. Looking at the bill before you, I ask you to consider how much pain and suffering can be mitigated when newborns with a family history of phimosis are provided with this covered circumcision. But covering adults who have phimosis who need this operation later in life will almost certainly save money for the state as well. Allow me to tell you a little bit about my family's relevant experiences. My father, like me, was born in Hungary, and during World War II, he was drafted into the Hungarian army and served as an officer for 2 years. He was only 22 years old when, during his military deployment, he encountered such severe pain due to phimosis that he asked to be circumcised in a military hospital. This was very dangerous at the time because circumcised men, if captured by German Allied forces, would be suspected of being Jewish and could be sent to concentration camps. He realized the danger, but had the operation performed nonetheless. My son had a very similar encounter. He was attending his 2nd year at West Point when he too found himself suffering from phimosis and decided to have a circumcision in a hospital near West Point. My brother was only in his teens when he too experienced severe pain and required a circumcision. One of my brother's sons had the same experience when he was in his 20s. Finally, when I was in my 50s, it was my turn. At that time in my life, I thought that I had beaten the odds, but my luck had just run out. I started to suffer increasing pain due to phimosis, which included tears in my foreskin as well as bleeding.
If you could please start wrapping up.
Yes. Having intimate relations with my wife kept getting more and more painful. Finally, I too had to have a circumcision. All 5 of us recovered quickly and had no further health problems after the operation, and either from the operation or subsequently. So, thank you, Mr. Chairman, and I'm willing to answer any questions if they are asked. I also have a handout I can give to everyone.
Okay. Yeah, if you could pass that around, and Representative Shapiro has a question.
Thank you, Mr. Chairman. Other than your very compelling personal story about this, have you done any research into whether the occurrence of
Phimosis.
Phimosis, which I'd never heard before, to be perfectly honest. Have you done any research to see if there is a genetic component to that, or if it is frequently, like evidently in your family, if it's frequently involves a family history?
I can't say that I have a very extensive research on that. Obviously, in my family, it was pretty obvious. And I have found many sources that implicate the idea that this does carry through the family in the male component. And I've had conversations with a number of doctors about this. For example, the doctor that performed my circumcision, he too said that it is known that this can be a family thing that is passed down from one to another. And so I do think that this is one of those conditions that I think sometimes gets neglected, because more often we hear about this as a religious issue. My father was Catholic and not Jewish, so it was not a religious issue for him or a cosmetic issue. And but when it gets to a point when you can't bear it anymore as an adult, it's a much more serious operation than as a newborn. So that's why I'm asking you. Incidentally, in this bill, it does mention phimosis after puberty as a condition that's covered. And I would suggest that if there was a real family history, this happening, we shouldn't be waiting that long.
Thank you for your testimony.
Representative Freitas.
Yes, thank you, Mr. Chair. And thank you for taking this. My question is, the factor about Medicaid, you don't object in any way that Medicaid would reject this. Here we're asking to not include. So is Medicaid a factor in your testimony this morning?
My suggestion for my amendment is that under the areas that are covered under the state Medicare program, that family history, demonstrated documented family history should be included.
Okay. Follow-up?
Follow-up. I understood that part. My just basic question is, do you object to the Medicaid being included, or circumcision being included in Medicaid? It sounds like they want to not have that covered by Medicaid, and I don't think that should be the case.
Well, I think if I understand direction of your question is whether I think that should be covered by Medicaid or not. And it seems to me that in my situation, if I was a recipient of Medicaid and I had a demonstrated family history of this happening, I think it should be covered, because it's almost like I'm pretty sure I'm going to get it at some point. And this is a much more cost-effective, and it avoids many painful years later on.
Mr. Chair.
All set?
Thank you. That was the answer I was looking for. Thank you.
Glad to do it. Thank you.
Thank you. Any other questions? I'm seeing none. Thank you very much.
Thank you.
Also signed up to speak is Representative Ellen Reed.
Thank you again, Mr. Chair and honorable members. Once again, my name is Ellen Reed, representing Rockingham 10, Newmarket and Newfields, and I am happy to see my former colleague, the Honorable Peter Somsich, in the room, who is in favor of the underlying bill with the amendment that I would also agree to exempt or allow for Medicaid coverage of people with a family history. The reason I am a co-sponsor on this bill is because I believe in the separation of church and state, and to the extent that this is predominantly a religious and cultural and not a medical procedure when it's done automatically, it really has no business being paid for by the taxpayers. There's no other, I kind of challenge anybody to find another strictly cultural, non-medically necessary procedure that we cover with public taxpayer money. I don't think that we do. In fact, there are many medically necessary things that we don't cover with taxpayer money. So again, to the extent that it is not medically necessary, the only issue, there's been talk about, well, infections or whatever, and this of course is except for all the exemptions in the bill and the one that the Honorable Somsich has mentioned. The only studies that have given kind of mixed results was the potential for the prevention of future STIs. And as was previously testified to, those predominantly fell on what the hygiene of that culture was in general. But not only has every physician organization in the Western world, or I would say actually almost the entire world, including our own, say that automatic circumcision is not medically necessary. I just want to read from NIH, which is, of course, our federal National Institutes of Health. This is from their Sexually Transmitted Infections in Male Circumcision, a systematic review. And the quote is, consequently, the prevention of sexually transmitted infections cannot rationally be interpreted as a benefit of circumcision. There you go. So it's not medically necessary. I do want to address comments that were made earlier by my friend who's the new member in the House about the mark of poverty. I myself grew up in South Memphis. We were always on public assistance. I lived in a condemned house for a long time without plumbing and heat. So I understand when she talks about marks of poverty, I take that really, really seriously. And it did actually, I considered that deeply when we were talking about that before this hearing. However, that same representative testified on the previous bill that she herself has left her 3 sons intact. So one can now say why, if this is such a terrible mark of poverty that gives long-term psychological problems in our society because it's such a cultural norm, why then did you mark, or rather not mark, your own sons with that mark of poverty? So in terms of mark of poverty, and is this really a problem? 17 states already prohibit Medicaid funds from being used for circumcision, medically non-necessary circumcision. Rather than it hurting poor children, I would say that, and I understand that as a nurse or as somebody having to tell a person that this isn't covered by Medicaid, that might be difficult and uncomfortable. But the question is, what is right? So rather than hurting poor children or marking them with poverty, I think it's saving poor kids from being hurt for no good reason.
Please start wrapping up.
I am, sir. Thank you. And the $200,000 that we spend on circumcision and then the revisions from botched circumcision in this state by Medicaid, I think those funds could better be used to help poor children by providing pediatric eye care or dental care. I think that better serves low-income families and marginalized communities. And finally, back to the medical necessity, again, 1 in 16,000 people who are intact, men who are intact, experience a later need for adult circumcision. That is far fewer than what Boston Children's Hospital says is the rate of complication of circumcision, which is 3%. 3 out of 100, 1 out of 33. So anyway, with that, I will end my testimony, Mr. Chair.
Thank you. Any questions? Representative Cushman.
Thank you, Mr. Chairman.
Representative Reed.
Sorry,
I'm so used to getting off the hook, Representative.
I'll give you an easy one. Are you aware of, so just let me know if you follow here, that if we take away the funding, then we've seen like in other states, there will probably be a decreased demand. And are you aware of what happens to the prices in the private market of things when the demand decreases?
So this is a kind of common problem, rather, not just in medicine with Medicaid, but also in education, where if you do nothing else to control the market forces, which I would say we should fund these things, not circumcision, but fund healthcare in general and fund education, but that then you have to put restrictions in exchange for the public funds and the public trust being given towards that. You have to put restrictions on what those private forces will do, because what they will do is rent-seeking behavior, and they will up the price. If it's being paid for by the government, they're going to take as much government money as they want. So when you unfortunately, when you remove those, the benefit of removing the funding is that the price comes down. I would like to see everybody have medical care, but automatic circumcisions is not medical care.
So that that could potentially be a benefit for those people maybe who don't qualify for Medicaid, or even the people who do qualify for Medicaid, but they're having trouble of maybe affording that the price will come down. It'll be probably more easily accessible for
I do believe that eventually the market forces would come down if this wasn't being covered by Medicaid, so that it would be more accessible. I can't say it would be accessible to everybody, but I don't know that I want automatic maiming of babies to be accessible.
Other questions? Okay, seeing none, thank you. Also signed up to speak is Representative Kelly Potenza.
I don't know if I can follow up that. So I'm just here in strong support of the bill for a multitude of reasons, but I think we have to be clear. Not medically necessary, elective procedure. So that's why would we all be forced to pay for something? And if there's education, if someone still wants it after being provided the informed consent and the necessary education that's needed, then I think finding the funding or finding the funds to do so won't be very difficult. So that's pretty much all I have to say. It's elective, not medically necessary. So we shouldn't have, it shouldn't be paid for. It just like anything else that you're going to decide to do that is not, plastic surgery, anything like that. Those are things that have to come out of your own pocket unless, and there's lots of exceptions in here, which I think there might be some other ones that are added in here, that are amended in here. And from what the previous speaker talked about too, the gentleman, I think that it's pretty clear that this bill makes sense. 17 states is another thing too. We can look at all of that that's been implemented. And yeah, education is key. People need to be, there needs to be informed consent in education, and it's just really important that I think we move forward with these.
Right.
Thanks.
You. Any questions? Seeing none, thank you. Also signed up to speak are Andrew Sheffer and Zoe Fowler. I can give you each 3 minutes. You've asked for 10 to 15. I can't do that.
That's understandable, sir.
3 minutes apiece, or up to 3 minutes apiece.
So again, I would like to apologize in case there's any new faces here. I do have a bit of a stutter and a twitch. It's something I've had for a long time. Might take me a couple seconds longer than 3 minutes, but I'll do my best to keep it concise. So I'm here.
I'm sorry, Representative Weber. You gotta put
a little closer. Could you just speak a little closer into your microphone, because as you can see, it really does change the volume, and it helps not only for us here in the room, but for anybody who's following along at home.
Of course.
So thank you.
Of course. So again, I would like to apologize. I have a stutter. Boilerplate disclaimer. So one of the reasons I'm here to support House Bill 1683 is because, again, like with the giving education, I feel this is another side of a coin here. Providing education and, not using public resources that should be going towards treating sick people, that should be going towards, people who have, medical emergencies. We're wasting resources on circumcising people when most of the time, unless for the, for certain medical issues, if they have a medical reason, understandable. That's completely, that's reasonable. But otherwise, I don't feel it's appropriate to be spending American taxpayers' dollars on a unnecessary and very damaging procedure. I also feel that I apologize. I also feel sorry. I also feel that having Medicaid as a method of obtaining a circumcision encourages people. I'm someone who lives in poverty right now. I've heard that it's a mark of poverty. I'm not making much money right now. I'm on disability. And I still have no desire or anything to go get circumcised. I feel that objectively it is a harmful medical procedure that is a drain on our resources. And I apologize, my stutter is kind of acting up right now, so I'm going to
problem, that's
resign myself at this point. Unless you have any questions for me.
Sure. Does the other gentleman wish to speak, or?
The idea that state medical insurance should pay for circumcision to me would seem at best fanciful, because any benefit to the procedure could just as easily be rendered as an adult as it could as a baby. It is not a mark of poverty to have a foreskin any more than it is a mark of poverty to have any health condition that is later fixed. We do not perform open heart surgery on babies, even if we, or rather we do, only in the instance that we can prove beyond a shadow of a doubt that they cannot wait.
Okay, thank you. Are there any questions from committee members? I'm seeing none. Thank you very much.
All right, thank you so much.
Thank you.
Y'all have a good night, or good day.
Also signed up to speak is Shane Brewster.
Hello, thank you again. I'm Shane Brewster. I will keep this short as to not completely beat a dead horse. I would like to speak in favor of this bill for everything that has been said prior and more. I would like this bill to be passed to help reduce adverse outcomes of unnecessary circumcisions, ideally in doing so, reserving funds for medically necessitated procedures. That is really all I have.
Thank you. Any questions? Thank you, sir.
Thank you very much.
Also signed up to speak is Anthony Quadro from the Healthy Quality Campaign. And you, again, you indicated 6 minutes. Please keep it to 3.
Yes, sir. I just have some handouts that are pertinent to my discussion. If I
Sure.
can approach.
I won't count that time against you.
Right, I'm trying. Okay, on HB 1683, I ask for your support on this bill because we should not use public resources to encourage medically unnecessary surgery that also violates a child's bodily autonomy. We shouldn't give healthcare systems financial incentives that can lead them to pressure parents for a needless surgery. Just being born male is not a diagnosis. I'm also concerned with the surge of Latino immigration because foreign-born Latinos are almost universally intact, and their cultural practices may come under pressure to do things the American way. And they may be coerced to circumcise their children, which may be presented to them as a free service. And when I hear, talk about that circumcision or being intact is a stigma or a mark of poverty, well, Latinos, not that they're in poverty, but immigrants are almost universally intact, and they don't seem to have a problem with it. So why do we have a problem with it? Someone brought up, what if there's a history of family phimosis? I've never read anything in the medical literature about familial phimosis or being used to justify circumcision at birth to preempt an adult condition. Phimosis can be caused by improper care as a baby, such as by forced retraction, which we've heard about, and there are minimally invasive treatments such as steroid creams that can address this if it's diagnosed as an adult. When I reviewed the fiscal note, I noticed it did not take into account the cost of circumcision complications or the additional savings that would be realized if this bill passes. Referencing a study I supplied to you on page 3, the complication rate for circumcision was placed at 11%. Okay, so these complications will require the services of a pediatric urologist surgeon in a hospital setting, which is very costly. So the fiscal note, and per my exhibit page 4, should really include these cost savings passed on. All this pain, suffering, and trauma being inflicted on babies and taxpayers for no reason. Why would we want to do this? Public funds should not be used to promote violating bodily autonomy. The public sector should set the standard for placing autonomy first. I think we should all live up to the motto of New Hampshire, to live free. Let's have the next generation of children live free as natural, normal, and healthy, intact people, because that's what they are. They're people. I urge you to think about the future and how we treat our children. Is there any questions?
Thank you. Yeah, any questions? I'm seeing none. Thank you, sir. Also signed up to speak is Dr. Param. Welcome back.
Thank you very much. And I only asked for a minute. I wanted to basically say that I was very confused by previous testimony on how it's going to be so difficult to explain to poor people what's happening to them. I represent for 3% of doctors look like me, Black and female. And consequently, when you talk about poverty, I want you to also think about BIPOC issues here, because there's a whole issue of how unfair our medical system is for all of us, and it's across the class ladder. So right now, I would like no coverage, not from the Republican fiscal responsibility end, but from the complications and the fact that when the mom goes back, maybe she won't have people listen to her because she's poor, because that is a piece of this. And then the last thing I wanted to say was there are incentives for doctors to do things. I lived with them all the time. So I understand some people didn't feel that, but under managed care, yes, there are incentives to do things that may not be exactly 100% of what you want to do morally. Thank you.
Thank you. Any questions? Thank you. Also signed up to speak is David Atkinson. And again, you asked for 4 minutes. Please keep it to 3.
Good morning. I also was puzzled by the earlier testimony about poverty because I have spent the past 10 years spreading foreskin awareness around the US and speaking with people on the street in many different neighborhoods, rich people and poor people. And poor people are intelligent and they understand the structure and function of the human foreskin and they understand human rights. I will now read my prepared statement. It should be your choice how much of your genitals you get to keep. The question before us now is whether New Hampshire Medicaid dollars should be used to fund human rights violations. The last time New Hampshire considered this issue in 2015, opponents argued that passage of such a bill would result in fewer services to low-income residents. Providing services to low-income residents is certainly a worthy goal. Therefore, let me be clear. Getting part of your penis cut off without your consent is not a service. It is an act of theft and violence. Despite the good intentions of the people who carry out this act, the newborn child experiences trauma and betrayal when he only wants to bond peacefully with his mother. It makes no difference whether the person who cut my penis intended to hurt or to help. The result is the same. Part of my penis is gone forever. Also, parenthetically, I heard people talking about pain, and I would say that even if foreskin amputation could be accomplished without torturing the child, it would still be a human rights violation. The children of Medicaid recipients, like all children, deserve the opportunity to reach adulthood with intact genitals. The best way to serve them is to leave their genitals alone to develop normally. We also heard briefly about the American Academy of Pediatrics, whose 2012 statement expired in 2017. More recently, in December 2022, the AAP published a patient education document regarding care of the intact penis, which includes the text, quote, "At birth, the foreskin is attached to the head of the penis. Until the foreskin fully separates, it shouldn't be pulled back. Forcing the foreskin to retract before it is ready can cause severe pain, bleeding, and tears in the skin," end quote. Since premature forcible foreskin retraction, such as that, is the first step of neonatal foreskin amputation, it seems clear that the AAP has quietly retreated from prior support of this practice. The state should not condone, let alone reimburse, an activity that harms children, particularly low-income children, and that is contrary to modern medical evidence and advice. Passage of this bill, HB 1683, will curtail wasteful government spending, prevent numerous human rights violations, and reduce the suffering of baby boys and the men they will become. Thank you.
Thank you. Any questions? Okay, thank you. Also signed up to speak is Matthew Goodwin. Okay, Mr. Goodwin's not here. Okay, well, moving on. Also signed up to speak is David Llewellyn. And again, sir, you put 5 minutes. Please keep it to 3.
Thank you very much. David Llewellyn. As I previously identified myself, I'm a lawyer who's spent the last 28, 29 years dealing with circumcision issues. I support this House Bill 1683. First, Medicaid by federal statute is only allowed to pay for medically necessary procedures. Now that is often, the determination of that's often left to the state, but it is clear that neonatal circumcision is not medically necessary. Therefore, ab initio, this bill should be a no-brainer. It should not be permitted to be done unless there is a medical diagnosis that requires it. I will address very briefly phimosis. The former representative who testified about his unfortunate family history. Unfortunately, what I heard was burning, cracking, difficulty retracting the foreskin in an adult, or at least in a teenager, almost always, and his dad during the war. Almost always that's caused by yeast infections. I've represented several adults who had circumcisions or recircumcisions who actually had a yeast infection, never diagnosed by the urologist, and diagnosed afterwards, either pathologically or otherwise. I even had a recircumcision in South Carolina where the gentleman still had the yeast infection. I had to send him to a urologist who knew what he was doing. You have to be careful about ever including phimosis as a reason for circumcision unless it is after puberty, because otherwise they will just say congenital phimosis. I see that diagnosis all the time, and that is essentially a medical fraud. All children generally have phimosis at birth. It also can be corrected by other than circumcision. There are other surgeries that can be done, Z-plasties, bioflaps, and the like. I won't bore you with it, but it's really not necessary to include that. As far as the state really should not be providing an opportunity for cosmetic surgery and unnecessary surgery, which they do by funding this. In regard to economic considerations, it's actually in the literature that a doctor has said every baby boy is born with a coupon for $125 on his penis. So is this actually encouraged because it's reimbursed? Absolutely. I would address the whole question of equity. I believe in Medicaid. I believe that we ought to be providing things we don't provide. Eyeglasses, for example. I think in this state you do provide dental care. We don't in Georgia. We ought to be, but we ought not to be wasting the public's money. So I approach this not from a Republican or a Democratic perspective, but from a perspective that yes, the poor should be covered, but we should only be doing necessary things with public funds. In regard to being marked with poverty, my foreskin has never marked me as being poor. And I'm not exactly the richest lawyer in the world, but I'm not poor. Nobody's ever said I was because I have a foreskin. Hispanics generally don't circumcise, and they make up a large percentage in most states of the population on Medicaid. So I think you would find if it weren't encouraged.
You could please start wrapping up, sir.
Yeah. Anyway, I think that it's very clear in essence that it is not medically necessary, therefore it should not be covered. I would change the bill a little bit. I would add some things for medically necessary circumcision, such as penile torsion, hypospadias, epispadias, other congenital malformation of the penis that or foreskin that requires removal of all of the part of the foreskin for correction. I would add those, and I would add to on line 3, item 3, or line 13 rather, I would add in place of recurrent urinary tract infections, which you really aren't going to be able to determine under the age of 1, I would change that to congenital core D, which is a congenital bend of the penis, which may require correction early. Those are changes that I would make to the bill if I had a choice in the matter. If anybody has any questions, I'll be happy to answer them.
Any questions? Okay, thank you, sir.
Thank you very much. I do want to say I am impressed by the fact that they're public hearings and the attentiveness of everyone here in New Hampshire. Makes me proud to be what am I, a grandchild of New Hampshire, I guess, but it makes me very proud. Thank you very much.
Thank you very much for that comment. Also signed up to speak is Georgeanne Chapin from Intact America. And again, you asked for 4 minutes. Try to keep it to 3, please.
I will do that. Thank you again. My credentials are on record, both in writing and for my prior testimony, but I will emphasize that I ran a nonprofit Medicaid managed care plan in New York State for 25 years. Medicaid, I support House Bill 1683 FN. Medicaid's a lifesaver for low-income families, working families, the elderly, and the disabled, but Medicaid resources are finite. That's why Medicaid's standard for coverage is medical necessity. Some who oppose discontinuing Medicaid coverage of circumcisions argue that doing so deprives poor children of a benefit that wealthier families are able to afford. The opposite is true. Circumcision confers no benefit on any boy or the man he will become. It only benefits the medical professionals and facilities who can bill and collect for the procedure and those who make their livings from repairing the damage. That's why the American Academy of Pediatrics continues to push for Medicaid coverage of circumcision. I'm going to depart from some of the prior testimony, the tone of it, and talk about my son. My son is 43 years old. He was born in 1980. When he asked his dad and me, he got into school, only a couple of boys look like me. How come I'm not circumcised? And we told him, you're one of the lucky ones. You have the body parts that you were born with, that God or nature intended you to have, and you should, while not holding that over other boys, you should be happy. You should be proud. And indeed, when he was 18, he thanked us. He said, you know, I never thanked you and Dad. I asked you a question. I never thanked you and Dad for not having me circumcised, but I really want to thank you. I can only imagine what pleasure his foreskin was giving him at that time that brought him to that point. But most boys, all boys, should be able to have what my son has, which is his entire body. I'd like to just briefly go through the bioethics of circumcision because other people have mentioned it. It'll take a moment. Neonatal circumcision violates every basic principle of medical ethics. Autonomy means that individuals have the right to choose for themselves what to do with their own bodies. Doesn't mean the parents, it doesn't mean the doctors, it doesn't mean state taxpayers or state Medicaid. Individuals have the right to choose what they do with their own bodies. Benevolence is the principle that doctors should act in their patients' best interests and treat them with kindness and compassion. Permanently removing healthy, normal genitalia from a baby, often with inadequate or even no pain relief, clearly violates the principle of benevolence. Non-maleficence, you're all familiar with it. It is best expressed with a Hippocratic oath, with which you're all familiar. First, do no harm. Removing a healthy body part creates harm. Finally, justice is a particularly important principle to apply in the context of routine male circumcision. In the U.S., girls are rightly protected from forced surgery on their genitals. Boys are entitled to the same protection. To do otherwise violates the bioethical principle of justice. In sum, again, infant circumcision violates all of the principles of bioethical principles of justice, autonomy,
non-maleficence, and beneficence. By calling for an end to medically unnecessary penis surgery, this committee is doing a service to all New Hampshire residents and to the future boys born in this state and the men they will become. Thank you.
Thank you. Any questions? Seeing none, thank you. Also signed up to speak is Adrienne Sodi. Again, you have 3 minutes, ma'am. Welcome back.
Yes, so I'm Adrienne Soti, and I'm here to support eliminating Medicaid funding of circumcision. As you had heard me before, I had described how I was given improper advice in how to care for my intact son, which the American Medical Association describes is exactly what you're not supposed to do because you will cause phimosis. Many parents do not know that, and therefore, falsely believe that that is a condition that may run in their families, when in fact, perhaps they're not getting proper medical care. There are alternative treatments, as described earlier, and number one, there are steroid creams. Just like we women often for weeks or months have issues with yeast infection, men can have that issue as well. The solution is not to remove their genital tissues, just like we women do not have the coverage of our clitorises removed to eliminate that, or any other genital tissues removed. We always revert to the most conservative treatment, which is what should be done, should be afforded to men as well. So that I would definitely not use as an amendment to this bill. And one of the reasons why circumcision should not be covered by Medicaid also is the need for repeat corrective surgeries. I have earlier handed out some papers. There was a study in Massachusetts General Hospital that said 7.4% of all visits to a pediatric urologist were for circumcision complications. This translated to an average total cost per patient for redo procedures of $1,617 and an estimated annual cost of $137 to that institution for a single urologic provider at the hospital. So that should be taken into consideration, as well as what a Utah study shows, that the complications of circumcision about 11%. Doctors opposing circumcision state that approximately the funds saved would be $2,000 per child, which include the original procedure and include later costs for follow-up and surgical botch repairs. And it could be put to better use for actual pediatric medical needs in New Hampshire. I also want to mention a very good Jewish friend of mine who is a lady in New York who I contacted originally when I first was looking for information about intact care and just understanding circumcision. She runs an organization, used to run, No Circ New York, National Organization of Circumcision Information Resource Centers, and she's been educating people about this issue for 40 years. She is a Jewish lady who does not believe in circumcision. She lives by the motto, first do no harm, and the golden rule. She teaches her parents to massage their babies and ensure nurturing beginnings, and does not support procedure that inflicts pain and causes lifelong psychological and physical harm, which is exactly what another representative suggested. We would be saving those Medicaid or poor Medicaid patients who are subjected to the surgery. So that cannot be further from the truth. Remaining intact is the default state, and it should be normalized. Many insurance companies, besides Medicaid,
please start wrapping up.
also do not cover it. So it might be a good idea to look into that as well. Thank you.
Thank you. Also signed up to speak is Yakov Abuhav.
I simply don't think that there's any place for taxpayer money to be used for child mutilation under these for no good reason. Also, the idea that doctors are just angels that do always good is not true either. They have a lot of incentives, and money is obviously one of them.
Thank you. Okay. And I have two cards here. I believe they're from the same individual, Rich Angel from Grafton, from Genital Autonomy. Sir, you've got
There
10.
should be one card.
I've actually got two. One says 10 minutes,
there's-
one says 3 minutes. 3 minutes is the one I'm going to choose, okay?
Well, somebody brought up mental health of parents, and I'd just like to point out that the mental health of children is what should come first. And I'd like to tell you a little story about that. The first symposium I attended on the subject was the Second International Symposium on Circumcision in San Francisco. The second speaker was Dr. David Chamberlain, who went on to lead birth psychology. If you look up birthpsychology.com, I think it is, or .org, he wrote Babies Remember Their Birth and other birth books on that subject. And so anyway, after he spoke, I did the questions and answers thing. I asked him, Dr. Chamberlain, I found your book in the bookstore called Babies Remember Their Birth, and I looked all the way through it, and I didn't find anything on circumcision. How did you overlook that? Or am I missing something? He said, well, thank you very much. Actually, I wrote a burning chapter on circumcision and other procedures that are done routinely on infants without anesthesia, and the publisher refused to publish the book with that chapter intact, so I had to omit it. And if you want to know more about the psychological impact of infant circumcision, look up doctorsopposingcircumcision.org/for-professionals. You'll find it. Just look for psychological impact. And in case you think that Doctors Opposing Circumcision is biased, you are correct. And their bias is do no harm. 2, bodily autonomy for all. 3, education and preventative care. And 4, conservative treatment for the rare problems that do come up now and then, usually because of iatrogenic care. That is to say, most of the complications are iatrogenic in nature in the first place. And with that, I would like to yield the balance of my time to the next speaker.
Okay, thank you. Any questions? Seeing none. Okay, thank you. Actually, there's no one else signed up to speak on HB 1683. The blue sheet in the back indicates 6 people did sign up in favor of it and 3 signed up opposed to it. So with that, I'm going to close the public hearing on HB 1683. As previously announced, we're going to continue 1669 until later this afternoon, until 3 p.m. It is after 1 o'clock, so we can move on to HB 1194. And at this time, I will recognize the prime sponsor, who once again is Representative Phillips. Actually, is Representative Phillips here? Oh, okay. Okay.
Good afternoon, everybody. I hope everyone got their lunch in. I'll be very quick. This bill 1194, just as a definition correction to align with the idea that vaccines protect people from diseases that are passed person to person. So the RSA should match that. And that's all.
Well, that's quick. Representative Palmer.
So looking at the schedule, that sort of leaves out tetanus. And I'm not quite sure why we would want to leave out tetanus since it's not communicable person to person, but if you get it I've seen somebody with tetanus, and I never want to see that again.
Just a definition change. What do you mean by leaving it out? You mean on what things can be mandated? People can still choose
Right.
tetanus, yeah.
Right, but I'm just not quite sure then why we would change the language, why we would have a bill to change the language if there's no other thing than it changes the language.
Representative Parma, we're having trouble hearing you up here.
Is this not working?
Just move it closer.
Even closer, sorry. I guess, so since most of the other diseases in there, pneumonia is a little iffy, but are infectious and transmitted person to person, and I guess technically tetanus is really infectious as well, but it's not transmitted person to person, but it's kind of a really key thing to have vaccinated. I'm not quite sure. Maybe you can explain to me better than I'm understanding the reason that we need a language change if it doesn't really change anything.
I mean, we're trying to, I guess vaccine is supposed to protect you from catching something from someone else, right? And tetanus cannot. You cannot catch tetanus from another human being.
Right, but I wouldn't want somebody to opt out of the tetanus for some reason and then get tetanus. But I'm just not understanding the rationale for the bill. I guess that's
I believe people can opt out of whatever they want.
Yes, but why do we need to get rid of the word infectious?
It's not transmissible. I don't know. I just.
Representative Cushman.
Thank you, Mr. Chairman. Thank you, Representative. Isn't it true that the idea for mandating vaccinations is that you are preventing something that can be transmissible between people, and that is the only scenario where the government asserts some kind of ability to do that, and that matters of diseases that are not transmissible are personal decisions where government has no authority to step in?
Yes. Thank you.
Follow up.
Are you aware of any tetanus vaccines available in the United States that don't also include antigens for communicable diseases such as diphtheria and pertussis?
I'm not a medical professional, but I'm not familiar. I think they're all combos.
Thank you.
Thanks.
Other questions? I'm seeing no other questions. Okay, thank you.
Thank you.
Also signed up to speak is Ryan Tanian and Dr. Benjamin Chan from the Department of Health and Human Services.
Good morning. Want to make sure people can hear me. Yes. Great. Mr. Chair, members of the committee, thank you for hearing our testimony. My name is Benjamin Chan. I am the New Hampshire State Epidemiologist and an infectious disease physician. And with me today is Dr. Ryan Tanian, who is a registered pharmacist and the chief of our Bureau of Infectious Disease Control. And we are here to speak in opposition to House Bill 1194 relative to this definition change, which removes the word infectious from the current definition of non-communicable disease in RSA 141C. As is already started to be discussed, we believe this proposed legislation is intended to prevent the department specifically from requiring certain immunizations that are currently required under RSA 141C for entry into childcare and schools, specifically the tetanus vaccine and combination vaccines, which include tetanus. All of the infectious diseases currently listed under RSA 141C for which the department currently requires vaccination for children in childcare and schools are spread person to person, with the exception of tetanus. However, there is a conflict because the tetanus vaccine is not a standalone vaccine. Rather, it's a vaccine that is formulated in combination for other diseases like diphtheria and pertussis, which are also required immunizations under RSA 141C. Therefore, a child must receive a tetanus-containing vaccine to be immunized against diphtheria and pertussis, which sets up a conflict and a contraindication within the legislation. So should House Bill 1194 pass. So we believe that this legislation, if adopted, would prevent the department from requiring any vaccine that contains tetanus, including combination vaccines for some of these other important communicable diseases. So for that reason, we oppose any attempt to remove the department's authority to require tetanus vaccine, particularly if it jeopardizes requirements for other communicable diseases based on the currently available vaccine formulations. We also want to make the committee aware that during the 2018 legislative session, House Bill 1367 was proposed relative to removing tetanus from the law requiring certain immunization. And that proposed legislation at that time was determined by this committee to be inexpedient to legislate. So in summary, while it's true that tetanus is not transmitted person to person, we still recommend, for the reasons already highlighted, that all children and adults be appropriately immunized against this potentially deadly disease. And we oppose legislation that would limit the department's authority to require certain vaccines that are safe and highly effective at preventing the spread of disease and outbreaks in childcare and school settings. And with that, I will end our testimony and take any questions. Thank you.
I think that's exactly 3 minutes. That's excellent. You indicated on your pink card that you had written testimony you were going to submit. Is that correct?
Yes, and I thought we had already submitted that.
Oh, okay.
I think it has been submitted. And I'll just also point out that there's actually more information in that testimony specific to tetanus. It's an uncommon disease. We certainly highly recommend that people get vaccinated against it, because even with modern medical care, when people get tetanus, it can be, there's like a 10 to 20% fatality rate because of how severe the infection can be.
Okay, thank you. Dr. Tanian, did you want to say anything, or are you just here for backup, so to speak? Or
just here to assist if there's any questions. Thank you.
Okay. Are there any questions? Representative Weber.
So I'm wondering about the effect of the language of removing that one word and being left only with the person-to-person designation when it's, am I correct in thinking that that might be a problem because there are issues of transmission from animals to people or from less direct contacts than person to person through food or something like that, or hot tubs or other things? I mean, I know there's no vax for that, but.
Yeah, Representative Weber, thank you for that question. And you're absolutely right. Tetanus is a disease that's transmitted through the environment. You know, this is it's a toxin mediated disease where somebody can get infected from the environment with spores of this bacteria. The spores start germinating and reproducing in their body. It releases a toxin that causes the disease tetanus. So it's not transmitted person to person. It's an environmentally acquired disease. It's still an infectious disease, right? It's not transmitted person to person, but it is an infectious disease, and hence removing the word infectious disease or infectious from the definition would specifically target that vaccine.
A follow-up, sure.
And are there other routes of transmission, like through contact with an object or other ways of transmission that are not strictly speaking person to person, but through an intermediary of some kind?
So tetanus is not a disease that somebody gets and then passes along to somebody else through the environment through an intermediate mechanism. Right? This is a bacteria that's like in the soil. You know, the classic example is somebody steps on a rusty nail, for example, and that rusty nail's been in the environment. It, you know, punctures the skin, you know, contaminating somebody's, you know, body with the bacteria and the spores that then release the toxin into the body. But it's not like somebody has it and then passes it through the environment to somebody else. It's just a bacteria that's everywhere currently in our environment, and hence the need for a routine and periodic boosting with the tetanus vaccine.
Representative Murphy.
Thank you, Mr. Chairman, and thank you for taking the question. This a simple question, I guess, and I should know this, but the mortality rate for unvaccinated patient from tetanus?
I'm trying to think. So the vaccine is probably near 100% effective, right? So if somebody gets tetanus, it's almost always, I don't, nothing's ever 100%. It's almost always in somebody that's unvaccinated or is not up to date on their vaccination. And so when tetanus does occur, obviously there's supportive care that you can provide. But even with, that supportive care, 10 to 20% of people will still die from the disease.
Okay.
And it's a toxin-mediated disease, meaning somebody gets it, it causes convulsions, paralysis. The layperson's term is lockjaw because it causes such severe muscle spasms and convulsions that people can break their bones from the symptoms. So it's not a pretty disease. I'm impressed that you've seen a case of tetanus. It's not common anymore because of the vaccine, but it's not transmitted person to person.
Thank you.
Representative Palmer.
Thank you, Mr. Chair, and thank you for doing this one. The other things that come to mind would be this would get in the way of any kind of issues around vector-borne disease later on, because that's not person to person, but it might, now that there's a malaria vaccine, not that we have it here yet, but who knows?
Yeah, no, that's a great point. Thank you for that question. We certainly can't predict the future of what's coming with vaccines, but there are a number of other vaccines potentially out there in development. I think the question is going to be, and again, just going back to we only require a subset of vaccines for children entering school and childcare. And, there's a number of criteria that we often talk about. One is that the vaccine has to be highly effective. And second, it needs to be effective at preventing infection and preventing, outbreaks. And so, whether a vaccine would sort of meet that criteria, I think remains to be seen what the vaccine is. We've also talked in the past about how we don't require and don't plan to require vaccines like influenza vaccine or COVID-19 vaccine because these are recurring vaccines where you see efficacy drop off over time. And so what we're really looking for when we add a vaccine to the required list, which we haven't done in many years, it's really high efficacy preventing outbreaks and spread of disease in childcare and school settings. It just so happens that with tetanus, you can't get the tetanus vaccine without also getting vaccinated for some of these other highly communicable diseases, and that poses a problem with this current legislation.
Okay. Representative Cushman.
Thank you, Mr. Chairman. I just want to raise a question of the appropriateness of an employee of the executive branch coming here in his official capacity and supporting or opposing a bill and not just providing technical information. I believe that instructing the agents is a right for the people in Part 1. It's reserved to them. It's not a right given to government agents in place of the people. So I just see a little bit of a conflict here. I feel that they either should only be offering the technical advice without supporting or opposing if they're here on behalf of the state, and or be here as a private person and then they can support or oppose.
All right. Any reaction, gentlemen, or to that comment, or?
I guess I'll just say that, I think we've oftentimes taken, so there's a number of options. Certainly providing information is one option, but we have certainly, the department has, opposed and supported bills, even that also, impact our authorities. So that's, I think opposing this bill is not outside of the realm of the positions and the processes of the department in the past.
Okay, thank you. Other questions? Seeing none? Okay, thank you.
Thank you.
The last person I have signed up to testify on HB 1194 is Laura Condon from Bedford.
Good afternoon. My name is Laura Condon. I'm from Bedford, New Hampshire.
And I support this change in the definition because this is an error in the definition of non-communicable, and it warrants correction in statute. The committee should be aware that over 76% of the vaccines purchased and sold by the Department of Health and Human Services are on a voluntary use basis. This demonstrates that parents will actively choose vaccination for their children, even if it's not required by state statute. There is no expectation that people won't use the tetanus vaccine for their children. So that is a unsubstantiated concern. The requirements of vaccines are for products that contain risk. They are not risk-free products. And so because of that, they must only apply to diseases that can actually be spread from child to child. The intent of vaccination requirements are to prevent the spread of disease in the community, not specifically to protect one individual. If we were protecting one individual, we would be mandating that they wouldn't be allowed to eat the junk cereal and the donuts they're eating for breakfast. There are now over 70 doses of vaccines recommended for children from birth to age 18. No, that is not a misstatement. Over 70 doses of vaccines recommended for children from birth to age 18 by the CDC. There are dozens of more vaccines in the pipeline. There could be vaccines against obesity, and if we didn't have a proper definition in statute, those sort of vaccines could be required for children. To speak, because tetanus was raised, I wanted to add some comments about this because I was involved in prior legislation with regard to vaccination against tetanus. Tetanus is a bacteria that's ubiquitous. It's everywhere. It's probably here. It's probably on you. It's everywhere. It's extremely rare that anybody who comes in contact with tetanus, because we all do, may have an adverse illness outcome. In fact, if somebody is experiencing symptoms of tetanus, you actually can't test for tetanus. It's not like you can do, a bacterial culture and test for tetanus because tetanus is ubiquitous. It's everywhere. So it's actually a diagnosis of elimination. So they test the person, could it be this, could it be that, could it be this, could it be that? It's not. So they said, well, must be tetanus. In fact, if you look at the cases of tetanus in this country, it is only in the very elderly, those over age 60. They are chronically ill with severe illnesses, often already in some sort of medical institution. In spite of that, and there might be 24 cases a year, in spite of that, the mortality rate is extremely low. 99% of those chronically ill individuals survive their diagnosis of tetanus. And you'd think that, there would be much more outbreaks because the majority of adults actually are not current with tetanus recommendations. So for those reasons, I do believe that this bill is a necessary bill at this time, and I would be happy to take any questions.
Thank you. Any questions? Representative Cushman.
Thank you, Mr. Chairman. So in your view, is this just a correction of an incorrect definition? Because the definition of communicable, non-communicable.
Absolutely. It is, just an error that was made when, the definition of non-communicable was put in place. And it's a technical area that needs to be corrected to protect our children from vaccines that don't address a communicable problem.
Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. In your research and your data, do you see any contradiction to the statement that this tetanus vaccine is close to 100% effective? Could it be still true that it's 100% effective?
That the vaccination is 100% effective?
For tetanus. Yes.
For tetanus, I have not found evidence of that.
Other questions? Representative Nagel, you're acting like you. Well, we prefer questions. Okay. Any other questions? I'm seeing none. Thank you.
Thank you.
I have no one else to sign up to speak to HB 1194. Does anyone else wish to speak to HB 1194? On the blue sheet in the back, in terms of people expressing their position on this bill, 7 people signed up in favor and 2 people signed up against.
Mr. Chairman,
Yes, Representative Cushman.
do we know what the numbers on the online portal sign-in?
I do not know that, no.
That might be helpful for us to understand where, what the public opinion, if most have been the number.
And that may be continuing even beyond today. Certainly, especially for executive session, that might be something to be for us to be made aware of.
Thank you.
Yeah, there you go. Representative Palmer.
I think that might be helpful because the online testimony overwhelmingly the people did not list where they're from. And I'd like to know on the online, we'll see how many people in New Hampshire actually have an opinion one way or the other. So that.
Sure. Anything else on HB 1194? Seeing none, I'm going to close the public hearing on HB 1194. Next public hearing scheduled is not until 2 o'clock for HB 1213 FN. So we will be in recess for the next 20 minutes and reconvene at 2 o'clock. Good afternoon and welcome back to the House Committee on Health and Human Services and Elderly Affairs. The next bill we have to be considered today is House Bill 1213 FN. And I will recognize Representative Emily Phillips once again. We're seeing a lot of Representative Phillips today. We could have canceled today if it wasn't for you, you know.
I very much appreciate having everything scheduled on one day. Thank you, everyone. Good afternoon again. So I am on the the Special Committee for Childcare, and we have heard a ton of testimony that there is not enough supply of childcare providers in New Hampshire, that there's plenty of demand, and that they are overworked, underappreciated, and they have a lot of burden as far as paperwork. So this bill was written in a way to allow daycare workers to opt out of collecting vaccine information. We threw in the private schools too. We've heard overwhelmingly in the online portal, you'll see from daycare workers who support this bill because they're not trained to handle confidential medical information, and they feel like they're constantly chasing down parents whose children are due for vaccination or updated paperwork. As you know, our state has a great exemption program. So sometimes they're just getting the initial exemption from the child, but other times they're chasing people down. So it's not really a public health issue because some people have exemptions, some people are following the schedule. So we're just trying to relieve the paperwork burden for daycares and private schools, because who are we to tell private businesses what to do? So that's the gist of it. Questions?
Any questions? Seeing none, okay. Oh, Representative, HB 1213.
I do have a question.
Okay, sure.
Thank you, Mr. Chairman. Thanks for taking my question. I've become a stickler on definitions. So this is going to sound like a really weird question, but is there, I was looking to see if there's any definition of public school versus private school anywhere in statute, and I went through, I couldn't find one. And I'm just curious, given the complexity of education these days, if that's germane or...
A very good question. I don't know the answer to that. Maybe someone behind me can define it.
Thank you.
Thank you.
Okay. Also signed up to speak are Dr. Tanian and Dr. Chan from the Department of Health and Human Services.
Good afternoon again. I'm Dr. Ryan Tanian. I'm joined with Dr. Benjamin Chan, and we're here to speak about HB 1213. And the department at this time, we do oppose the bill as written. So this bill actually does more than minimize or reduce the reporting requirements, which I can talk to in a moment. But HB 1213 would also remove the requirement of the vaccines that are currently required in child care agencies and private schools, and it would be limited only to children who are attending public schools. So the department believes that this would unnecessarily place children, teachers, school staff, both at schools and child care agencies, public or private, at risk for infectious disease outbreaks. We believe it would also negatively impact the effect of the surrounding community. You know, for example, I can share with you right now, Philadelphia recently identified a measles outbreak in a child care center. And this was in December of 2013. And the Department of Public Health in Philadelphia is working with 3 area children's hospitals where patients may have been exposed, as well as other hospitals and an urgent care center to identify individuals who may be at risk. Additionally, there's just a growing number of measles outbreaks reported globally, as well as here in the United States. And these outbreaks not only put the health and safety of all children, regardless of what type of school or educational model they may be pursuing, but it puts everyone at risk. And when we do go to investigate and bring these investigations under control, they actually are quite costly. There was a study in 2020 that reviewed measles outbreaks from 2001 to 2018, and it was estimated one outbreak cost $152,308, and an individual case was approximately $38,000. And these costs were associated to the public health response, hospitalizations, investigations, and other things that go into bringing those outbreaks under control. And also, facilities would possibly have to voluntarily close if there's health risks due to their staff. It may also affect staffing ratios and other reasons for why a child care facility may need to close. So the department also believes that we already have a process in place that's important to protect all children across New Hampshire, and also allows for medical exemptions and religious exemptions. As far as the documentation and reporting requirements, the department does not collect or retain any individual student or patient information that is managed at the school level. What the department does do is look at aggregate raw data about the number of students in childcare and school settings who are considered up to date or may be exempt from a vaccination. And it also helps our folks at Public Health work with school programs to work on any sort of process improvement or quality initiatives. And I can share a recent example where there was a school that had had reported a odd-looking number of exemptions. We had a conversation with the school nurse, and it was a new school nurse. It was their first year working, and they were actually reporting the information incorrectly. So we were able to work with them after reviewing some of the information and make sure that what they're reporting is accurate. And then lastly, we believe that all New Hampshire children should have an equal opportunity to attend school or childcare in a healthy and safe environment. And we believe that there's already proper measures in place to protect against these diseases. I want to thank you for the opportunity today, and we're happy to answer any questions you may have.
Okay. Any questions? Yeah, Representative Murphy.
Thank you, Mr. Chairman. Just a technical, it says on the card that you have submitted testimony, and I believe you did that.
Yes, that's correct.
I'm trying to find it. I was just wondering, when you get back, could you send that out again, perhaps, that testimony? If you're going to do that, even 1194, because I'd just like to get both copies if I could.
Absolutely.
Thank you so much.
Representative Nagel.
Thank you, Mr. Chairman. Thanks for taking my question. I want to make sure I'm understanding this bill properly. As I read it, the children are still required to have these immunizations. What no longer would exist if this bill takes place is that the child care agency or the private school would have to maintain the records and demonstrate that they've had those. So in other words, if I start there, I don't have to bring a record that I've had this immunization. Am I reading that bill wrong?
So what I will say, the interpretation that the department had on this bill, there's three pieces to this, where one, it is now removing the requirement for children who are attending childcare or private schools would no longer be required to have vaccinations. The second point is the department would not have the ability to review any sort of immunization records at the school. And lastly, only public schools would be required to report the aggregate data to the state.
Can I follow up?
Follow up.
As I see, it says the requirement to have the immunization is line 1 of the statute. But that doesn't seem to be removed. It's only the changes in line 2. So according to what I'm reading, they still have to get the immunization. The agency or the school doesn't have to. Right, correct.
Right. So thank you again for this question. But as we reviewed it at the department, we interpret this as the immunization requirements in 141C20A would no longer be required for children in child care or private schools.
You all set? Okay. Representative Cushman.
Thank you, Mr. Chairman, and thank you for making that statement. If that's your reading, that the documentation requirement of this law, it requires either then immunization records or an exemption, is that correct?
I'm sorry, could you state the question again?
So the department's interpretation of the law is that if this bill were to pass, that there would no longer be a requirement for private schools and daycare agencies to ensure that children have been vaccinated according to this RSA.
That is correct.
So then does it also follow that it's the position of the department that agencies also must accept exemptions, since this statute says that they have to keep either the record or the record of an exemption?
So the exemptions, whether it's a record of immunization or an exemption, the department does not collect that information. That's maintained at the school or the child care agency.
Right. But you're saying that the statute requires the kids to be vaccinated to go to the daycare or the private school. It says immunization or exemption or partial immunization. So all three of those, one of those three is required for a child to go to a daycare or a school in New Hampshire per this RSA. That's how the department is reading it.
As currently written or what's being proposed?
As currently written.
Yeah, so as currently written, RSA 141C20A, children attending childcare, public or private schools either require documentation of the immunization or an exemption.
Thank you. Can I ask one more follow-up?
One follow-up, one more.
Okay, so if this bill passed, then it would remove a requirement for children to be either vaccinated and show proof of that. And it would also remove the requirement for daycares then to accept exemptions.
I would have to look into this in more detail to answer the question about accepting the exemptions, but our initial interpretation is the immunization requirements would only apply to children attending public schools.
Thank you.
Yes. Does that answer your question?
Thank you. Yes.
Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. Is my understanding correct that state and specifically DHHS are in business of providing, selling some of those vaccines? And if so, like, let's say the worst case scenario that all private schools and daycare centers would stop, those kids stop purchasing and using those vaccines, what would be financial implications for DHHS and otherwise? Can you elaborate?
Yes, thank you for the question. So the state does not sell vaccines, and vaccinations are actually conducted at the child's pediatrician's office or family care provider. Is any clinics that may be conducted at a school, particularly the school-based influenza clinics, are conducted through either partnerships with healthcare systems or the regional public health networks. So aside from a transactional aspect to purchase and selling vaccines, there would be no impact, but we believe that there would be a financial impact potentially to child cares or private schools that may have to close due to a disease outbreak or increased healthcare costs due to increased children contracting infectious diseases that are prevented by vaccines.
Any other questions? Seeing none. Okay, thank you, gentlemen. Also signed up to speak is Representative Rossberry.
Thank you, Mr. Chairman. My name is Representative Rossberry. I'm also the chair of the House Special Committee on Childcare. So this was one of the things that came forward. As you guys know, we've been working on ways to increase access to childcare and decrease the cost of childcare while maintaining quality childcare. So this was one of the things that has come up in our time is childcare centers have a lot of paperwork burden. a ton of paperwork burden. I believe 3 other childcare centers have written into the committee supporting this bill. This bill, I know that there's going to be a tendency for this bill to try to get caught up in the vaccine, not vaccine debate. So let me start off with, I am vaccinated, my child is vaccinated, my wife is vaccinated. I'm not anti-vax. I have, what you do with your body is in fact your choice. But what happens is you guys, the state has turned childcare centers into this kind of faux reporting agency on vaccines. The irony being is we have a religious exemption waiver. So any health argument that might be made is kind of moot, because I could have all 65 of my children that are under my care sign a religious exemption waiver, and that would be perfectly compliant. So what happens is childcare centers have to maintain these immunization records. We get asked for them. It's a recurring thing that we constantly have to update. And we're already, that's not why anybody got in the childcare industry, was to track these medical records. One of the things that I wanted to flag is there has been kind of quiet concerns about HIPAA violations, because while HIPAA doesn't cover child care centers specifically, you look at kind of like what's covered it, we do have medical procedures that are performed in a child care center. DCYF might come in and perform a mental exam from a child they're investigating. All of my teachers are, we can give EpiPens, we can do those things. The claim has never been made, but I am terrified that one day it will be made and it could be extended to us. And a problem with that is we are in no way HIPAA compliant. You are forcing parents to turn over private medical information to us that we do not have to hold in a standard that a medical center would hold. So I do worry about kind of the liability of that in the long run if that claim is ever made, because while it wouldn't be a direct jump to that, I do think that a sleuthing person using the law could actually connect the two, given the other services that get provided at child care centers outside of kind of what you would normally think of. But I do believe that this would reduce the burden. It would reduce paperwork violations. What happens is when DHHS issues a violation, we have to post it prominently in our center. Most parents either don't look at it or really look at it. There's kind of 2 parents, the ones that are really like, oh my God, what is this? And the ones who don't notice it's there. And then we have to start explaining about, if you miss one child, right, you can get written up for that by DHHS, and then you have to post it publicly until they inspect you again. So these sort of things, they do add up. It's one of the deals of it was one of those things, and you can kind of see it happening, right? It's like, all right, well, we're just going to add this, and we're going to add this, and we're going to add this. So one of the things we're trying to do in the Child Care Committee, Special Committee on Child Care, is remove those things that have been added over time. So I'm happy to answer any questions about this. I will say DHHS came up here and said there'd be a fiscal impact on childcare centers if we took away this requirement. My personal belief in dealing with parents and children is that the overwhelming vast majority of parents are going to get their children immunized because they believe it is the right thing to do. I don't think the state requiring it to attend, the state doesn't even require it because you can sign the waiver, but I don't think the state having it on there, I don't think that's a valid, I don't think that's a valid argument. Just to be blunt, there's illnesses go through childcare centers on a regular basis. It's not because a childcare center is dirty. Like at my childcare center, we disinfect every night, and then we do a deep clean every Thursday, and we still have stuff gets through there because kids are kids. They get dirty and they have weaker immune, so they have newer immune systems that don't have everything yet. So we're kind of used to dealing with that on that front. So I wouldn't put a whole lot of weight to that. I haven't met a single child care center owner that has said, oh, we have to have these immunization records, otherwise we'll be shutting down because there's going to be a measles outbreak. It just bluntly sounds a little far-fetched to me. But anyways, I'm happy to answer any questions. Like I said, I own a child care center over in Epsom, New Hampshire. That's where I just came from. That's why I look like this. But I'm happy to answer any questions from the business side of it.
Representative Parma, you had a question, or?
Yeah, well, my question is really, and Representative Phillips sort of said when we threw in private schools, and I'm sort of I've got two questions about the private school thing. Is one, well, why? I mean, there are small private schools, and my kids actually went to a little one, and I was one of the people who helped collect the data because there wasn't a staff member to do that. So that would fall into sort of the same boat that you're talking about lack of resources. But I doubt St. Paul's has that problem. And the second part of my question is, so people send their kids to St. Paul's from all over the place, and there are a bunch of other big private schools in New Hampshire that have kids from everywhere. And I would imagine the parents of a lot of those kids are sort of expecting that the school is keeping track of that, because there's no way the state could keep track of somebody who's coming from California to go to school there. So I guess I'm a little bit leery about putting the private schools into this boat along with the daycare centers.
I mean, I don't know what the question is there. I don't work in the private school space. I can't say dealing with parents. They're usually more generally surprised that we ask for that. But I can't speak for private schools. I don't work inside of a private school setting. I work inside of a childcare setting.
I guess maybe I'll put the question the other way. Then would you mind having this bill amended to take private schools out of it?
I mean, if that makes it more likely to pass, that would be my statement. If it makes it more likely for the bill to be successful, then sure. My philosophical answer would be leave them in. But if it makes it, politics is not a dictatorship. So trust me, I have to make deals all the time in election law that I don't always love. So.
Other questions? Seeing none. Oh, Representative Cushman.
Thank you, Mr. Chairman. Thank you, Representative. Being that you run a child care center, is it your understanding of the law that the law says that children have to have, is it your understanding that you have to honor exemptions if you receive them as a part of that law? You have to honor either an exemption or a vaccination, and that you can't discriminate, you can't keep kids out?
Correct. And there was, I believe in the written testimony, the answer to your question is yes. I believe in one of the written testimonies you received from one of the other child care centers. We don't check into whether or not there is I can't carefully use a legitimate religious exemption, right? We don't put them up to some sort of religious litmus test, nor would we, by the way. It would be grossly inappropriate to do that. We just take them on their word. I would be stunned if there weren't parents who just signed that form just to avoid having to either turn that information over or go get it from their child's PCP. It is definitely a catch-all, and I don't see a way in which you could legitimately enforce it, because how are you to determine what somebody's true religious beliefs are, especially a child care center employee?
Representative Shapiro.
Thank you, Mr. Chairman. So if you share my assumption, which maybe you don't, that tracking vaccinations through public schools, private schools, daycares, overall improves compliance and the numbers of people who get vaccines, if you share that assumption, but it's such a problem with workforce and tedious bureaucratic work that daycare centers have to do, can you think of another alternative to kind of track vaccinations in a way that would encourage people getting them and encouraging public health, basically?
I think you need to let people be people and make the decisions that are best for them, right? I'll give you an example for myself. Every single year I go to the doctor, and every single year I get a flu shot. Every single year I go to the doctor, and every single year I get a pneumonia shot. Why? Because I've had pneumonia 3 times, been in the hospital for it. People should be able, I believe that most people believe that vaccines keep them healthy. That's their business. I am not a doctor. I'm not here to tell them it is or is not. I personally believe that it is. That's why I put them in my body. There are certain vaccines I haven't put in my body because I question it. I don't think that using childcare centers as an arm of the government to encourage people to get vaccines is appropriate. I think what would be more appropriate would be a public health campaign, or going to the doctors directly, and maybe having anonymous aggregated data from the doctors who are the ones actually administering the shots. I think that would be more appropriate than using childcare centers as a reporting agency of DHHS.
Other questions? Seeing none. Okay, thank you. Also signed up to speak is Henry Vayu from representing the YMCA Alliance of Northern New England. Are you sitting in for Mr. Bayou?
No, he was unable to make the hearing due to a conflict, but he wanted to just share some written testimony. So I'm just
Okay.
going to pass that out.
Sure, thank you. You won't be speaking for him then, I take it. You're just passing out the test. Okay, thank you. Also signed up to speak is Jesse Davis, representing the Department of Health and Human Services.
I am Jessie Davis, and I am the Bureau Chief of Child Development and Head Start Collaboration, and I am the Child Care Development Fund Administrator for the state of New Hampshire.
Yeah, you indicated 5 minutes on your card. If you could
Yes.
keep it closer to 3, I'd appreciate it.
That's fine. So we have federal reporting requirements for the scholarship program, and we currently have 603 childcare programs out of roughly 700 who receive scholarship dollars for their programs. And this would put us out of federal regulation requirements for those families who need these services.
Oh, that's it?
Yes.
No, that was quick. Any questions? Representative Cushman.
Thank you, Mr. Chairman, and thank you for being here. Can you explain what the requirement is? Is it something that you could give to participants who wish to obtain those funds on a voluntary basis?
So if you receive scholarship dollars as a child care provider, you do have to maintain records of either being immunized or having an exemption on file. When you become licensed, we go out and we review to ensure that you are in compliance with that federal requirement. Does that answer your question? I'm sorry.
It sounds like they could do it voluntarily from what you just said. Is that correct?
Yes, absolutely. As long as this bill is written in a way that doesn't exclude these programs from having to meet that federal requirement.
Representative Leon.
Thank you, Mr. Chairman, and thank you for being here. Reading this, it says that it doesn't have anything that prohibits the child care agencies or the private schools from keeping those records. It simply removes the shall, the requirement that they keep them, and the requirement that they keep them available for inspection. Without any language prohibiting them from keeping these records, if they're able to access federal funds, would that resolve your objection?
I'm neutral. I'm sharing information. So I'm not opposed or for this bill. I'm just simply sharing what the federal requirements are for these programs.
Sorry. And then as the follow-up, so you don't see anything that would prohibit them from keeping these records in this bill as written?
Correct.
Thank you.
Representative Shapiro.
Thank you, Mr. Chairman. I'm a little confused. So you administer scholarships, which includes federal money and comes under federal regulations, to individuals or
So-
to child care centers?
Families are eligible for scholarship dollars. In order for a child care program to receive those monies for those families to subsidize their care, they have to meet federal requirements, which requires them to have immunization records or exemptions on file.
Follow up. So we're not talking about the individuals who apply for the scholarships. We're really referring to any child care setting that accepts those federal scholarships to keep track of all their students' vaccination records.
Absolutely, yes.
Thank you.
Other questions? Okay, I'm seeing none. Thank you.
Thank you.
Also signed up to speak is Kate Frey from New Futures. Again, ma'am, you indicated 5 minutes. If you could keep it closer to 3, that'd be great. Thank you.
I can probably do it even less than that. Good afternoon, Chair and members of the committee. My name is Kate Frey. I'm Vice President of Advocacy from New Futures. A lot of my points were said before, but we do oppose HB 1213, both from a public health point of view and the impact it could have to child care programs. We really view this as a way to weaken the New Hampshire childhood immunization program. We have a very strong program that offers access to all New Hampshire children free of charge through a very collaborative effort with federal funds, general funds, and the insurance companies. We've in the past had very high rates. We've seen rates drop because of the pandemic, like many states have. And the concern about this bill is there's just one more way to have less, see those vaccination rates drop more. If we see more of those rates drop, we will open the door to previously eradicated diseases. I have a lot more detail in my testimony, but we are especially concerned about the piece about child care and the adherence to federal block grant requirements. We understand that it would require the programs to collect the vaccination data. If the program stops collecting the data, how will they know, how will they be able to report it? They will not be eligible to participate in these child care scholarships. And I just want to make a note that the child care crisis in New Hampshire, as we know, has worsened since COVID. In 2023, New Futures championed the Child Care for New Hampshire Working Families Act, which modernized the New Hampshire child care scholarship programs, got $60.5 million in the budget to ensure that families qualify for scholarships. So if HB 1213 passes, we would be concerned to be taking a step back from the progress achieved in really improving childcare access in this state. With that said, we would oppose House Bill 1213. We ask you to vote inexpedient to legislate.
Thank you. Questions? Representative Leon.
Thank you, Mr. Chairman, and thank you. It's good to see you again here.
Nice to see you.
I may have missed this when I was trying to listen to your testimony. Did you just say that we're spending $60 million so that we can receive federal grants for childcare, or did I miss one of the details in that?
So we have additional general funds so we can leverage further federal funds to expand child care scholarship programs to reduce the rates for families for childcare. So this is what one of the accomplishments we were able to make in the budget to really improve access to childcare in the state. So our concern with this bill is one of the requirements is to collect vaccination rates. If we're not collecting vaccination rates, that will put the federal funds at jeopardy.
Thank you, sorry. And as a follow-up, could you provide the other federal requirements that are coming from that money? Because I just want to make sure that we're balancing these needs. And do you see anywhere in here that prohibits the child care agencies from still collecting these records?
I guess my concern is while I explicitly don't see it, I don't see anything that, how will they know what their rates are if they don't collect this information? And how will we know that's accurate information if there's nothing in the statute that dictates they do so? I guess they can collect it voluntarily, but the concern would be, whether that information is accurate. And then we also lose the public health reasons why that information is important to collect, as the department had said earlier regarding outbreaks.
Representative Shapiro.
Thank you, Mr. Chairman, and thank you for taking this question. I really missed my opportunity when the person from the department was testifying, but you're smart, so maybe you know. Do you know what percentage of daycare centers accept these scholarships?
I don't off the top of my head because I'm not the child care agency or child care expert at New Futures, but I can get that information to you.
And
follow up.
And do home daycares take these as well?
I believe home daycares, but I would defer to the department on that. I will say that many of the child care providers we work with are in opposition to this bill because they are concerned how it will impact their scholarships.
Okay, thank you.
Other questions? Representative Nagel.
Thank you, Mr. Chairman. Thank you for taking my question. And again, as Representative Shapiro had just said, you're sitting in the wrong place at the wrong time, so I'll address this to you. I'm a boots on the ground doctor, but I've also been involved in policy development at the local, regional, national levels. And what's driving me crazy in looking at bills over and over and over again is everything is just another form. It's just one more form. And I understand the need for data, but the problem is that data adversely affects our ability to do our job. And I think that's what's driving this bill. And we deal with a thing that used to be called meaningful use in medicine that's now called managing interoperability or something. It's really adversely affecting our ability to do our job. And we need to find better strategies on how to satisfy your needs to collect data and our needs to do our job for the people that we care for. And I'm just curious if you have any thought, if number one, do you understand that? And number two is, do you have any creative strategies that can help solve that dilemma, especially for small providers and small schools?
So again, I'm not, thank you for the question. I'm not a child care expert, but I will say that this information has been collected for some time. We have not, I think through our circle of providers, have heard concerns about it. It's what's been collected. I do think the idea behind expanding the scholarship programs and the money going to child care agencies hopefully can offer to offset some of those costs in some way if there's an easier way to do it. But I do, at the end of the day, really believe that that public health information is really important to run a child care business.
Other questions? Oh, Representative Mazur.
Thank you, Mr. Chair. Thank you for taking my question. So we've heard it before, but again, I'm just clarifying, in your opinion, does this bill prevent child care agencies from collecting this data? Does it prevent them?
I mean, it says here that such records, public schools and child care agencies shall make it prohibits them from making an annual report. I guess if they're not making an annual report, are they collecting that information? I think it just makes it unclear. I would have concerns about that. And how can they report to regarding the federal dollars if they don't have that accurate information?
Follow up.
Follow up.
Thank you. You also, we also talked before, you said about, skewing the data if it's not collected. But there could be a lot of medical exemptions existing with all of these different childcare industries that are currently collecting this information that are actually skewing the data. So how would this change?
Yeah, my understanding about exemption rates are that they're pretty low in this state. I defer to the department on that, so I'm not sure how much that would skew.
Yeah, I would like actual data on that as well. So thank you.
Thank you.
Other questions? I'm seeing none. Thank you. Ma'am, did you submit some written testimony earlier? Have we already gotten that, or? Yeah. Oh, okay. All right, great. Yeah, we saw it on the pink card, but I couldn't remember if we had gotten it already or not. Okay. Also signed up to speak is Laura Condon from Bedford. And I know you have some written testimony also, right?
No, you turned it off. Yeah, if you want the red, you need the red light to be
Okay,
on.
you can hear me now? Okay, thank you. Good afternoon. My name is Laura Condon. For those wondering where we live, I'm from Bedford, New Hampshire. Yes, I'm a New Hampshire resident. I'm a volunteer New Hampshire Director of Advocacy with the National Vaccine Information Center. I'm here to testify in support of House Bill 1213. Please take note that the analysis statement for this bill is not correct. This bill makes no vaccination requirements for public school children, nor does it change any of the vaccination requirements, nor does it remove any requirements. What this bill actually does is remove certain reporting burdens on private schools and daycares, and it also provides important privacy protections that align with privacy protections relative to vaccination elsewhere in state statute and rules. I wish to point out the separate immunization requirement provision, the enforcement provision, and the exemption provisions in state statute. And you touched on it, Representative Nagel, earlier. You are correct. There is the immunization requirement provision, that's RSA 141C20A, Roman numeral 1. And let me read that one for you. It requires that, and I quote, all parents or legal guardians shall have their children who are residing in this state immunized against certain diseases. These diseases shall include, but not be limited to, diphtheria, mumps, pertussis, poliomyelitis, rubella, rubella, and tetanus. The commissioner shall adopt rules under RSA 541A relative to other diseases which shall require immunization, period. That's the end. Then there is the enforcement provision in state statute, which is RSA 141C22A, Roman numeral 2, and that's in this bill, so I won't read it for you. But I want you to note that this provision, the enforcement provision, is using schools and daycare agencies as the enforcement mechanism for the very broad immunization requirement I just read. Please do not confuse the broad requirement with the limited enforcement mechanism. Then there is the separate provision, the exemption provision, that's RSA 141C20C exemptions. And that provides two exemptions. One is a medical exemption I will not read. You can refer to that. And the other one, Roman numeral 2, a parent or legal guardian objects to immunization because of religious beliefs. The parent or legal guardian shall sign a form stating that the child has not been immunized because of religious beliefs. Period. I want you to note this exemption provision is a separate section of RSA 141C20 and is broadly stated. There is nothing in this provision that ties it to schools or daycares. It applies to all children in the state, whether they're in a public school, a private school, a daycare, and no school or daycare, wherever there is an attempt at the immunization enforcement provision. It is a very broad protection. Some additional considerations in this bill is that there's concern if a daycare school is not an enforcer that they won't accept all exemptions provided in statute and may deny entry. Again, these exemptions apply to all children in the state regardless of where they are situated. It would be unwise for any private business to deny access based on a parent's use of a statutory vaccination exemption, as it would put the school or business at great risk of civil rights action against the organization. Parents in the state of Mississippi won a religious exemption this past year when a federal court ruled that the state cannot afford a secular exemption, which is the medical, without affording a religious exemption because doing so violated the First Amendment. Finally, there are other good provisions in this bill. It would protect individual students from the prying eyes of state government. This provision protects individuals from having their private individual immunization records viewed and perhaps copied by DHHS. This aligns with the privacy protections relative to the vaccination registry. The government is not authorized to view or maintain individual vaccination records without specific individual written consent. I dare say that any parent who submits their vaccination records to the daycare is under no impression that DHHS will be marching in and looking at those records. I hope this bill will have your full support. I'm happy to take any questions.
Thank you. Representative Nagel.
Thank you, Mr. Chairman. Thanks for taking my question. I just have a question that you may or may not know the answer to. When the data is reported, and I know there's rules that had to be developed, is the data reported electronically, by paper? Is there a requirement of any kind on how it has to be reported?
I don't know how it's reported, if it's paper or electronic, but the bill is, and the privacy protection it's removing is the provision, it's on line 10 of the bill, such records shall be available for inspection during reasonable hours upon request by the commissioner's designee, which certainly indicates that they could go in there and look at individual records.
Are you all set, Representative Nagel, or? Yeah. Okay.
Thank you for the question.
Any other questions? Seeing none? Okay, thank you.
Thank you.
No one else has signed up to testify on HB 1213 FN? Yes. Nope. Just before the gavel. Thank you, Representative Penza. Okay, Representative Kelly Potenza is recognized.
Sorry about that. I was holding on to it. So Representative Kelly Potenza, Stratford District 19, just speaking in support of this bill. I don't have too much to say except for I want to speak on the private school aspect to kind of answer Representative Palmer's question. So my kids have attended private school for, gosh, 10 years now. So, at least that, right? So in all the schools that they've attended, you have to provide, an updated physical. And so my children were, of course, patients for Dartmouth Hitchcock. And so automatically on their physical form, it automatically attaches the immunization records. The school that they're currently at, this just kind of speaks to the privacy issue. And my daughter was able to log in to see all her, her medical records right there, but it wasn't really locked down because they have an electronic portal. So that was a little concerning to me. More so, it's automatically the immunization records are attached to her current physical. So that's usually happening, and I can't see that being different for pretty most of the parents that are submitting information. So, and I also believe that this bill, like it says, it's not stopping it, prohibiting it as well. So it's making it an option. In private businesses need to be, I think, private businesses. It's different than the public. And then in regards with the scholarship piece, which was interesting, if they need that information to be able to get a scholarship, why wouldn't they just be able to get that from the families that are applying for those scholarship funds directly? Why would that have to be provided to by a daycare center or another entity like that? And then in regards to a question that was asked by Representative Paulov, it talks about DHS and that they don't purchase vaccines. So let's just be clear. DHHS purchases vaccines from the CDC. So this year alone, DHHS will ask for over $25 million to be paid to them through the Vaccine Association to pay for these vaccines. So I just wanted to be clear about that. But I fully support this bill, and I hope you will too.
Any questions? Seeing none, thank you. Okay, I know of no one else planning to testify. I have no other pink cards. No one else has signed up. The blue sheet in the back where you can sign up just to indicate your opinion one way or the other if you're not speaking has 7 in favor, 2 opposed, and 1 neutral party. And online, what did we have online?
Online, we had 74 supporting and 69 opposing when I pulled it up earlier.
Thank you. Okay, it is now a little past 2:45, so I'm going to close the public hearing on HB 1213 FN and open the public hearing on HB 1661 FN and recognize the prime sponsor, Representative Gearhart. There he is. And we need a pink card, Representative. Oh, you've got one. Okay, good. All set. Sure. 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 Is that Mr. Bodwin or Representative Gearhart? Representative Gearhart is, you're talking about John Bodwin, Senior? Yeah, okay, great. Thank you.
Good afternoon, committee. I'm being joined with John Bodwin. I'm Jason Gearhart, Northfield, Franklin, Merrimack, 25. John Bodwin is a knowledgeable individual on this bill. He helped write most of it. This is relative to immunization reporting requirements, and this bill requires death certificates to record certain information regarding immunizations received by the descendant. The bill also establishes certain reporting requirements for the Department of Health and Human Services regarding death records and immunizations. I'd like to hand it off to John for the time being, and we'll just switch back and forth. But he has a handout that was passed around that if you'd like to address and take it on. Thank you.
Thank you very much. Thanks for having me, guys. Appreciate being here. So this bill is unique in the entire country. What it's doing is allowing the people access to the data that belongs to the people, which is the health of the state. So I'm just going to start going through the handout a little bit because it'll lend some structure to how you perceive the data. There was an estimate of $160,000 that was done by New Hampshire with regard to this bill. It doesn't seem as though they looked at the other column where it would save probably more than $1 million a year for the state. Can't really talk about that in a short time here, so anybody is welcome to contact me and I can go through any financial analysis and also point out the flaws in the 160K. So HB 1661 would be a net budget reduction for the Department of Public Health. It would save lives. That's the most important thing. Save New Hampshire lives and provide a better functioning Department of Public Health and keep them on mission, which is for the health and safety of New Hampshire citizens. Without the bill, the truth remains hidden from the people. Public confidence in DPH will wane as more people die, which has been happening. And people prescribed medicines that were recommended by the government, and I don't mean New Hampshire, not necessarily, people who rely on the CDC and FDA for what is safe and effective, they've been let down. Many have been let down. So let's talk about one specific cause. It's the code is D68, but these are other clotting defects. What you have here on this page, these are New Hampshire residents who died in Massachusetts. I have all the Massachusetts death records. It would be illegal for me to have New Hampshire records of the same type, but I have these legally from Massachusetts. And of ceteris paribus, all other things being equal, you see the bar of 2021 being very high when it comes to clot defects. And one gentleman, Martin from Somersworth, he was 47 years old, died with multi-organ failure, stroke, hypercoagulability. That's hyperclotting. All of a sudden, the guy started hyperclotting, all in days. He did not have a history of this. Cardiac amyloidosis, which is a known condition from COVID gene therapy injections. It's known to happen. So I don't know when he got his vaccine. This could be correlated, and we don't have to let private information out. What this bill does is it makes sure that the public knows the correlation of the immunizations to the health outcomes, which the people should know and have a right to know. With anemias, there's thrombocytopenia, inability to clot, leukopenia, neutropenia. The example here is febrile neutropenia in hours. Acute myeloid leukemia, AML, that's also a signal that's been growing very strong since COVID immunizations. And you see that 21 and 22 are also very high for New Hampshire residents who died in Massachusetts hospitals, only, again, 21 and 22. This is sudden kidney failure. It's also called acute renal failure. This is probably the biggest epidemic of single deaths since 1918, 1919, and nobody's talking about it. The CDC knows this. They have to know this. 100,000 excess Americans died involving acute renal failure in 21 and 22, and very many in 2023. And the exact time that it started happening was 2 weeks after November 2nd, which is cms.gov, where the NCTAP, which is the incentive, 20% of the entire hospital bill gets paid from the federal government. They get a bonus. The hospitals get a bonus. The doctors get a bonus for using remdesivir, baricitinib, and other medicines. That's a big one. So Joseph was 30 years old, multi-system organ failure in 9 days, pneumonia, flu, Staphylococcus aureus, and sudden kidney failure. He was from Franklin, New Hampshire. Clots in the brain that cause strokes. You see that 2022 is almost double. Actually, it's almost triple some of the other years. Jeffrey was 53 years old, died from a stroke in days, hypercoagulable in months. Again, very hyperclotting. Intraventricular hemorrhage. And then Elaine was 61 years old. She died from a cerebral herniation, another kind of stroke, multifocal cerebral infarcts, and a bonus of an aortic dissection. Her aorta blew apart. Those are also very high since the vaccine, if you want to call it a vaccine. And lastly, for these, this set is clots in lungs. In Massachusetts, there's more than 500 excess pulmonary embolism deaths in 21 and 22 alone. 500. And I've correlated many of them with knowledge of their vaccination dates. Now in New Hampshire, you see that 2021 is very high. Lindsay was only 27 years old, from Newton, New Hampshire, died August 4th, pulmonary thromboemboly and deep vein thrombosis. Those are usually in the calf, and they call it throwing a clot, right? It breaks off, it travels to your lung, and then you can die, and she did. I don't know her vaccination date, but this bill would force that analysis to be done, and that analysis is not being done by any government at this time. Why? It's purposeful inaction, omission of conduct where there's a legal duty to act, and they should be doing this. So this public oversight in this bill would be the best in the nation. Also, Jeffrey was 30 years old from Epping, New Hampshire, cardiogenic shock. It says massive pulmonary embolism in 6 hours. He also had brain cancer in 8 months, another signal known from the vaccine. And Amy was 40 years old, disseminated intravascular coagulation all through her body, coagulating clots all through her body, and a pulmonary embolism and DVT. Now, I do write I write a Substack probably 2 or 3 times a month, so I'm a journalist. As a journalist and a member of the press, people approach me with information from official sources, and I won't divulge it if I don't think it's real, but if I check it out, yeah, I will. So I'm going to share some here today. This information regarding the health of the people of New Hampshire should not have to have been acquired as I've done. The data belongs to the people, not the government. The government is of the people. Here are some facts people would have known if Bill 1661 was in place years ago. At least 87 people. When I say at least, it's because the data I have is only a subset of people from New Hampshire, a small subset. 87 people died in New Hampshire within 3 days of COVID immunization. At least 50 died within 2 days of immunization, New Hampshire. 24 died on the day of or the day after immunization. The next 11 people died on the same day, New Hampshire, of immunization. Rodney Lucas was 62, Barbara Jenkins 68, Amy Thomas 72, Daniel Cheney was 76, Ann Kasich 77, Louise Fontaine 81, Marguerite Timlage 83, Roger Pinchard 83, Catherine Downs 84, Sheila Green 85,
Sorry,
Edward
could
Mayo
you
93.
just give the ages and not the names since you have last names there for privacy?
Okay, sorry, I finished actually. And that is the problem in that, do we want to keep secret from the people things that are killing the people? I mean, the point is the health and safety of the public. And so, they all died on the same day of immunization. And I'll skip the last name for the others. But so Anna Tucker was 26 years old. Anna died 1 day after immunization. Her obituary says passed away peacefully in her sleep. The first name's going to give this guy away. Stoshu. It's a unique name. 35 years old, died on Christmas Eve, 2 days after immunization, unexpectedly. Robert died March 19, 2022, 4 days after immunization. Of matching VAERS report 2201082 report mentions cardiomyopathy because they gave an immunization to a guy with a heart transplant in 2017. Why would you give somebody a medicine for a heart? He had a heart transplant. He also had a bone marrow transplant in 2021. And if you remember, I mentioned AML earlier. He also had acute myeloblastic leukemia. Now, I know from the Massachusetts data and the Minnesota data, I have 1 million death certificates, unredacted. Probably the only one in the world outside government. And if you haven't seen my analyses, I can send you a copy. I have 2 books coming out within 3 weeks. So because the government refuses to look at this data and hides the data from the people, very few of us know that AML is common from this vaccine. So is lymphoma. And all the blood causes on the trifold that I went through a moment ago, all pretty common from the COVID vaccines. It's not down party lines. You shouldn't have an orthodoxy one way or the other. I don't care. The reason I looked into this is because I lost my son and I wasn't doing anything else and I'm depressed. And so I just want to save kids. The adults can take it because do your homework. If you haven't looked into what this actually is and the defects in manufacturing that Kevin McKernan found, and if you don't know what I'm talking about, you should really look into that. So I don't know how many lawyers are here, but manufacturing defect is a strict liability standard. very easy to determine. They didn't meet their own specifications, and they shipped the product anyway. So the product has DNA contamination in the form of plasmids. And I'm not a scientist, so I won't go into that in detail. But the point is they're shipping contaminated product to the public. And nobody's saying anything. The government's just saying, take it, take it. So this bill, 1661, I'm just going to close by saying, it just gives transparency to the people. And it doesn't matter what side you're on. If you believe vaccines are safe and effective, great. This will prove it. This will prove it. It'll prove them safe and effective, or it'll prove them not safe and effective. And when I say them, some of them are going to be good, some of them are going to be bad, because it also has to do with all medicaments, not just vaccines. So if remdesivir is good or bad, we'll find out. If it's a combination of, why aren't they looking at remdesivir in combination with vancomycin? That's a very strong antibiotic given kind of in the end as people go septic. But I guess I'll just thank you very much for your time. I hope this impressed something on you. And if you have any questions, please ask me, because this is so important.
Representative Gearhart, do you have anything to add, or are you just?
I was just going along for the ride. No, I was hoping John would talk briefly about the last part, the audits. I think that's key. Transparency is the mission here, because there's been, I don't know what the right word would be, but there's been a drop in people getting vaccinations because of fear and concern and so forth. So the best way to bring back trust is to show the truth, and this is part of it. So if you want to speak briefly about that, just explain the independent nature of it.
The section 1, it requires that the vaccine dates, immunization, any immunizations given within the last 2 years prior to dying be put on the death certificate. It's a nominal, less than 5-minute thing that any medical examiner or doctor can do. The analysis of the $160,000 was grossly exaggerated, because all you really have to do is look for the number of unique names in the death certificate database in New Hampshire, and only those people would have to be trained. Let me skip to the last. It also forces the Department of Public Health to do quarterly reports, which would take maybe, I don't know, 15 minutes to 30 minutes, and they just put out a quarterly report. It's just, you write some scripts and you correlate two databases, the immunization database and the death certificate, or Medicare if you want to get complicated. The last one, though, is really interesting. I like it. Of course, I wrote it, but it allows the people to come in the state offices and audit the data. Not just everybody, but people have to submit reports, and of those reports, 4 are drawn by lottery. And the people doing the work cannot have been in pharma industry, any pharma ecosystem company, or government. So it allows 4 entities, it could be 4 groups or 4 individuals or a mix, to come in and look at the data under NDA. The data exists for a reason. It's to be studied, and the studying of that data would provide invaluable information to the people with regard to public health. The reason the public health department exists is for the safety of the public, and yet they're not doing anything with it. Nobody is. So the last part is pretty key. It allows the people to have access to the data with reports, and no one's names, all privacy laws are adhered to. There's absolutely no problem. The only reason to be against this is if somebody's trying to hide something. And people on both sides should be for this. Right? Thank you.
Representative Barma, you had a question?
Yes, thank you, Mr. Chair, and thank you for taking my question. So, one clarification: I never got a bonus for prescribing remdesivir, so I missed out on something. But my concern is, and my question will follow, is I was a hospice medical director for about 30 years, so I filled out a lot of death certificates, and I rarely would have had the information on vaccinations, because a lot of the times a patient will have shown up at our hospital. I won't have the records for that, and obtaining them would be very difficult. And I still would probably not know, for example, if they got a COVID vaccination at a pharmacy, it wouldn't be there. So it would be very hard to collect this data. I wonder if you did any research on that and how that might be made easier, because it would be really, I mean, it would take me hours to find that.
I can explain that. Yeah. So in fact, in that analysis of the $160,000, what they're doing is they're talking about how long it would take to train doctors to have access to the New Hampshire Immunization Information System, which exists. And that's a registry of all the vaccinations people have gotten if they didn't want it. There is a box you can check for it to be redacted. And in the case where it's not there, it's not there. But in the case where it is there, it would require a doctor to look it up. And that would be like less than a 5-minute thing. You just go into the NHIIS, you log in, and you'd probably already be logged in if you're doing death certificates, if you're a medical examiner. But if it's a doctor, you're probably talking, if somebody dies in the presence of a doctor attending, that's when a doctor fills out the death certificate. And in that case, it depends. If they work in a care home, they're going to be doing a lot of them. If they're just, regular family practice and somebody dies, it's probably like once a year, right? So, it might take them 10 minutes instead of 5 minutes. It's really no big deal. It's pretty easy to do.
Yeah. Representative King and then Representative Polazov.
Thank you, Mr. Chair. Thank you for taking questions. I'm a little confused. What is it about Massachusetts that is different than New Hampshire? You've got some case individuals here and their cause of death. I guess they put that on their vital records. They put that on their death certificate. Does New Hampshire not do that? Does New Hampshire not put a cause of death? Or
New Hampshire has a state law that doesn't allow me to have those records. It's privacy. There are certain, so it's governed by state law. It's not a privacy and death HIPAA violation. That's federal law, and HIPAA doesn't apply to dead people. So each state has privacy, and many of the states have 50 years. Some have 70 years privacy and death, where they wouldn't allow me to have a full database of all the decedents. Massachusetts apparently does allow me to have it, and Minnesota as well, and Vermont we have also, but Vermont does not have the ICD-10 codes from the CDC, so it's a little different.
Follow up.
So
it's not on their death certificates, but the information is available, or it is on their death certificates in Massachusetts?
New Hampshire has the same death certificates as everybody else. There's Part 1 and Part 2. Part 1 has cause A, B, C, D. Part 2 has conditions contributing. The causes are in Part 1, and you should not have anything on there that's not causal in the causal chain of events that cause death. However, many of them do it wrong. A very large number of doctors, no offense, fill out the death certificates improperly. Medical examiners do a better job. It's supposed to be in a reverse time order where cause A is the immediate cause and the last one listed in A, B, C, or D. Sometimes there's only one filled out, A, sometimes it goes to D, but the last one is supposed to be the underlying cause of death or root cause, which is the thing that started the causal chain of events that caused the death. But a lot of them do it in reverse time order backwards. So I hope I answered your question.
Yes. May I have one more follow-up?
One more follow-up.
Okay. Would it not be beneficial for us to more or less copy what Massachusetts does and at least allowing that information to be accessible like you currently have with Massachusetts?
That would be good, but that's only the death certificate database. If I had the Massachusetts data and access to the Immunization Information Registry system, they call it. It's the MIIS. You have the NHIIS. In Indiana, they call it CHIRP. In California, it's CARES. It's different acronyms, but they're all the same thing. Anybody who does that, I will end the entire debate in a week. Ron DeSantis and Joe Latipo have a proposal for me from a year and a half ago and a year ago, and I told him the invitation is open. He's been told by 6 very well-known international people, just have him come in for a week or two. Just give me access. All you got to do is correlate the 2 databases, and debate ends. I'll find over 10,000 people in Florida pretty easily.
Thanks.
Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. I like the idea of transparency, and you put here 10 days of close of each fiscal quarter. So my understanding is some manufacturers, they don't oppose to transparency. They only ask for 70 years to be transparent about what's going on. And my understanding is that New Hampshire is not opposed to transparency. We have DHHS visit portal, but it shows mostly data going up to 2019. So my understanding is that all those deaths and all those spikes like in acute kidney failures and such wouldn't be accessible to public if we are looking only up to 2019. So my point is so it usually takes time. Sometimes it's for good reason to release data. So what's a good time? Like, let's say they say it's impossible to do it within 10 days. Like, would be like 6 months be a reasonable amount of time, or 5 years, or 70 years? Like, what's reasonable?
Yeah, no, I can comment. So there's provisional data that's not been verified, and that's usually like a year and a half, depending on the jurisdiction. So that the federal government, I can't remember, but it's about 6 months when they say these deaths, the data that they're providing is provisional, saying you can't rely on it. It's really legal indemnification. The data is pretty good. But what if your public health department is indeed a vigilance, a sentinel standing, on the wall looking out for the public health, they should be looking at it weekly. Pathogens come into our society all the time. I found things in 2018 nobody ever knew about. There are anomalies in various causes of death. Such a system that I've created could potentially, if you put all the data in there and I do all put all the parameters in, I could tell you, well, 39 years ago in these 2 zip codes, there was an increase in B-cell lymphocytic leukemia. Let's go look at their water supply from then. We have the water reports from then. Was there too much nickel or cadmium? This is the type of intelligence that's so easy to do. The system I've created doesn't exist anywhere in the world, and yet the data is available to the government. So, Representative Polisov, I can't answer like a definitive date, but if you have a Department of Public Health whose mission is the health and safety of the public, they should be looking at it weekly. I mean, the reports are rolling in. And okay, if it's provisional, that means somebody outside the government looking at it, it's legal indemnification where you're saying, you can't rely on it. We're not responsible if there's a mistake. All right, that's just semantics.
Representative Leon.
Thank you, Mr. Chairman, and thank you for all the research that you've done and for coming to share some of your findings. My first question is around the data that you're looking to get from the IIS. My question would be just so that we can have good, solid data and be able to show which events have no relationship to a vaccination event, and to be able to appropriately case match them between those with a vaccination event and those without. Would you be amenable to having it indicate whether a person has no IIS record because they have not enrolled in the IIS, or if they have a record with no vaccination events, because those two, it could confound the data if you have somebody who has not chosen to participate in the registry versus those with no vaccine events.
Yeah, absolutely. If they chose not to participate, the record's not there. It's not there. You can't blame. So if there needs to be wording, I can't remember what the exact wording is. I thought I accounted for that, because if there's no record, you can't blame a guy for not putting it on the death certificate. That's what you're saying, right? Yeah.
And if I can follow up. And then as my follow-up, I think that this idea of these audits are incredibly helpful, but I do know that academia or pharma may also be interested in this in order to improve outcomes. My question would be that if those 4 audit roles are not filled with private individuals or with the public, if opening up those to academia or to pharma companies or anybody who's associated who want to get those data and perhaps improve life would be beneficial.
Yeah, I don't think it needs to be statutorily included. I believe that the Department of Public Health could probably have them just sign a contractor agreement and invite them in to look at the data under NDA. I don't know that what this does is it compels that the work be done for the people. But if you want to add pharma, that would be up to your HHS department.
Thank you.
Thanks.
Other questions? Representative Nagel.
Thank you for taking my question, or Mr. Chairman, sorry, it's late. Thank you for taking my question. I have actually 2 questions. One has to do with the data that you're collecting that you want reported within such and such a time frame. I mean, one of the things we know in medicine is that association doesn't necessarily imply cause. And what I'm looking at is the data that you want on a regular basis implies a number of comorbidities, a vaccine type, things like that. I don't see type of cause of death listed in that data that's being asked for. Is that something that you would want?
whoever did the audit of the public health data, I didn't, I would hope that it was the immunization registry, all Medicare and Medicaid. What are they being treated for? So if somebody dies on the same day as vaccination, and about half of the ones that I found were actually fentanyl overdoses.
Yeah.
Okay. Not these, but so would you blame the vaccine for that? I mean, I would, because I think it affected their brains to cause them to commit suicide, but that's a stretch, right? So what you're saying, yeah, correlation doesn't equal causation. It's a catchphrase we all now know. It's been drilled out there in the public domain. But when you see that everybody's, and this is how I found this stuff, when Cassidy, a 7-year-old girl in Massachusetts, died, they said she died from COVID, and I was like, no way. And I went and got the 500,000 death certificates, and I found that it does say she died of that. But then I found a VAERS record for a 7-year-old girl, the only girl in that time frame, who was vaccinated 5 days before Cassidy died. And she reacted in 5 minutes, vomited for 8 to 10 hours. They gave her a second vaccine a couple weeks later. And that one is the date of January 13, 2022. She had immediately stomach pain. She had 103-degree fever, didn't have a bowel movement for 3 days. And Cassidy Baraka was dead on January 18. Sorry.
I'm not sure if I asked the question well. When I'm looking at the data that you want, there's nothing listed in there as cause of death. I mean, you have the age, when the vaccination,
Well, the death certificates have cause of death on them.
What's that?
Death certificates have cause of death on
I
them.
know, but this is the data that you're asking the state to report. So in section, new section 2, public immunization death reports, you're asking for aggregate data to be sent. I didn't see anywhere where the actual causes of death were going to be included in that data. It seems to me that would be important.
So the section 2 that there's multiple 2s on here.
Can you reference page number and line?
It's line number 25 on page 1, and it goes all the way
okay.
to line 13 on page 2, or
Okay.
10.
Oh, yeah. So, correct. I didn't have cause there. It's just how many people died within 1 day of vaccination, 3 days, 1 week, 3 weeks, 10 weeks, 25 weeks. And the numbers are what they are. Just report them to the public.
I'm just curious. I'm sorry.
Well,
I want to
it's
get
okay.
to my other
One more
question. Am I allowed
follow-up.
to
So,
ask my other question?
If you
One more
think,
follow-up.
All right,
Well,
yeah.
real
Why
quick.
does that help you?
How does it help you? Because you understand ceteris paribus and what it means, right?
Yeah.
So all of the other things being equal, if there's all of a sudden a spike and a jump,
Yeah.
then you have to investigate. The public would say, darn it, you HHS of New Hampshire, we want you to investigate. And if you investigate and find they're all pulmonary embolism deaths, well, you have a problem. You need to figure out the cause. But if it's fentanyl and some guy fell off a cliff and a school bus got in an accident and all of a sudden a bunch of kids died, you'll find out almost immediately and you'll report it to the public. But those anomalies that occur as a matter of consequence of accidents, people are going to know about. But all of a sudden, pulmonary embolism deaths, you're going to know. This reports it to the public. It won't create fear or panic. It'll just create the public to demand of the department, tell us what happened, please. That's all.
Can I ask a second question?
Second one, you've asked about 4.
No, they were follow-ups on the first. This is totally different.
Is it a quick one?
Yeah, I think so.
Okay.
In terms of the audit, how you select that, I'm a little concerned about who can apply to be an auditor. For
Yeah, that-
example, if I wanted to just put
Yeah.
in my name into the lottery with no ability to analyze data, am I allowed to be one of the people?
No, it says in there they has to have a level of competence. So each proposal that is submitted, so you submit a proposal, the proposal has to have certain metrics like you're going to do. Like I don't like statistical methods with regard to epidemiology, but most of you guys do. I'm an engineer. I like waveforms and calculus and other stuff.
Well, you're
but,
one of them.
But if somebody wants to submit a proposal, it has to have a level of competence. Not anybody can submit one, but you're going to choose the ones that get to be chosen, the 4 that get to be chosen from the lottery. It has to meet certain standards. Absolutely.
Hey, other questions? Representative Cushman.
Thank you, Mr. Chairman. Thank you for being here. Can you explain why the dates of reporting are contingent upon the dates of presidential and midterm elections?
Yeah, absolutely. Everything is political these days, and that is the greatest amount of avoidance you could possibly have from any political election. And if the information were to get out to one candidate, not the other, or some people would rely upon it better. that it would probably not be good. It wouldn't be fair. So this is the fairest way that it could be. They would have a year to know about it before any election. That's why.
Other questions? I'm saying no other questions. Thank you, gentlemen.
Thank you.
Thank you.
I really do thank you very much.
Okay, thank you. Also signed up to speak are Ryan Tanian and Chawi Chawa from the Department of Health and Human Services.
All right, good afternoon again. I'm Dr. Ryan Tanian, Bureau Chief of the Bureau of Infectious Disease Control. I'm joined by Chawei Chawla, who is our Bureau Chief for the Bureau of Public Health Statistics and Informatics. And we are here today to speak in opposition to House Bill 1661. As you know, House Bill 661, if enacted, would amend RSA 5C 64A to require death certificates issued in New Hampshire to include immunization records, but sourced solely from individuals who are participating in the New Hampshire Immunization Information System. The proposed legislation also has specific immunization data elements, reporting requirements, and as others have spoken already, some independent audit reports. So first, House Bill 1661 conflicts with RSA 141C20F Roman numeral 5, which outlines the allowable use for NHIAS information. Under current law, allowable uses include ensuring participants receive recommended immunizations in a timely manner, facilitating reminders or notices to participants when due for recommended immunizations, and assisting in identifying individuals who may require immunizations during disease outbreaks. So limitations on the use of participant information were established for the protection of privacy, and expanding this use as outlined in House Bill 1661, it would not be considered allowable. House Bill 1661 also conflicts with RSA 141C20F Roman numeral VI subsection F and Administrative Rule HEP 30704, which is related to authorized access to NHIAS. So authorized access is limited to administering current and former healthcare providers, the Division of Public Health Services, with limited access provided to schools, child care agencies, and local health departments. Under the current statute and rule, not all persons who may medically certify a death record, such as the medical examiner, are authorized unrestricted access to the NHIAS. So the department believes that broadly granting unrestricted access to NHIAS to any person who can certify a death certificate could be costly and present privacy and security concerns. If enacted, we would require additional safeguards to protect participant information from potential unauthorized access. Additionally, House Bill 1606 from the 2022 session amended NHIAS to be an opt-in and voluntary registry. So as a result, immunization records of persons who did not voluntarily choose to participate in the registry could not be included as part of their death certificate. So other immunization records that are not contained in the IIS may be omitted or would be unavailable, and those include medical records, records of persons who have opted out or withdrawn their information from the registry, or those who have received immunizations outside of New Hampshire. So because the legislation does not require other sources of immunization records to be included as part of a death certificate, this legislation is establishing a biased standard for NHIAS participants when compared to non-participants of the registry. So functionally, information in the IIS may be incomplete or potentially incompatible to align with death certificates processed by the Division of Vital Records Administration. Data in the NHIAS would be considered incomplete for the purpose of vital record standards, as it may be self-reported. It could and also be changed by the participant. So unlike for vital records, NHIAS does not require the use of a participant's legal name, permanent address, or contain other identifiers such as a driver's license or social security number. So the department is concerned that the information between the two two systems could not correspond to the exact death certificate, placing a burden and liability on the person certifying the death certificate. And then lastly, the department, we use a robust contract and procurement process to facilitate audits. Selecting an auditor through a random lottery would bypass well-established, competitively bid and thorough vetting process. So the department uses a minimum necessary approach when granting access to data sets containing personally identifiable information or information technology platforms, and we believe that House Bill 1661 would weaken measures currently in place to protect and maintain the integrity of these data and patient information. And this language does not set forth clear standards, certifications, or qualifications of the persons or organizations conducting such audits. So in summary, the department is opposed to House Bill 1661 due to the data limitations, potential incompatibilities of the data sets as it relates to death certificates, and we believe that there's also a undue burden placed on the persons who are medically certifying death certificates, and we would be happy to answer any questions.
Thank you. Representative Weber.
Thank you, Mr. Chair, and thank you very much for taking my question. I just had a question on your written testimony. Was that submitted through the system, or was it, because I haven't seen it, and maybe I just missed it because I wasn't here at the very beginning.
Thank you for the question. It was submitted electronically.
Could you very kindly in the future also submit it in print copy for those of us who keep our records in print? It would be really helpful, and I didn't catch any of those citations, and I'm the person who likes citations, so that would be helpful.
Absolutely, thank you.
And there have been issues with the submission system in the past.
Representative Mazur.
Thank you, Mr. Chair. Thank you for taking my questions. My question, I might have one more. Is DHHS as alarmed as many other people regarding the amount of sudden deaths, turbo cancers, etc., that have been happening ever since the COVID vaccine has been released? Is that on your radar? Are you alarmed at all by it? Is it anything you're going to be looking into or think you should be?
Thank you for the question. So DHHS, where we are specifically in the Division of Public Health Services, we when we look at death data, it is based on what is reported through the vital record system and the death certificates. We wouldn't necessarily look at anything beyond that unless there was a concern. And as far as deaths reported related to vaccines, that is reported through the VAERS Vaccine Adverse Event Reporting System, which can be done by medical professionals, but it can also be done by anyone, and it's also self-reported.
Yeah. Follow up? Yep. So the amount of sudden deaths and also the ages of the people as to where this is happening, that you're saying that this hasn't just spiked an alarm that, hey, maybe this is something we should look at because this person is 27 years old. This person's a teenager, myocarditis, all of that. Like, this is all just, I mean, anyone right now can look around and see what's happening. So the fact that is DHS, are you at all forming any kind of committee or anything to look into this and to what's happening? Is that on your radar?
Yeah, for the record, my name is Chawla, Chiahui, Chawla. I'm the Bureau Chief of Public Health Statistic Informatics. So the Division of Public Health Services, we do publish aggregate that data on our data system. Right now, the most current one, I believe, is 2022. We are waiting for the final confirmation from the most recent year data. From those data portal, as well as the statistic reported that we release based on the program needs, we do focus on certain indicators. Just before this this hearing, I have my staff to look into the most current death certificate data to see if there's any vaccine causing adverse effect this type of records using ICD-10 code. So WHO does have ICD-10 code for COVID-19 vaccine, which is U12.9. We look at that data, this coding, excuse me, the ICD codes against the vital record data. We found no record that related to those ICD-10 codes that we're looking to that related to the vaccine adverse effects. So we do look into different kind of topic for the reporting purpose. And I'm sorry, I just want to emphasize that this bill will amend the RSA 5C64A. This is under Division of Vital Records Administration, which is under Secretary of State. So New Hampshire is the only state that the Vital Records Statistic Reporting System or Vital Records Statistic Data System not under Health Department in the nation. So to amend this part, we will need to work with the Division of Vital Records Administration if the bill is enacted. And I believe that the Division of Vital Records Administration also submit written testimony as far as we were told.
Representative Leon and then Representative Weber, I think you had your hand up earlier. Okay, Representative Leon.
Sorry, can I ask one follow-up question to Representative Mazur and then ask my questions? The first question was about the ICD-10 codes for the COVID vaccination. Are those only for people who have been vaccinated in a doctor's office, or would that also capture those who are going to a drugstore or some other location that's not a doctor's office for that administration?
The ICD-10 codes that I just mentioned is based on the birth certificate, on the cause of death description, and also the ICD code that transferred from the birth certificate, this ICD code. So this will be certified by the either medical examiner or their certifiers to fill out this form. So this part of information, I'm not in the best position to answer how this is certified, how that certificate is certified. But the ICD-10 code is based on our search through all the ICD-10 mortality codes that are related or has vaccine as a keyword. We use that as our very roughly just have a fresh look and to search those codes in the vital record death certificate database. And we found no records related to vaccine adverse effort based on our current database that we have access to.
Okay. As another follow-up?
Follow-up.
My actual question that I was initially trying to ask. I know that we've seen the VAERS data, and there's been a lot of skepticism about the applicability of the VAERS data. I'd like to know how you view self-reported information, such as the VAERS database, as opposed to more population-based record keeping. How in Sweden we're able to look with, they have a lot of information on their population and their health, and there's a lot of population-based data. Would having this information, including a recognition for those patients who have no IIS record, and therefore it's not a zero entry, it's a null entry, give us something that is more meaningful than VAERS, even if we aren't able to reach the Swedish registry model to look at case-matched people and see if there is a signal of risk here in New Hampshire, or a signal of no risk, quite frankly?
Practically, this could be done. However, we are worried about the data limitation and data quality, particularly in our New Hampshire immunization information system. Excuse me. Like Dr. Tenyon addressed, that the NHIS is opt-in and self-report voluntary system. So some identifiers such as names and address, we don't validate that. So in order to link back to our, the vital record death certificate data, it probably won't have the one-on-one match. It will be very fuzzy match. In that sense, to identify how many, to make some connection between those two systems would be a little bit risky, and the result may not be really meaningful in a statistical standpoint. But we are happy to look into and maybe do some proof of concept. However, this will have a further discussion later on.
All right, could one more follow-up? Sorry.
Follow-up.
So I recognize that there are some that are not going to be able to match to the registry. If out of 100 deaths, 10, let's say only 25% of them have valid entries with which to compare with the IIS, in which you either have records of vaccination or no records of vaccination. Is there value to be able to case match those individuals to look and see if there is either a signal of risk to the people of New Hampshire, or to say that we have case matched and we are not seeing any indication of higher mortality after these vaccinations, and to start rebuilding that trust that's so desperately needed?
Again, based on the data system quality and limitation, we don't recommend to do so until we have really comprehensive IS system established and data points are all validated, then we can perform that. Right now, we can look into the vital records death certificate data set and using the cause of death description and also ICD code to identify how many people are certified with this were certified under this type of cause of death and produce that the result. And in fact, Division of Vital Records, they do have NHVRIN, NHVRIN, statistic reporting system, query system available for all the public, users to be able to query for the underlying cause of death. That part does not really connect it to any IAS system or vaccine data, but to understand the overall cause of death, that would be the entry point for us to use as well. I don't think I answered all your question, and sorry if I missed part of the question. However, maybe you can describe on the IAS limitation again.
Yeah, if I may, sharing an example of, some of the limitations as, we've spoken to earlier. For example, with the IIS system, there's no requirement to have, say, a legal name. So someone named William could be in there as Bill, or Susan is in there as Sue. So it places a tremendous burden on the certifier of the death certificate to have to go through all the, hundreds or thousands of records in IIS to ensure that the person they're associating an immunization record to matches someone's legal information that's contained in the death certificate.
Sorry, respectfully, I think you're overthinking that part, but I know that's your job, so thank you.
Representative Shapiro.
Thank you, Mr. Chair. So I might have this all wrong, but when the medical examiner is determining the cause of death and writing a report, do they take into consideration available medical records or interviews with families that might shed some light on whether there's a correlation with a recent vaccination?
I thank you for the question, but I don't believe we're in a position to speak for the Office of the Chief Medical Examiner and their processes.
Okay. Thank you.
Other questions? Representative Cushman.
Thank you, Mr. Chairman, and thank you for taking my question. So even if we can't cross-match every death certificate to every record in the IIS, we would still be able to, if there were a significant climb in a certain, say it was a cytokine storm, was a cause of death that all of a sudden had increased fourfold in this system, and then there might be people who aren't in the system or who you couldn't cross-reference with, but you'd still have the signal there with the data that you had, correct?
Theoretically, yes. However, practically, IAS has some specific use and access restricted by the law. So for myself, I don't have access to IAS. I have access to vital record because I'm the data steward, but I don't have access to IAS. So in order for us to do so, like what Dr. Tanyan addressed, we will need to look into the statute on who can access to both vital records and IAS in order to perform that kind of work. But back to the data analysis and statistical, one of the missions that the Division of Public Health Services has is really to provide meaningful data to the public. We try to be transparent as much as possible without violating any privacy and protecting the confidentiality. That is our mission and goal, to provide this kind of meaningful data. So, you know, if the data set is not really comparable or is not really has lots of limitation, we really don't want to perform that kind of analysis and deliver the report that may not be validated.
Follow up.
So it sounds like the department admits that there are faults with the VAER system and that it's not adequate to perhaps make determinations on these things. And so it sounds like we could have an amendment to bolster our ability to surveil these things in New Hampshire. Would the department be willing to help us write an amendment to grant those permissions?
Yeah, so thank you for the question. We would say that there's limitations with the VAER system. You know, just as there are limitations here, we would be open to looking at any proposed amendments.
Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. Sorry I came in late. I was testifying on another bill, but just does the medical examiner who is writing up the death certificate, I know that the IIS is an opt-in, but do they have access to look at the IIS?
Thank you for the question. So currently, the medical examiner does not have access to the IIS.
So at a minimum, I'm sorry, Mr. Chair, quick follow-up.
Follow up.
So at a minimum, we would need to grant them access in order to go anywhere.
As we interpret the bill, it looks like we would have to grant anyone who can medically certify a death certificate access to the IIS.
Thank you.
Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. For me, it looks like catch-22. So we have people who write death certificates. They wonder why this occurred, and then you use their code to look if something happened. For example, last year, Dr. Benjamin Chan testified for DHHS that COVID-19 vaccines indeed cause increased myocarditis in certain populations. But before that, like for a while, it was pushed on public, it pushed on medical examiners that vaccine-related myocarditis is medical misinformation. People were losing their licenses for even mentioning it. So, of course, they were not putting those codes, ICD-10 codes, because they didn't want to say that it cost for vaccine, or they didn't know better what stopped the heart of a young boy. So you wouldn't look in that death because it's not on the code, and the code wouldn't be there because they were said it's not happening. So my understanding is that we need something like this bill, like to try to came out from this catch-22 situation. Could you comment?
I'm sorry. Could you actually state what the question was?
So, besides this enacting this bill, how we fix this situation when you only look in vaccine-related deaths if it's already listed as vaccine-related deaths, and don't investigate. For example, if boys are dying from myocarditis in 2021, nobody would put it as vaccine-related death, so you would never look into it. So how do we fix this situation?
Thank you for the question, but I think it goes back to a comment I had spoken to earlier. The Office of the Chief Medical Examiner and those processes are separate from the department, and the department isn't necessarily in a place to validate or verify the information that persons who are certified or persons who are eligible to certify a death certificate place on there.
Other questions? Okay, I think we're all set. Thank you.
Thank you.
Thank you.
Also signed up to speak is Ben Bradley from the New Hampshire Hospital Association.
Good afternoon, Mr. Chairman and members of the committee. My name is Ben Bradley, Vice President, State Government Relations for the New Hampshire Hospital Association, representing all the state's community hospitals and all specialty hospitals in New Hampshire. The Hospital Association is opposed to HB 1661 and has several concerns with the bill, which would require additional steps for providers to comply with RSA 5-C:64, medical certification of the death record. This would include emergency room doctors, physician assistants, advanced practice registered nurses, and long-term care providers, among others, who may certify death certificates, so not just the medical examiner of the state. Current statute states, quote, "The medical certification on the death record shall be completed by the attending physician, APRN, or physician assistant, or certifying physician, APRN, or physician assistant, and made available to the funeral director, next of kin, or designated agent as soon as possible, but no later than 36 hours after the time of death." We're concerned the language in HB 1661 would create delays to medical certification of death records, given the requirements in this bill to include additional data elements from the New Hampshire Immunization Information System. This bill would also require access to and training on the use of the NHIIS, which is not currently afforded to all providers who may certify death certificates. Additionally, providers would be responsible and likely liable for positively identifying a New Hampshire IIS participant is the same individual they are certifying in a death record. This could be particularly challenging as the IIS does not include identifiers that would be needed to confirm the patient's identity. Thank you for the opportunity to provide feedback on this bill. We remain opposed and respectfully request the committee ITL the bill. I'm happy to answer your questions.
Thank you. Any questions? Seeing none. Okay, thank you.
Thank you.
Should probably get a pink card for the next one. Nobody grab the blue sheet while I do myself.
Okay, again, thank you, Mr. Bradley. Before I close this public hearing, I have no one else signed up to testify on HB 1661. I do want to just read those who signed in expressing support and opposition. Let's see, 1, 2, 6. 9 people signed up to indicate support for this bill. 2 signed up to oppose this bill. That is for those who were not going to be testifying today.
And I have the online.
Okay. Okay. And what's the online?
And online, there were 155 in support and 37 against and 1 neutral.
Okay. Having no one else signed up to speak today, I'm going to close the public hearing on HB 1661 FN and open the public hearing on HB 1669 FN, which we had continued to this afternoon. It was originally scheduled for 11:15 a.m. And I'll recognize the prime sponsor, who is the vice chairman of this committee, Representative Erica Leon from Derry.
Thank you, Mr. Chairman and members of the committee, and thank you, everybody, for moving this later in the day because in person, this one had a lot less interest than the other bills, and those of us involved were already here for the day. I do want to say that online, there's a little bit more interest in the bill than we're seeing here. There were 154 in support, 44 opposed, and 1 neutral. So as far as the New Hampshire Immunization Information System, it was first authorized a long time ago, but it never really got up and running until COVID and when it was necessary in order to record the vaccine administrations that happened during COVID at the National Guard site and others that happened outside of the normal course. This has been a program that's been discussed as a very big interoperative program so that between states it'll be possible to share information. We're a state that takes our privacy very, very seriously, and in 2018 we passed Amendment 2B to our Constitution about that right to privacy. It's one of those things that we need to make sure that all of our laws are squared up and trued with that privacy, and that is in the light that I brought this bill. This is simply designed to say that we cannot share our IIS data with any other organization or any other body unless they are equipped to honor our law for our withdrawal, to treat our privacy the same way that we treat our people's privacy. If they're not able to do so, then we shouldn't share that information. There's some of us that are more sensitive to vaccine information. There's other people who are more sensitive to abortion information. But we should be treating all of our medical information with equal care and equal diligence. I had included a section in the bill to say that upon specific notarized request by a patient or the patient's parent or guardian, if the patient's a minor, immunization records may be shared with a non-compliant entity. I believe that's why we have the massive fiscal note. Because this is a newer program, I didn't quite recognize that the IIS would not be pushing out one individual's information. This is looking at the COVID vaccine passport system that was happening. I know people that in order to attend conferences, they needed to be able to present their vaccine certification on their clear, kind of like the one that the biotech executive had been working on as well. So this was something where somebody would voluntarily share a vaccination event in order to be authorized into a system. I wanted to make it so that it was easy for people to share their IIS data, but I think it's a costly and unnecessary one because that they can ask their provider to share that immunization. So I would actually look for us to limit this to only that first sentence and to strike the second one that says upon specific notarized request, because I believe that what gives the $3 million price tag. Because if we wait to share our data with those who can honor our request to keep our people's privacy inviolate and to make sure that if we withdraw from our registry, any other state will also withdraw that information, I think it's quite important. I've been working with the department on some administrative rules that would include language that is similar to this, but I think that it's important not just to have it in administrative rules, but also to have it in the statutes, because we want to make sure that if at some point they decide to wash information back and forth between different states, that those who have chosen to leave the registry here in the state are not involuntarily brought back in when their information is shared with another state. And as this becomes a more fluid, more interoperative system, we cross state lines for all sorts of things, partly for some bills and other committees, but also to get health care, because we have people that go between Vermont and New Hampshire to Massachusetts and New Hampshire, especially for a lot of the specialized care, and to Maine. So if you're pulled into that system and then your information comes back and you've withdrawn here, I just want to make sure that we're protecting people's privacy. So I know that the department has had some concerns about the cost, and I would be hopeful to know from them whether removing that specific, that ability to share with a non-compliant entity would resolve the fiscal note. And with that, I'm happy to take any questions.
Representative King.
Thank you, Mr. Chair, and thank you, Madam Vice Chair. I know you weren't a co-sponsor of these other bills we had just been discussing, but on the one hand, it's like we're talking about the IAS records are, quote unquote, it's been referred to as the people's records, and we have a right to know, who was vaccinated for what, and to tie that into cause of death and stuff. But then here it's like, well, we need to make sure that stuff is secret. So Do you see any conflict between these two ideas where on the one hand, the IIS, information should be kind of kept under lock and key, and then another way where it's like, well, we need this information for public health benefits? What are your thoughts on this?
So I was somebody who would have been very, very happy to enroll in a control group registry when COVID was first hitting, because I figured it'd be good to be able to give my information, and if we were doing any public health efforts, to see how that compared to the natural course in others. I believe that the data in the previous bill, sorry, I'll back up for just a second. I've dealt with a lot of data. I've dealt with a lot of information. When I was a medical device analyst, sometimes we'd look to the population-based records in Sweden or in other areas. And sometimes, in order to get good data from a registry type scenario, you're going to have to look at a lot of records to find records that can actually be case matched and that you can look at to see if you can find good data. I don't expect that the prior bill will be able to look at every individual, because if in my mind it's properly drafted, you have an opportunity to say these are the records that are in IIS, or they have an IIS but there were no events during this time period, or no record found. Because no record found doesn't say that they're not vaccinated, and it doesn't say that they are. And therefore, to try to look at any correlation or possible causality, you would need to remove anybody who has chosen not to participate in the IIS system. The big argument for the IIS is for public health benefit. So should somebody choose to participate in it and choose to be able to have their information in there, there is an argument that it makes sense to then correlate that so that they may be able to work as an early warning signal to others. When I was a device analyst, I actually got to know a pathologist, Dr. Renu Vermani. She had noticed that as she was doing pathology on patients who had a drug-eluting stent, she was finding that the coating, the antithrombotic coating, had started flaking off. And by having that flake off, they were having late stent thrombosis events where it was throwing it to another section of the vasculature, and then it was causing other clotting issues, both in the heart, in the brain, and in the lungs. Had she not been paying attention to this and looking at that signal, this wouldn't have really become an issue. This would have been a discussion about, are we doing enough anticoagulation and should we extend anticoagulation longer? Because Dr. Vermani spoke about this and had limited data, but data that gave an indication, work was done, those coatings were changed, and actually some people changed their clinical course. So you don't need to have the information for everybody, but if you're able to find the information from those people who are willing to be a part of this data collection, there's a high value to it. But because it's not a prospective, double-blinded, randomized control study, there's always going to be limitations to the data. But if this is something our people are experiencing, does it make sense to, as skydivers do, learn from the blood of others instead of having to do it ourselves? Or does it make sense to say, just because there's some challenges, we don't want to find any signals and any messages that people are leaving for us? So I know that's nuanced, but I think that both of those are valuable.
Okay. Representative McLean and then Representative Palmer.
Just a question. I mean, I'm still putting in my mind as to what the IIS is used for. Is it used, to look back at specific cases for transference of specific data, or is it used just anonymously for population studies, or both? I'm just trying to understand the scope of how the data is used.
So we're the last state, thank you for the question, we're the last state to have an active IIS system. This is something that's been building over the years. And quite frankly, I don't think that all the use cases and everything that it is going to be used for is known at this point. Because when you have a data source, there are lots of different things that you can do. And depending on what limitations you have on the data, there's a lot that can be done at the departmental level, because it's something that's done through an executive branch agency, and they have a lot of authority to work within that data, which they have, which is appropriate because they should be able to find signals and look and see if after a certain product is released to the market, if there's a signal in death rates, that's worth looking into. So we need to give them some latitude and flexibility, but it's also important to make sure we have guardrails. And I think the fact that we don't understand how the IIS will be used now that 50 states are on board, especially how the IIS will be used once all 50 states are freely communicating with each other. I think that it's important to wait to put our information into that free exchange with other states until we know that the privacy of our people can be respected. And also at this point, the information is not being shared with other states. So this would not be retracting anything that's already happened. It's simply putting a condition on that expansion, that unless they can honor our privacy and our constitutional provision for privacy, we're not going to share that information.
Follow up.
Just a quick follow-up, because I know a lot of the discussion about the database, for example, for abortion, there was discussion, we're going to anonymize that data, things of that nature. And is that the ultimate intention with the IIS along that same lines, or is it, no, you can still go in and get Erica Leon, for example's data?
So thank you for that question. So some of the federal grants that we accepted during COVID were designed to look at different health equity, looking at the vaccination rates, looking at it being a health equity issue for under-vaccinated populations by the census block. There are over 600 census blocks in my town of Derry. So looking at that granular level and looking to see that this neighborhood is under-vaccinated could, in a different administration and in a different makeup of people in the government, it could lead to a very intensive, very invasive door-to-door offering of vaccination. And I recognize that this doesn't concern everybody, but the idea of going by and saying, I'd like to see your papers. Have you been immunized in this house? Is a very, very dangerous thing. That is something that it was enabled and was, I believe, was worked towards in some other states. However, the pushback against that very invasive level did happen. And so we did not violate people's rights to that extent. However, the words of that grant language that was accepted by the Executive Council would have allowed that, and it would have in fact encouraged that. Fortunately, saner heads prevailed.
I saw other hands up over here. Okay. Representative Cushman.
Thank you, Mr. Chairman, and thank you, Madam Vice Chair. Would you believe that administrative rules for the registry do allow for de-identified data from the registry to be released by the department for research purposes?
I wasn't aware of that, but I actually think that that's good. I love data, but I also like it with a good dose of privacy, and I think we need to balance the two.
Other questions? Seeing none. Okay, thank you.
Thank you.
Also signed up to speak are Ryan Tanian and Sherry Chowa from the Department of Health and Human Services.
Thank you again, Mr. Chairman. Ryan Tanian. I'm actually joined today by Anne Marie
Oh,
Mercuri.
I'm sorry.
Thank you.
Actually, the other name is on the card, though. I didn't read it wrong. Okay,
Thank you. Yeah, so I'm joined by Anne Marie Mercuri, who's the administrator for the New Hampshire Immunizations Program. So we are here today just to provide informational testimony for anyone on the committee that they may have in relation to this bill. As Representative Leon had mentioned, we've been working closely with her through the administrative rules process, which we had a hearing on back on October 3rd. We collected that feedback that was from that hearing, as well as the submitted feedback online. We've looked at the proposed rule again. We've gone back through with the bill sponsor, and we have made some, adjustments. And we're, just here to say that, at this time, we do not share our information from the IIS with other states or other entities. If we were to, there is a robust process that we would have to enter into a memorandum of understanding. And through that memorandum of understanding process, we have looked in our rule, as well as through this legislation, that we would require that privacy provision where individuals would be able to withdraw their information as well. Again, and if the bill sponsor chooses to do an amendment, then the department would be happy to take a look at that and update the fiscal note as well. So happy to answer any questions.
Any questions? Representative Polazov.
Thank you for taking, thank you, Mr. Chair, and thank you for taking my question. I'm still trying to figure out your status in terms of vaccines. Like I understood that you don't sell vaccines to individuals, but is it also correct that you're procuring vaccine on direction of CDC through Vaccine Association?
Sure, I'd love to answer that. Good afternoon. My name is Anne Marie McCurry.
Could we get the spelling of your last name? It's Anne Marie.
MERCURI, like
okay.
Mercury, but with an I.
Okay, great. Thank you. So,
Thank
sorry.
you very much.
Interrupt. Go ahead.
Mr. Chair. Thank you for the question. So there were a couple of questions that came out earlier about the NHIAS. So if you don't mind, could I explain a little bit about the NHIAS? Okay, so thank you. So the NHIAS is a new system. We launched it in April of 2021. The primary intention as we were building the NHIAS was to assist and support the state in maintaining the accountability of vaccines that are distributed through the New Hampshire Immunization Program. So those vaccines are funded through a combination of public funds through the federal government under the Vaccines for Children program. Also, another program that's federal is the 317 program. And that 317 program is for underinsured and uninsured adults. So for the adult section, we can only assist for the cost of vaccine for those underinsured and uninsured adults. But for the children, because we participate in the federal Vaccine for Children program, and New Hampshire statute allows us to collect funds through the New Hampshire Vaccine Association, that would be assessments from the insurance companies. We are able in New Hampshire to provide vaccine at no cost to all children, regardless of their insurance status. So the program works to maintain the accountability of these vaccines because, as you know, vaccines are very expensive, very costly. We want to do a good job of that. We're a good steward of the monies. The NHIAS also serves to consolidate immunization records for those individuals who are participating in the system. So for individuals who voluntarily choose not to give their information, that information is not transmitted to the state. So we don't have any listings of people who have opted out. We only really know the information from the people who have gone ahead and given that consent to share their information. Additionally, it's only the providers who receive the vaccine supplied through the state who are required to participate in the NHIAS. So that means that if there are providers who privately purchase the vaccine, they don't need to report that to us. It's only those who get the vaccine through us. So that's just a little bit of the background there. So I just wanted to make sure that we answered that question. And I am so sorry. Could you please rephrase your original question so I can make sure I address that?
Yeah. So you said that you do collect funds, and could you expand what where those funds go? Do they fund general fund or DHHS directly, or split in some way?
Okay, thank you very much, because I think that I did include that the funds for the vaccines do come through the federal Vaccines for Children program, and then the federal 317 program, as well as the New Hampshire Vaccine Association, to cover those non-VFC eligible children so that all children can be vaccinated.
Other questions?
So the department does not have general funds for the purchase of the vaccine.
Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So just as a point of clarification, if I go down then and I got my COVID shot or my flu shot or whatever at Rite Aid or CVS, that's not going into the IIS then. That actually would go into Rite Aid's database or CVS's database, and they would retain that separately from the IIS. Am I correct?
Under normal circumstances, the vaccine that is not distributed through us would not go into the NHIAS. COVID vaccine was very different because under Executive Order 76, all COVID vaccine from the federal government and the state supplied had to go into our immunization registry. So COVID vaccine was the only vaccine that was not distributed fully through us that also was reported to the NHIAS.
Follow up?
Yeah, so all other vaccines then. So COVID, it's all in there if you opted in, but everything else is not. And going forward, Rite Aid has their own database kind of thing.
During Emergency Order 76, the ability to opt out was temporarily suspended. So therefore, individuals were not offered the opportunity to opt out because of Emergency Order 76.
Other questions? Seeing none, thank you very much. I have no one else signed up to testify on HB 1669 FN. The blue sheet in the back indicated that 10 people did sign in favor and 2 against. Do we know what happened online?
And as of right now, we gained 1 person in support since the introduction of the bill, with 155 supporting and 44 opposing and 1 neutral.
Okay. Those are all the bills we had noticed for today. Again, I have no one else signed up to testify on HB 1669 FN. So I'm going to close the public hearing on that bill, and we will be adjourned. We're hereby adjourned.